price index is the normal price of, you have to pick a basket of services that you're tracking with the consumer price index, but it's substantially inflation plus 2. And the bill we look at is much higher increases. So we're missing a whole slew of drugs underneath what that bill requires if we don't capture drugs that are rising at the rate of inflation plus 2.
I guess through you, Madam Chair, the data that you've collected suggests that a lot of drugs, or at least the drugs that are in this list, are growing at prices or inflation rates well above CPI plus 2. I'm looking at Cialis, which had a unit cost that seemed to decrease, according to your data, by 50.67% between 16 and 19. Auvi-Q, which is an anaphylactic drug that would, or device, increased by 60%. Onfi, which is anticonvulsant, that increased by 70.99%. So those seem to, I don't know what those are for a year-on-year.
Yeah.
It seems like there may be drugs that are increasing much faster than CPI.
There are drugs increasing at much higher than the rate that's in the governor's bill. And just to be clear with the committee, the prices that are listed on our site, just for clarity, because I want to be fair to the manufacturers, we're listing unit cost there. We're not listing WAC, which is the wholesale acquisition cost. So there might be some slight differences there. And we will have a report up in the next month or so for last year's drug spending. And that report will also be the basis for some of the reporting for the benchmark work. So there is a tie between that bill and the benchmark.
And then I guess like my question on this, obviously, I think the elephant in the room is making sure that we have a steady supply of prescription drugs for the Connecticut marketplace. I don't know what the status of the Massachusetts legislation is. I know that there is a section of this bill that's attempting to prevent drug manufacturers from removing their products from the marketplace. But can you speak to that concern that a drug manufacturer in response to this legislation may choose to remove a drug from the Connecticut market?
Yeah, I can try. Vicky can correct my mistakes as well, as always, of course. That section is in there. That section will do some work to prevent market exit. It is borrowed from model proposals put forward by the National Academy for State Health Policy that are substantially more aggressive in terms of the restraints they would put on drug prices. One of those NASHP model bills, for instance, which has been introduced and heard in states around the country this year, would cap prescription drug prices at Canadian prices, which are probably something like 40% of their American prices. So I don't want the fact that that section is in there to lead the committee into thinking that we have real concerns about market exit as a result of these caps. The companies are selling drugs at this price for a profit in Connecticut today. They will be able to increase those prices and probably their profits in real terms by 2%, in nominal terms by something close to 4% were this bill to pass. And I would be very, very, very surprised if that final section of the bill ever had to be used to maintain supply here in Connecticut. The bill does guard against, if there's sort of an exogenous shock that truly limits supply, there's a national drug shortage list that the federal government maintains, and drugs on that list would be exempt from this limit on their annual price increases.
Thank you for that answer. I guess I also have questions about the covered Connecticut portion of the bill that are similar to my co-chairs. It does give an extraordinary amount of flexibility to the executive branch in terms of how to implement the spending under that. And so one question was about what we can do as part of a 1332, because my understanding is, forgive me, folks. So my understanding is that a 1332 needed prescriptive language from the legislature. Vicky, I don't know if in particular you had any knowledge about that one.
As we've crafted in past legislation, that Section 1332 usually would be authorized. So if we had a plan, I'd have to come back to you. The language that we've proposed in previous bills would have an authorization from the legislature. I'm not I'd anticipate if we came back with a plan with a 1332, we would probably seek to have that authority clearly granted.
And I'll say on that matter in general, we're obviously very happy to work with the committee to structure our flexibility and your oversight in a way that's comfortable to you and to your colleagues. One of the reasons behind the streamlined approach taken in our bill is that unlike the committee bill, we were trying to turn on these supports for plan year 2022, 9 months from now, anticipating that there will be a significant amount of pain still in the COVID-induced recession and recession economy, and then we would like to deliver aid to people in a timely fashion that might not allow us to come back before you all next session with a plan before it needs to sort of go live during open enrollment. But again, we should work together on language that everyone feels comfortable with.
I'm going to be answering some constituent concerns for the time being, but I will have some more questions in a little bit. I'll turn it back to you, Madam Chair.
Thank you, Senator Lesser. Senator Wong.
Thank you, Madam Chair. It's hard to follow up. The baby looks adorable, Senator Lesser. Thank you, Mr. Dack, and thank you, Vicky and Mr. Bukhari. Thank you very much, and my appreciations to the governor for taking the initiative on this very important matter. I think, Mr. Dack, you're absolutely right. I do believe that health insurance and healthcare is a human right, and I really appreciated you articulating that Republicans and Democrats in the country and within our state fully support the idea of containing costs and managing it. The difference is how we go about it, right? So let me go right to the Covered Connecticut account. So obviously, I have great confidence in Ms. Valtre's ability and her history of service, really on the grassroots level. She has done the work on the grassroots level. So I have great confidence in that. How is that funded? Where is that revenue coming from? Is it a tax or an assessment? And who is going to be assessed those values or taxed on those values?
Sure. So there are two possible sources for revenue for the Covered Connecticut program combined so that Vicky and the other stakeholders with which she consults can make a plan with some certainty. The statute guarantees that they will add up to $50 million. One source is a essentially reinstated state level version of a federal assessment on health insurance plans that was created in the ACA and sunset for the final time at the beginning of this year. That equated to somewhere between a 2 or 3% assessment on health insurance plans. The state version that we're proposing is structured a little differently from that federal assessment to avoid concerns that carriers had about retaliatory taxes from other states. We worked with them both in 2019 and again this year through CID and their tax departments to do everything we could to address that concern that this would lead to unexpected taxes from other states. I believe we have addressed that concern and left an escape hatch if we've missed something, but you're of course welcome to ask the carriers about that later today. So it would be an assessment on health insurance companies in the state, an assessment again at a level, as I said in my introduction, that is much less than they were paying under the federal tax and much less than other states that have reinstated the federal tax are asking of health insurance companies in that state. The second revenue stream is our hope, obviously, is that pharmaceutical companies, as we understand most in Connecticut already do, are complying with the new limit on year-over-year price increases on their products. But to the extent they exceed the inflation plus 2% limit, there will be a penalty assessed at 80% of the difference. So if their price this year was 100, inflation plus 2% would have taken it to 104, and they decide to charge 110, the penalty would be equal to 80% just of that difference between 104 and 110. And that money would go into the Covered Connecticut account and be used for the purposes described in the bill of defraying the high cost of healthcare to the people of Connecticut.
Well, thank you very, very much. Now, in regards to the second component of the pharmaceutical companies' input in this is in addition to, obviously, the first part of the component in regards to prescription drug cost management, correct?
Thank you for the clarifying question. So the two sources together will add up to $50 million a year. So should the pharmaceutical companies pay $10 million in penalties for unjustified price increases, the amount expected of the health insurance companies would go down from 50 $240 million to make up that shortfall. Again, our hope is really to change behavior in the pharmaceutical companies, not to collect revenues. Although I will note that because the insurance companies and their premiums cover those pharmaceutical costs that we're hoping to bring under control, they should see decreased costs on the pharmaceutical side of the house that more than outpace the contributions they would be expected to make to the fund.
Thank you. And just for me, clarification, my question was the revenue side asks for the pharmaceutical companies if their prices exceed a certain percentage that you cited. But my question is, would they also have a separate obligation on their business in regards to the underlying proposal on prescription drug reductions? Is it two separate, or are they combined into one?
Ask it one more time. I'm sorry.
No. What I mean is the first part in regards, as you eloquently said, about drug cost of maintaining it and reducing it, and asking the pharmaceutical companies to be a partner in this in lowering prescription drug cost. That is one big component of this bill. Is that in addition to the expectation that they would be contributing to the revenue side? Two separate expectations of their involvement in the contributions to this proposal.
No, thank you. Thank you for clarifying. No, I would say the expectation of the pharmaceutical companies is that they would limit their year-over-year price increases to operate within the, I think, still generous limits imposed by this bill. I would note that the Grassley-Wyden bipartisan bill in Washington, D.C., over its iterations, has proposed a simple inflation cap on year-over-year price increases. So the 2% on top of inflation included in the Governor Lamont and Governor Baker proposals is more generous to the companies in that respect than some of the proposals we've seen, at least in the Medicare context in Washington. And if companies kept within those limits, they would have no other contributions to make to the Covered Connecticut Fund.
And obviously, you're well versed in that area, and the devil's in the details, obviously. And that being said, there are unintended consequences of a domino effect. So I'll give you case in point. The potential $50 million assessment or a tax, however you want to do it, on insurance premiums that would have sunsetted, but we're going to reinstitute a portion of a kind of a derivative of it. What if this gets put into place? Do you not think that the insurance companies would offset that cost burden onto commercial products?
I think the real anxiety. Yeah, thanks for the question. I think the anxiety is that they might pass that cost increase onto their consumers. There's nothing in the bill that would require them to do so, but it's a possibility that we should acknowledge forthrightly that this would mean costs on companies that are being passed on to costs on consumers. We think those costs are small. We think they're small in comparison to those asked for by other states and by the federal government, and we think that they will raise at minimal impact on either companies or consumers a substantial enough sum of money that would allow OHS, in consultation with other stakeholders and with the members of this committee, to drive dollars towards where they could make a very significant difference over and above the difference we're hoping to see out of the plan that's passed in Washington this week.
And I appreciate that, and I'm extremely concerned about any additional burden that we have to our businesses in the state of Connecticut as they struggle to overcome the economic free fall of the COVID pandemic. To pivot also to the drugs, I think you raised the concern that there are certain drugs that are protected on a federal shortage, but let's just use hypothetically. And I do want to give a shout out to our biotech and pharmaceutical companies, because it is Pfizer, which was through their incredible medical ingenuity and innovation and success that we're able to get one of the 3 vaccines that have been approved on COVID to kind of address the issue of the COVID pandemic. So look, our pharmaceutical companies do tremendous good, and the incredible level of R&D that's necessary to create the science and the ultimate successes is incredible. I want to make note and be on the record to comment on that. But when you talk about us setting up a prescription drug system in Connecticut, now, when we looked originally as this began, of looking at Canadian structure of cost caps and all that, we had a immediate rebuke from the Canadian government that said, don't encroach on our supply and take away and impact what we do. What do you say to the challenges that if the state of Connecticut does it, or even state of Massachusetts does it in a combination? What do you say if another state says, you know what, we'll pay fair market rate, give us a drug that's not on a health shortage list that we want because it's the next great thing, but it may be kind of a optional or selective choice? Are we looking to control the free market between states of prescription drug costs versus supply and demand?
Yeah, thanks for the question. I remember the same calls from the Canadian government last year. I suspect that coupled with some of the difficulties around physical reimportation of drugs is why other states around the country, like Washington, as I referenced, have moved this year from proposals that would import Canadian physical drugs to proposals that would import Canadian prices. That's obviously not this proposal, so I won't talk about it at particular length, but we did work with the Office of the Comptroller to look at the impact that would have in Connecticut. In other words, the difference that the state, which ensures a number of lives, is paying between Canadian prices and US prices. And we found, just by looking at the top 50 drugs that the Comptroller's office purchases, that if you took those down to their Canadian price, the state would save $32 million a year. It would pull $32 million out of our just state drug spend, more than 10%. Sort of a shocking illustration of what Vicki alluded to earlier, which is the extent to which the United States and US consumers and employers are overpaying for drugs relative even to other developed countries in the world, and perhaps subsidizing those research and development costs or direct consumer advertising and marketing and detailing by the drug companies here in Connecticut. I'm really not anxious that if we told a company that was selling a drug for $100 on December 31st, that on January 1st they could raise it to 104, but not 110, that they would say, okay, we're going to take our business elsewhere. Among other things, they're selling it at that price or something far below that price and at a profit in every other country in the world.
My concern is if X state says, I'll pay you 150 and I want to get that drug for my constituents in the state, and my free market or my existing market is not constrained by government regulations, that they may choose to go there before they come to the state of Connecticut. But neither here, it's not been proven, it's not been validated. And I think the biggest challenge we have with trying to look at finding solutions for healthcare, and believe me, it's an issue that's longer than you and I have been in public service, and it will continue to be. If we had the magic solution, everybody in this world would look to do that. It's a complex ecosystem, but I really appreciate your approach and your diligence, and having someone like Ms. Veltri, who has the experience and have done the work to be able to articulate some of those ideas. So Ms. Veltri, just one question in regards to the previous question about the amount of control and the amount of impact that you would have in managing the Covered Connecticut account with the monetary funds that you're allocated. One of the things that was very important that you noted was the fact that accountability and transparency is critical, and that you, in managing this account, would report to the Department of Insurance. Is that regulated under statute, or is that just something that you would be looking to do because the nature of your public service experience?
I'm sorry, I'm looking around because you keep changing spots on my Zoom screen. So I apologize if my eyes are moving, but actually I report to the governor. And so the insurance department is a fellow agency, right? Like DSS. So obviously, all of us need to be on the same page, which itself drives some accountability, right? Because whatever plan we come up with affects insurance plans. It may affect Medicaid, right? May affect the exchange. So that level of joint analysis and accountability, I think, is really strong. Plus, we obviously report to a governor, and any plan would come back to the committee. So I feel like there's a strong level of accountability there, plus the ability to engage other people in the work, right? We have that ability, and we will use it, as we have done with the benchmark. So we've been very transparent in that process by engaging parties from across different healthcare sectors, especially when it affects them. And I think we have to do that here too. So I feel confident that we'll have a good accountability mechanism for them.
Thank you, and I appreciate that. But the point would be that there is no statutory requirement for reporting and transparency. Yes, you'll report to the governor, but the governor is not required to disclose the transactional and cost and the real transparency that's necessary that we require on statute. I think that was one of the biggest questions we have with any plan, because it currently in the state of Connecticut, any insurance product that is sold and used are required to report and to follow the regulation of the Department of Insurance.
Oh.
The possibility is there is no statutory requirement that this account utilizing premiums or assessments or taxes and impact on prescription drug cost from the public would have the transparency and accountability requirement of statute. You're
Well,
well
we could
intentioned,
work
and it goes to
with the
governor.
committee. We could work with the committee on that. I think, as Johnny had said earlier, we're happy to work with the committee to make the committee comfortable. I think with accountability on the account, I think that we can do that. And so obviously I have no problem working with the committee on that.
So,
to ensure that's
and I
in there.
appreciate your quick response, which consistent with your incredible workability with legislators and the public. So I look forward to working with you on that for greater transparency and accountability. And I thank you both for your time. And Mr. Bakari, I don't have any revenue questions yet. And I wish everybody a wonderful day and stay safe. And thank you very much for your time and my appreciation to Governor for his initiative and leadership on this.
Thank you.
Thank you. Representative Meskers?
Thank you very much. So I'd like to go, my first question is to Mr. Dash. So in the current market, are you able to import drugs from Canada?
No,
Are you able to import drugs from Switzerland?
no,
Are you able to import drugs from the United Kingdom?
no,
So are we living in a free market for pharmaceuticals?
we're not. It's very tightly regulated.
Okay. And the regulations are resulting in prices that are at least 50% in excess for most of the OECD countries, as I understand it.
That's right, sir.
So when we stand in front of our pharmaceutical industry, which I support and have done tremendous work, we have to recognize that their pricing model is a profitability model based on US consumers versus their consumers around the rest of the world. And it's an advertising model and a profitability model where we fund all the research, but we bear all the costs. And you could argue that if they're selling at cost in Canada, we're funding the selling of that cost, or that they're making a profit in Canada and the prices there are not so bad. I'm interested that the first thing you mentioned in the industry was that they're now looking at not importing the physical drugs from Canada, but looking at potentially using some model based on the drugs for Canadian drug prices as part of a fractional amount for modeling how pharmaceuticals should be priced in the United States. Is that a fair assessment?
That's right. There are bills like that pending in other states, and I'd be happy to follow up with you directly or with the committee to provide that information. Again, not the proposal before us today, but something that your colleagues in other states are taking a hard look at.
Okay, I think that's important that we as a committee understand that. I believe the United States produces about 28% of its drugs and imports about 72%. And they're imported and manufactured all over the world and sold at price points based on barriers to entry. So when we talk about a free market in pharmaceuticals, I can buy a car made in Brazil or Korea, but I can't buy an aspirin manufactured or sold in Toronto. There seems to be a problem there. So I appreciate that because, and it's a roundabout conversation in that we sit on the insurance committee. Now the insurance committee and the insurance industry is the one we love to hate. But the insurance industry represents 8 to 10 to 12 cents on the dollar of our cost structure in the medical industry for our health insurance, where 80 to 90% of that is either pharmaceuticals or the hospital industry. So until we get a grasp on that, we're going to be looked at ever spiraling costs of 7 to 10% a year. The compounding rate is leading us to high deductibles, high insurance rates. So we're faced now looking in this coming week on a public option and on the governor's bill. So I want to applaud you on the governor's bill in that you look to be taking the first stab at a cap, if you will, or cost containment on pharmaceutical prices, which will ease the burden on the insurance industry and ultimately to the individual who goes to purchase his insurance policy. So I really appreciate that this seems to be dealing there with insurance, with the cost of pharmaceuticals. Is there anything explicit within the constraints of 644 that you're doing in relation to hospital costs?
There's not.
Okay.
Although I agree with you that they, along with pharmaceuticals, are one of the significant drivers of ever increasing, unsustainably increasing costs of care in the market.
Right. So, but basically, so you've taken one of the three legs, well, two legs of the horse. You basically are giving the insurance companies coverage in that you're trying to curtail the cost that they are passing on to us of pharmaceuticals. So the next leg in that equation should be something done on the hospital side to do something on the cost of the hospital for hospitalization healthcare costs, which I believe also run about. Well, I believe the overall healthcare bill is about twice what it is in Canada, with fairly similar outcomes, if I'm not mistaken.
That's right. And I am sure there are bills pending before the legislature that would address that. They are not coming from us. Vicky Veltri, is working pursuant to Executive Order 5 to better understand cost growth in healthcare in the state of Connecticut, make it more transparent, make the people who are increasing their rates more accountable. And there are bills pending before this committee on Thursday that would codify some of that work. I think we've been very pleased with the progress we've seen over the last 14 months since Vicky began it, at least in helping us understand the problem and in hoping that sunlight will be a good disinfectant for those cost increases, as indeed it has been in Massachusetts, which is about a decade ahead of us on this kind of cost containment benchmarking and has seen significant decreases in year-over-year price increases, in part, we believe, as a result.
So I guess, Vicky, where I'm not confused, I'm trying to figure out the roughly $50 million assessment, which is coming hopefully at some point from pharmaceuticals and some from the insurance industry. It's a blend. That ultimately is a assessment or tax, but that's replacing a $300 million assessment from the federal government, roughly, is what you were saying, right? So basically, their cost structure is down 250. And I'm assuming in the short term, given the delays in medical expenditures and their billing procedures, their MLRs will be down around 85 to 80. And so as they smooth that out, there should be excess reserves and abilities to defray that cost. Is that a fair assessment?
That's our belief as well.
Okay. I'm interested. I thank Senator Wong on the issue in relation to disclosure. I think the accountability for any, whether it's from the executive or any office of the government, into how those assessments are effectively deployed is crucial. Ultimately, I think improving the coverage, reducing deductibles, I think the goals are all laudatory. So I'm anxious to see those happen. So I appreciate that. And, you know, I do worship at the research side of the pharmaceutical industry, but I do appreciate the fact that I think drugs that have been designed and invented 30 years ago, I think putting a price cap on the cost to limit the growth there, I think is more than a reasonable response. I think that's it for me. Thank you.
Thank you.
Representative Nuccio.
Thank you, Madam Chair. Good afternoon,
Good afternoon.
Mrs. Veltri and Mr. Dyke. So I've never met you before, so this is my first time. Hi, how are you? How you doing?
Good. How are you?
Good. Thank you for coming and explaining this. I want to start out too to say that I too, as Representative Meskers just stated, would like to commend the governor on this bill. It's very in contrast to the public option bill. This bill actually begins to address the cost of healthcare, and it doesn't mask that cost with a program that I'm not sure would actually be able to accomplish what it says it does. But I'm very interested in the portion of this bill regarding the pharmaceutical costs, and I definitely welcome those conversations. I think that so far what I'm seeing here, depending on how the language ends up, could be beneficial to at least change the behavior, which I think is a first step in trying to control the astronomical costs of healthcare. But my concern is really in relation to the covered CT portion. If you could humor me a little bit here, Mr. Dyke, you mentioned that the retirement of the high fee or the HIT tax, depending on who you talk to, you mentioned it as being a save for insurance companies, and I wanted to weigh in on that. All of the ACA fees, all of them, including the high fee, are pass-through assessments. So if you look at standard contracts in insurance, all fees and taxes are part of the cost to the employer. It's a standard practice, really, pretty much with any industry. I don't know any industry that doesn't pass on a tax or an assessment to cost of goods. So the insurance companies aren't or haven't saved anything with the removal of the high fee. What you saw here in the state of Connecticut is that rates were actually decreased because that was not passed through to anybody any longer. And if you add that back in at any rate, you are going to see a direct increase in the cost of healthcare. And that's based off of standard contracting and anything else that comes along with a tax or an assessment for an industry. Now, I wholeheartedly give you that the estimate of what the high fee was before to this 50 million is significantly lower, but it will be a direct pressure on the cost of healthcare. So I guess my first question is a 1332 waiver. I'm assuming you're going to utilize the Connecticut HRA Act since that was never truly repealed, or would we be utilizing new language for this 1332 waiver? Would it be the language in this bill here? Because there wasn't a lot of language in this bill directly regarding the implementation and parameters of the 1332 waiver.
So my hunch is, I'm sorry, Vicki, go ahead.
Well, I was just going to say that there isn't there isn't a lot of language about a potential 1332, but I think because we haven't decided, because the language of the plan gives potential options for the 50 million, only one of which might be a section 1332. And a 1332 would probably, if it were pursued, would be with a potential reinsurance program. And if that should happen, then we would, look to existing mechanisms or figure out the best path forward pursuing the 1332.
So probably the HRA, because that language is still alive and well. It hasn't been implemented in a while, but the language was never repealed from the legislation. So besides the 1332, what would be the other forms of funding that 50 million? So we've got the drug piece of it, the 80% on anything over the CPI plus 2%, possibility of a 1332, which would then lead into an HRA, like a reinsurance thing. So what are the other aspects that may fund that 50 million?
So the 50 million itself in terms of state dollars will come exclusively from either the reinstated shrunken HIT or the pharmaceutical assessment. One of our goals as we put together the plan will be to leverage the most federal dollars possible with that 50 million. And so you could do that through reinsurance, You could do that through very targeted expansions in Medicaid eligibility that would bring in the FMAP from the federal government for those expansions. And you can do it by getting more people to sign up for the exchange, which even under the expanded premium subsidies that will be available temporarily from the federal government, people may decide not to do because they can't afford the costs of care even once they have that insurance, right? If you're someone with, 250% of the FPL, you're probably making $45,000 a year as a family in Connecticut, and you're looking at $5,000, $6,000, $7,000 deductible. That's a deductible that might lead you to think, you know what, even paying this subsidized premium is not worth it to me. If we can come in with further premium support, or if the committee is kind enough to amend the bill in JFS language with cost sharing reductions, and we can encourage some members of the Connecticut population who are currently uninsured to sign up for an exchange plan, we will bring in significant amounts of federal dollars. For every person, the sticker price on an annual basis on an exchange plan is about $7,500. If the federal APTC, reduces that to $1,000 for someone, and they still think that's too much, if we can take it from $1,000 to $500, we're putting up $500 of state money, and we're bringing in, $6,500 worth of federal match in APTC dollars that would otherwise have gone unclaimed by anyone in Connecticut. So that was a roundabout way of saying $50 million from the two sources identified in the bill, but with the full intent of not only helping as many people as we can, but bringing in as much federal money from a variety of sources to provide that help.
Okay, so that actually leads me to a couple of my other questions, not to dance around too much, to try to stay on the waiver here. Are there any other options for the state that would not include increasing the tax, which are direct pressures on the cost of insurance? So any besides that, besides the assessment?
I don't think there are other mechanisms for the state to provide targeted support for the exchange population. Our general fund, as people know, is sustainably strapped. But there are certainly other proposals to try to meaningfully bring the cost of care under control, right? You see one example of that in the pharmaceutical portions of this bill. I don't want to pretend that's a silver bullet. There's a group of researchers at Yale who recently launched something. What's it called, Vicki? The 1% Project?
1% project, yes, the 1%.
The idea being that, if we're waiting for the silver bullet on healthcare, we're going to be waiting a long time. We instead need to start taking bites out of the underlying problem. This bill proposes one. There are others that I'm sure have occurred to the committee and are pending before it. And we'd welcome a conversation, of course, about those as well.
Right, and I think it's an important point that Johnny's making to keep making to all legislators and the public, which is, we are asking for an assessment here to get more people covered, to get people access to care, which hopefully actually itself drives some prices down, because without being covered, there's pent up demand. There's all sorts of things that can happen to people when they don't have coverage. But these are hard discussions about the underlying drivers of healthcare costs. And there's constantly a balancing project that has to go on between, you do want innovation. On the other hand, they're a driver. We want our hospitals to do well, but they are a driver. We do have to acknowledge that these are hard discussions. I think that we're going to have to continue to have if we want coverage to be affordable. That everybody plays a part.
Yeah, I wholeheartedly agree on that. I asked this specifically because I know there are states that have been granted 1332 waivers that have not implemented assessments, that have looked for other ways to fund it, and then pulled down a substantial amount of matching grants. I know Alaska is definitely one of them, and there are a couple others also that have done the same thing. So I was wondering if Connecticut was looking at trying to employ some of the procedures that other states have done that have not put a direct pressure back on the cost of insurance. So I don't know if that's a conversation that we can have, or more research that can be done to see if there are other options, but I just wanted to mention that it's out there. And staying with the Covered Connecticut, so if I understand this correctly, the Covered Connecticut dollars are going to be for granting subsidies for insurance, correct?
That's one option. Yeah, that's one potential option. The bill as worded gives some flexibility, but that's one substantial option. is to target insurance, premiums or cost sharing. That's what we're-
So we're looking at premiums or cost sharing.
Yeah,
Okay.
I mean, the bill is drafted. I think I may have said earlier, I hope I did. We do need a correction to this bill to move forward, that we would like cost sharing to be included as one of the options to target subsidies towards, because as Johnny said, you can afford a premium, but if your deductibles are running in the $7,000 range, you may not go get care. And that is what we're seeing more and more of, is people complaining about cost
Yep.
sharing.
Absolutely. So I guess that gets me then to probably one or two of my last questions. So with the new federal rescue package, there are significant dollars in here. It's the largest investment in ACA in over a decade. Significant dollars investing in the ACA, which include large subsidies, increasing the availability to people who were previously cut off in regard to the benefit cliff, increasing the percentage of the FPL to 400 plus, lowering the age that you're able to get subsidies. And the biggest one that I think is really big is maxing out the cost of insurance to a max of 8.5% of income. So there's also been a lot of signaling at the federal level that there's interest in even more funding for the ACA coming in expansion. So if we're going to be receiving this couple of aspects, I guess, if we're going to be receiving this slew of money that we're getting right now from the federal government for COVID and all of the other subsidies, $50 million compared to the billions of dollars that we're getting seems to be kind of a drop in the bucket. Is there any way that we could, if we're going to be receiving this money, look for ways to kind of use that or any other option as a match? Because enacting the covered Connecticut, funding along with all of these other things that are coming in right now through the ACA, and then throwing an assessment on top of that, you're going to see increase in the cost of care to anybody who's not on that exchange. Plus, we're going to be getting money from the federal government to make subsidies more available, increasing the FPL. It almost seems like we should kind of pause on this piece to see what happens with at the federal level before we intentionally increase the cost of healthcare here in the state of Connecticut. And I just wanted to point out, if we do get a 1332 waiver and we employ the HRA language that we have, that current HRA language is a premium-based assessment, and that means it's only against fully insured insurers. So the fully insured market in the state of Connecticut is about 30% of the entire insured market. And it's also the more costly method of insurance from a fully insured perspective. So we would be adding to a significantly smaller populace than the full insured populace using a reinsurance method. So I think we need to be very careful about where we're looking to get this money to fund the covered Connecticut. And I'm just wondering how much of this is actually going to be holy moly, I can't speak. Double, it's going to be duplicative to what we're getting at the federal level with what's going to be coming down from the rescue package. So have you guys really looked into the rescue package and what that is going to do for us here at a state level from a coverage perspective?
So we've looked into it. We only got, the final text hasn't even passed the House yet. It hopefully will tomorrow.
Today or tomorrow, yeah.
President's desk. I know our colleagues at the Department of Labor, who have to implement provisions that would otherwise expire over the weekend, are extremely eager to see the president's signature on that piece of legislation. We've looked into it. I thought your summary of it earlier was quite well said. And we knew it was coming, and that's why we wrote this bill, to provide OHS and the other stakeholders enough flexibility to accommodate the eventual federal reality as a result of that bill, and to accommodate the federal reality once the provisions of that bill sunset, as they're supposed to do, as currently written. As Vicky said, I do think we would need JFS language to allow the plan that OHS puts together for the committee and others' considerations to include the possibility of spending on augmenting the CSR as well as the APTC, because the federal proposals, as I've read them, do not address that cost sharing piece. Which really starts to phase out very quickly at the 200% FPL level and is entirely gone by 250, when we know that a lot of people still can't afford their deductibles. quickly, I guess on your last point, I do think it's important that we try as we collect money to collect it not just from the fully insured segments of the market, but instead, true to the Obama administration, true to the Lamont administration sort of general broad-based low rate philosophy. We've written this assessment. We wrote the assessment that the House passed in 2019 to apply to some TPAs as well, with an effort of minimizing the impact on everyone that it affects, and with an idea of minimizing the impact on sections of the market that are most vulnerable. And so it tracks the committee bill's language in most respects. Our language exempts the small group market from the assessment because we have particular concerns about the health of that market and that small employer community.
So the language that you have is going to exempt the small group market, go against the large group, and it's going to go against both fully insured and self-administered and stop loss through a TPA.
That's right.
Okay, so you're going to be looking more at a per member per month and not a percent of premium.
That's right. And the per member per month.
Or per member per year, actually, is what Connecticut does.
So per member per year.
Y'all like to give us the per member per year, and we got to break it down to the per member per month.
The way the formula works, I won't bore everyone. It's in the bill, but $50 million target. We know what we got that year from any penalties paid by the pharmaceutical companies that don't comply with the limit. We deduct that from the 50, and we essentially divide the rest evenly among all of the lives that the companies report to CID that they are covering. And then on a per capita rather than a per premium dollar basis, we assess them their share of that 50 million. That per life basis is advantageous on the interstate retaliatory tax issue that I referenced earlier, and in a couple other respects.
So just from a historical perspective, I know that 4.5 million from Malloy's budget is now 11.7 million. So you mentioned the 50 million. What's the stability of that $50 million, especially if we actually incent correct behavior in the pharmaceuticals and they start to lower that price? You're going to be shifting even more of that cost over to the insured from the pharmaceuticals, but more importantly, what do you see the growth of that market being? Because 50 million in subsidies right now, if we follow prior Connecticut assessments, it has the potential to be $130 million in 4 years.
Yeah, if the committee wants to, it's a fair question. $50 million is enough for us to do a substantial amount of work. I have not run the numbers under the new federal act, but right now the total premiums paid by everyone under 200% of the FPL on the exchange is about $20 or $21 million. So for $20 million, you could zero out premium payments by everyone currently on the exchange and hopefully entice many more people at that income level who were dismayed by the premiums or dismayed by the CSR onto the exchange. So I think we would be able to do significant things for the people of Connecticut within that $50 million limit. We would not have to increase it if the committee wanted to signal an appropriate rate of increase, should there be one in the legislation. One option would be to tie that 50 million to something like healthcare cost growth or overall inflation so that it keeps up without sort of mission creep. But again, certainly a conversation we're happy to have.
You just said that to the very wrong person. I would love to see if you are going to standardize language in there to limit the amount of growth. So it's actually a more reasonable number. That's something that I'd be very interested to see, that kind of language. So then the last question that I had, I guess that maybe we didn't really get into, is in regard to the drug portion of this, which again, I understand the need for and I'm supportive of. I think that this is definitely an area, like 26+% of healthcare cost is pharmaceutical drugs. How have you talked to the industry, and how long do you think it would take them, or would they be amenable to living under the regulations that we put in place here? Is this something that you see them doing, or them adjusting prices rather quickly? An 80% tax on that increased amount is a substantial amount of money. So I'm just kind of trying to get an idea of where the legislation's thinking is on how quickly they think this would actually help reform the cost of healthcare.
Yeah, the 80% is significant. It's, as you said, but I just want to highlight for everyone, it's 80% only on the amount
Yep.
above the limit, right? So it wouldn't claw back their sort of fairly earned charges or profits. The industry has concerns. I think those concerns are reflected in written testimony pending before the committee. I'm sure you'll hear about it from their representatives today. I am curious. I have meetings with at least one of those companies tomorrow, others later this week. The governor himself will be available to their CEOs for conversation. I do not have a good sense, and this is one of the things we'll be raising in those conversations. Are there Connecticut companies that are currently staying afloat only because they're increasing profits by 10% a year, or increasing charges by 10% a year? I don't think so. And we, as I referenced, we saw in the Alexion testimony that they say for their 5 or 6 drugs currently on the market, they're living within these caps, or at least that's how I read their testimony. I shouldn't speak for them.
Okay, thank you very much. Thank you for humoring me and putting up with my long-winded questions. I appreciate both of your answers.
Senator Lesser, did you have another question?
Yes, I satisfied some of my constituent concerns, so I've got the ability, if with the chair's indulgence, ask questions for a second time. So first off, I really appreciated the back and forth, and particularly Representative Nuccio's questions about how this proposal would fit in with the American Rescue Plan set to be voted on today. And as I see it, they're complementary proposals in terms of the subsidy portion, or any additional assistance that we could provide folks. So I thought that was a helpful point. I do know that this proposal is being compared with some of the other healthcare proposals before the committee, and so I think there's some question about what's in this versus other things. Obviously, if the prescription drug proposal in this is successful, that would potentially drive down prescription drug costs for the marketplaces overall. But is there anything specifically in the bill about the small group market?
The only thing in the bill that's specifically targeted to the small group market is the exemption from the reinstated assessment that I just referenced in our conversation a minute ago. The limit on pharmaceutical price increases would, of course, benefit them the way it benefits everyone in the market, but nothing specific.
And while the Covered Connect language, I think, could allow the administration to expand Medicaid if it so chose, there's nothing in the bill that explicitly expands Medicaid coverage. Is that correct?
That's correct.
And then there's nothing in the bill about the access for access for folks who are ineligible to purchase coverage presently on the exchange.
There's nothing in the bill specifically about that population or any other sort of Medicaid or exchange ineligible populations, although there is a general invitation to OHS to work with DSS and other stakeholders to look at ways in which the Medicaid eligibility rules could be expanded to expand access to care in Connecticut.
So back to the prescription drug portion, question about the wholesale acquisition price. To the extent that the bill is successful at limiting the growth of that, is there any sort of guarantee that that savings gets passed on to consumers as opposed to captured by pharmacy benefit managers or insurers? Is there where does that price go? And then the other sort of flip side of that is that one concern I heard from the industry was that they might respond by raising initial cost prices. Do you have a response to that?
Sure, I'll take the first part first with your permission. The insurance company's jobs is to negotiate the best possible rates for Connecticut consumers. And if wholesale acquisition cost increases are limited, I would expect the insurance companies to negotiate lower rate increases and to pass those benefits on to Connecticut consumers. And if the committee is concerned that they won't do so, minimum MLRs is the way to make sure that insurance companies are passing any savings on to their customers and our constituents. As Vicki said earlier, it's a hopelessly confusing value chain. Even for people like us who spend a lot of time thinking about it and trying to understand it, it appears almost to have been developed explicitly to defeat policymakers' efforts to bring costs under control. But I do believe that limiting the wholesale acquisition costs, sort of starting at the top, will lead to reduced costs throughout the value chain and ultimately reduce prices to consumers. Again, they may not see those at the pharmacy counter in terms of their out-of-pocket payments, but they will see them in premium savings, and that will provide them more money to meet challenging out-of-pocket contributions or allow insurance companies to offer better cost sharing on their side. As to whether companies will choose to sort of have a higher launch price in anticipation of eventual limits on their cost growth, it's a good question. It's a good concern to have. In some ways, I think if the 10 million lives in the Connecticut and New Jersey markets limit year-over-year cost increases, they can't set a launch price different for Connecticut and Massachusetts than they are for the rest of the country. I'm not sure to what extent we will fully drive their pricing decisions at launch, but I think there are other constraints on those launch prices, and if they are going to increase them to cover their R&D costs, I think the responsible, intellectually honest thing to do is to set those prices up front at a level that lets them recoup their costs rather than sort of luring customers in at lower rates and then increasing them later. As we all know, it is hard to get, and rightly hard to get patients who have accommodated themselves to one drug to change, even if the price of that drug changes. People's behavior becomes relatively inelastic.
And is there anything that would, I'm just trying to figure out, I don't know of cost limitations in it, price limitations in any state that you may know more than I do. But is there any, because we have interstate commerce in this country, is there anything that would sort of restrict or disallow transshipments, or I'm trying to figure out if could somebody buy Connecticut drugs and then sell them in California? How is this good? I'm just trying to understand how this would work in the stream of commerce.
Yeah, I wish we had sort of McKesson or one of the distributor companies here to testify today on that question. The limit applies to drugs intended for eventual sale in Connecticut, sort of final sale to consumers in Connecticut. I don't think that people will be buying shipping containers full of drugs here at the wholesale level and then shipping them through the Panama Canal or even across the New York border. Yeah.
And then one last question. There is open-ended language about what we talked about earlier about the 1332 waiver, that the permissive authority. I note that Massachusetts and Vermont have state-based subsidy programs that they've been able to leverage additional federal funding through the use of 1115 Medicaid innovation waiver. Does the administration have a position on the possible inclusion of 1115 waiver to enhance possible subsidies?
Vicki?
Okay, sorry, I was deferring to you. I think it's a possibility. 1115 waivers under the Social Security Act is normally done by the Medicaid agency to offer some flexibilities. It has budget neutrality associated with it. So whatever you propose, you have to do federally neutral budget with. So you'd have to consider those calculations. 1332 is deficit neutral, slightly different concept, equally confusing to most people, but is a federal deficit neutral mechanism. 1115s have been used widely across the United States for very different purposes. Massachusetts 1115 predated the ACA, as you know, and it's been renewed because the Mass Romney Care pre-existed Obamacare. And Massachusetts was offering subsidies under that 1115, and they've continued to do so. Vermont is using a different sort of mechanism for a statewide accountable care organization, but they are using an 1115 construct, and it is possible. So it's an option, I would just say, but an equally complicated option, to just be clear.
Thank you. Madam Chair, that's actually all the questions I have for right now. I want to thank the folks from the Governor's office for coming before us, and I'll turn it back to you.
Great. Senator Wong.
Actually, Madam Chair, I appreciate the indulgence, but for the second time, I'm happy to wait after Representative Farrar. Thank you, Madam Chair. I just
Thank
wanted
you.
to respect that.
Representative Farrar.
Thank you, Senator Wong and Madam Chair. Just actually a quick question following up on a few of the questions that Representative Nuccio had, and hi to you both. I had to jump on a little late, so you might have covered this earlier on. But in the proposal and this goal of this $50 million target, I believe, Mr. Dock, you mentioned that the way it'd be structured is you would build in what the pharmaceutical contribution would be, and then after that, kind of assess what the insurance company role would be. Do you all have numbers that you're anticipating in thinking about how this would roll out? I'm just trying to wrap my head around how this would be structured, and within the 50 million right now, what each source would really be contributing at a startup phase.
Yeah, my anticipation, or at least my hope, is that pharmaceutical manufacturers would follow the law, and they would limit their annual price increases in Connecticut to only inflation plus 2%, about 4% in real terms. And that would mean that the entirety of the $50 million assessment, 30 million in the first year, 50 million thereafter, would fall on Connecticut insurance companies, and ultimately, to Rep. Nuccio's point, probably be passed on, although not necessarily passed on to Connecticut's insurance consumers. We think that the reduction in cost increases on the pharmaceutical side of the house, even if the pharmaceutical companies aren't paying directly into that $50 million fund, will more than offset any increase in consumer prices associated with that $50 million assessment, keeping it not only well below the level that it's been historically and is in other states, but below sort of what trend would have been, but for this bill as a package.
Thank you for clarifying that. And certainly, as you said, the goal here is to, incentivize this behavior. I certainly hope it does that trick. From the standpoint, though, of what we're looking at right now in the market, you've noted that that's really not the case. So are you all anticipating, again, kind of certain amount of funds from having to, address these real cost increases amongst the pharmaceutical companies, or you're anticipating they change their behavior before implementation?
We're anticipating they change their behavior, especially if Connecticut and Massachusetts are able, as we hope, to act together, perhaps with our other Southern New England friends in Rhode Island, and start, setting a meaningful expectation for these companies of what really their consumers and our constituents can bear year after year.
Great. Thanks for giving me that sense of how you all kind of view this and working with the other states as well. Thanks, Madam Chair.
Thank you. Senator Wong, did you have a
Yes.
follow-up?
Yes, thank you, Madam Chair. I just wanted to respect that protocol, and I appreciate the opportunity to speak for the second time. And part of the reason for the second time is I really wanted to listen to my colleagues, and greatly appreciated Mr. Dax and Ms. Veltri's answers. So let me take that through from an analysis standpoint. The Senate Republican had proposed Senate Bill 1006. I'm not sure if we're going to get a public hearing out on that, but as I'm listening to you, I see a tremendous amount of similarity and the same frame of mind and thinking, particularly one of the components of reinsurance. And one of the questions I wanted to ask is, has the administration considered with the potential granting of federal funds that in utilizing the 1332 exchange and potential federal healthcare money and Medicare, et cetera, that we could offset the assessment and tax on premiums? That is it a possibility that we could use allocated federal funds in offsetting that cost to be able to create the reinsurance product? I know you cited it in your bill, but and in your testimony, but didn't go into deep discussions about that. I think reinsurance may be a very viable product at this time to be able to offset some of the cost considerations we're trying to address. Any thoughts on that question?
Yeah, the administration supports reinsurance. We had a governor's bill last year that included reinsurance. The landscape has changed with the shift in federal administrations and with the passage of the recent bill. What we want to do is buy ourselves the time, not for you to hear from just me and Vicky, but to hear from Vicky and the relevant agencies and experts on a soup to nuts plan for how this $50 million, 30 in the first year, could be best put to use for the people of Connecticut and put to use in a way that maximizes federal dollars in that effort. So reinsurance, we know from the Wakely report that AHCT has commissioned and you have probably seen, brings in roughly $1 federal dollar for every dollar we spend as the state. That's not bad. That's about what we get in Medicaid. There may be opportunities through more targeted premium supports or cost sharing reductions to bring in not one-to-one federal dollars, but a substantially higher federal match, and to target that match and the state dollars at the population most in need. So we're really open to whatever story the numbers tell us in terms of how we can best serve our constituents.
I am so appreciative and grateful for the open-mindedness and the offer of collaboration. It is indeed welcome for us to get the best product at hand. I think the second component that we share a lot of similarity with Senate Bill 1006 is the fact of addressing the cost of prescription drugs. I think the administration proposed some very different ideas than the pre-existing idea of Canada's pricing. And I'm very much receptive to engaging in that conversation. But I want to reiterate that for the Senate Republicans and the House Republicans, the idea is looking at prescription drugs has another significant cost factor. And I wanted to compliment the governor and yourself for that kind of a perspective. The third issue that we looked at was benchmarking, and that shared a lot of similarities in regards to, and I wanted to share that I've had some conversations with Ms. Jean On, who was the Chief Strategic Officer, I believe in some capacity, with Bay State Medical Centers, now with Nuvance, and she saw firsthand the more recent utilization of benchmark, and we have great talent in our state to be able to utilize and make a best benchmarking based upon lessons learned. Do you have any particular thoughts in regards to how the legislative branch can help policies to the administration in crafting a benchmarking program that will be truly effective in managing cost and being able to have some data points? That could be you or Vicky.
John, are you deferring to me? Because I think I can weigh in on this one. Okay, so.
It was a setup for you, Vicky.
It was a nice setup. Thank you very much. And we have been working, I want to thank this committee, the Public Health Committee. We've had a really good relationship on the benchmark work. It's even pre-executive order. There were a lot of conversations going on about implementing a benchmark program in Connecticut. And, we did start with the executive order in part because we had a bill last year. We had a bill the year before, it was late in session. We had a bill last year, the session died, as we all know. And we proceeded to work on it. And we think like the other states, that this is a really important thing to do. The transparency efforts are really critical to exposing the underlying costs that are driving health premiums and cost sharing that people are paying, right? That data is slowly coming out. We think that we will have to codify the benchmark. And I'm sorry, I will say in advance that I'm not going to be able to testify Thursday in person, but we are submitting testimony on it. We will have to codify that work. I think what's slightly different than when we initially proposed the bill is that we're actually working on it, right? So we're learning things as we go on how to best codify it. So we're in the first year of actual implementation of that benchmark. So we were kind of proposing that we come back next session with an ironed out bill that's consensus, that isn't going to be highly dramatic because lots of these kinks have been worked out in it. And we invite people to stay engaged in it. We do meet monthly with our legislative partners, the chairs and the ranking members and the vice chairs. We've been meeting every month or trying to with most everybody on it. But the key there is going to be when you see the data, right, that we will be showing, what action are we going to take together to address what we're seeing in these data? And those are going to be very difficult conversations, just being honest, like we're having today, right?
No, it absolutely. And we have the talent pool. And as I said earlier, your demonstrated experience and grassroots effort is critical for us to be able to utilize that. And as a cat go behind your back,
Yes, I'm sorry.
That's okay. That's okay. We had a baby and a cat.
Usually one makes an appearance, sometimes
Now,
two.
the fourth part of Senate Bill 1006, we talked about, and it's really important, is the fact of transparency and accountability. And I think I don't want to repeat myself or have you repeat yourself. That is absolutely paramount for any system to truly be effective and sustainable. So I appreciate both of your time. And I just want to reiterate that the Senate Republican are looking to create a better way, working with the administration to finding solutions. And I want to applaud the administration and all its staff members for being open and collaborating and working with all of our various partners. I think ultimately the best way we can contain cost and be able to manage a system moving forward is to address an entire ecosystem, but to do it in a collaborative way with existing structure. The idea of creating something brand new may be something that may be great and ideal, but the reality comes into a brutal confrontation that sometimes these challenges, like I said earlier, if we could solve healthcare cost containment, we would have done it 30 years ago. But nevertheless, I really appreciate all of your time and effort and my ability to be able to share that, at least for me, as a Senate Republican, that 1006 reflects a lot of the values and being able to collaborate and work together. So thank you, Madam Chair, for the opportunity. And thank you all for your work again and your indulgence and time. Thank you, ma'am.
Thank you so much for coming and spending this time with us, and we appreciate it and look forward to continuing to work together.
Thank you for having us, and likewise, we're always available.
Next, I have Senator Kelly, but I believe he may have left due to time constraints. I wanted to just see if he's available. I don't see him. Next, we have Representative Q Phipps. Is he available? There he is.
So good afternoon, everyone. Thank you for this opportunity to speak to you about this important bill. I think it's bill number 6587, the bill regarding EpiPens and epinephrine. This is a very important bill for numerous reasons. I think it's, I would feel remiss without talking about what's happened over the weekend, where one of our own coordinators, one of our own staffers, had a recent allergic reaction that put them in the hospital and very sick. And we are always, those of us with severe food allergies or allergies to insect bites and so on and so forth, are always this important and life-saving medicine away from death. And that was always really apparent. I don't actually remember my first interaction with my severe tree nut allergy, but it's something that my mom remembers very, very clearly. And in 5th grade, I won a math award named after a student who died from a nut allergy, only to graduate from Bryant University. And there was another award for a young student that was very involved in the university level and also died from the same thing, allergy to tree nuts and ingesting it and not making it with this life-saving medication. And I was really lucky. My mom worked for the state of Connecticut for many years. So we've always had really good insurance. And when I started working for Bank of America, who was making literally $1 billion a quarter at the time, I had the best insurance plan that they had, but the insurance was the prescription cost was $400 for an EpiPen, which was something at the time I couldn't afford because of the many other bills between student loans and housing and so on and so forth. I couldn't afford it, even as this company made $1 billion a quarter. And that inequity was always clear to me, that every time I ate at a Thai restaurant or any restaurant matter for that matter, I was always putting my life in danger. And it's always been scary. It's always been really, really scary. So when I think about where we're at today, after making this life-saving change last year in terms of diabetes medicine and insulin, and making sure that everyone had access to this life-saving medicine, where people should not have to choose between food on the table in medicine, or their housing payment in medicine, or energy in medicine, we in the state of Connecticut have already made a commitment saying that we need to make sure that we protect one another, and that people should not have to make those hard choices. And this is what this bill is really about, the ability to be able to afford to protect yourselves, to protect a loved one. And also as an educator, I think we forget of how many of these life-saving medicines you need. If you're a young child, you would need one at school, you need one at grandma and grandpa's house, you need one at home, you would need one at the after-school program. That right there could cost you hundreds, if not thousands of dollars at the current rates in which the prescriptions would cost. So I would encourage you all to support this bill to make sure that every young child will have this protection, that every family will not have to make the choice between protecting themselves or protecting a loved one and providing basic care. So I would highly, highly encourage you to support this bill, to pass this and make sure that everyone in the state of Connecticut can be protected and have this life-saving medicine.
Thank you, Representative Phipps. Questions from Representative Comey?
Hi, thank you. Good to see you, Representative Phipps. I think, we actually share that employee. And I was, it was a pretty severe reaction that happened over the weekend. And the story goes, when I dug a little deeper, is that she didn't realize, because she's a new employee, relatively new, and didn't understand that unlike her past insurance policies and her past plans under her parents and things, that the EpiPen would be covered. We're very fortunate with our state insurance that an auto injector is covered. But she was not aware that the insurance, she thought it would still cost her over $500 to get that prescription filled, and that is why she did not first fill that prescription. I think, we're sort of talking about the same thing when we're talking about the price of the medications. In fact, Senator Lesser mentioned the Auvi-Q as one of the highest the highest rising prices. In fact, here in Connecticut, the Connecticut is fifth highest among states in the nation for food allergy diagnosis and anaphylaxis events. And when you mentioned that you had to have that you heard that you had to have, I have a child with food allergies, to be completely upfront, is that I have as grandparents at school on him at all times, and then with mom and dad. So we have to have several, like sometimes a half a dozen steps with us. And it's just, insurance only covers a portion of that. But I think what's most important is that it is life-saving. This is a life-saving medication that will help in the situation where someone gets a bee sting and has anaphylaxis, or someone eats a food that they're didn't know that they were allergic to, or they did know that they were allergic to. And this is such an important bill for those that don't have the greatest of insurance. So I thank you for bringing it to my attention, and I'm not sure that I actually have a specific question. I mean, there's some great testimony that was uploaded by a colleague of mine, Patricia Donovan, who has done some great work on this. So thank you for allowing me to thank you for bringing this forward.
And I thank you for bringing up that point about having the multiple EpiPens in all the different locations. As I said, for one, at the current minimum wage, that could be over 30 hours of work for someone to be able to just buy the one. An entire week's worth of work to buy one medication, and you still would need one for school, for home, for grandma and grandpa's, for after school, and the many other places that you may need one for a child alone. So it can be incredibly, incredibly expensive for a family.
Senator Lesser.
Thank you, Madam Chairman. Thank you, Representative Phipps, for your testimony today. And I do wish the best to your staff member. I hope she's okay. And you know, like many other folks on this committee, I have personal experience here. I had an anaphylactic reaction at the Capitol a couple years ago, and this is something that is important to me. You know, the thing that we have to sort of weigh in making sure that these devices are available to folks is also the fact that the companies that manufacture them, and Representative Comey just mentioned this a minute ago, have been increasing the prices at an astronomical rate. I think preying on the fact that families are desperate. Right? People want to make sure that their kids are protected. The bill as drafted just speaks to the out-of-pocket costs that a fully insured person in Connecticut who does not have a high deductible plan would pay. It does not, as I read it, restrict the cost driver that the manufacturer puts on it by raising the price, you know, in the case of AviQ by something like 60% over a 3-year period. In the insulin bill that we looked at in the fall, we attempted to get around that by piggybacking on prices available to community health centers. Is that something that you would suggest this committee take a close look at as we try to not just address the out-of-pocket costs, but also the underlying costs?
Senator Lesser, that's a great question. And when I put in a similar bill to this idea, I suggested that we already have model legislation, the model legislation being the insulin bill that we just passed. And I think in many ways, just switching out the word insulin for EpiPens or epinephrine is the way in which this current bill should be written. I think why reinvent the wheel twice? Let's follow the best practice that we've already created.
Thank you. Thank you, Madam Chair.
Representative Meskers.
Yeah, Representative Phipps, thank you for the testimony. I think it, you know, we sit here, we argue about healthcare, we argue about cost, we argue about structure. And it's so helpful to have someone, a colleague, come up and talk about their experiences. You know, Senator Lesser, thank you for the commentary. Of course, unfortunately, fortunately, Senator Lesser, it was a couple of years ago. So the immediacy of your experience is less. So hearing the needs and realizing that our decisions weigh on or our decisions have outcomes and effects on people's lives is so important. So I really thank you for the testimony. Thank you for stepping up for that.
And I forgot one part about the story that I meant to share about just like how life-changing it is to have this medicine, have access to it. I remember when I first started working for my most current employer, where I got an insurance plan where I can afford the medicine. I took a picture on Instagram with it, with me holding my EpiPen, just being so proud that I would never have to worry again about being in danger at eating out or accidentally ingesting this. I took a picture of it. I made sure I documented it on social media because it was that important. It was that big of a change that I could finally afford this. And once again, I was a banker. I had been an executive director, someone that should have been able to have the privilege to not have to worry about medicine. But here I was 6 years ago, holding an EpiPen in my hand on Instagram because it was that important to me to let folks know that I could have one and that I was safe again.
And that takes us back to our commentary on the bill as well on 6447 when we start talking about without attacking pharmaceuticals. If we relentlessly raise the price of base medicines whose formula has been virtually unchanged for 50 years, we price people out of the market for whether it's insulin or EpiPens. We price people out of the market, and as Americans, we bear a cost that for some reason they don't have to bear in Toronto, or they don't have to bear in Switzerland or in London or Geneva. I guess I use a city. I guess I use a city everywhere else. But it's not fair that we should build a pricing model on the back of American citizens. I'm not arguing about the profit motive of the pharmaceutical industry. I just don't want to be I don't think the target should be on the back of Americans to fund the entire research industry of that industry. So I salute what they do. I just wish that, you know, the Canadians pay their fair share instead of the Connecticut residents. So thanks for your testimony.
Thank you, Representative.
Representative Nuccio, followed by Senator Wong.
Thank you, Madam Chair. Good afternoon, Representative Phipps. How are you?
I'm doing great. Good afternoon.
Good afternoon. So I too have a story like that with yours, and not for myself though, but my husband had a severe reaction to a bee sting, never had in his life, and it didn't happen until he was in his late 30s, and it required an ambulance trip and shots of more epinephrine and then shots to bring his heart rate down, and it was extremely terrifying and horrible. And I remember when we went to get our first EpiPen for him, which, by the way, back then you could buy one and you didn't have to buy two, and it was a $25 copay. And over the years, it turned into, like you said, it was a $400 copay, and you had to buy two. And we just didn't get it. We couldn't get it. You know, there was no way that we could afford it. So we had outdated ones and just said, you know, it's not too cloudy. Hopefully it will work. You know, so this is definitely a real matter. My question was going to be, though, I didn't know if you happened to hear any of the testimony for the prior bill that we were talking about regarding the pharmaceutical portion of it.
No, I did not hear that. I was in another hearing myself and preparing for the aging one a little later this evening, or afternoon, excuse me.
I know what that's like. So in that bill, they were talking about being able to tax pharmaceutical companies that increase their prices over a certain amount of the CPI plus 2%. And my only problem with bills like this one in the insulin bill is that it truly does not do anything to affect the cost of the healthcare piece of it. It doesn't do anything to affect the cost of the product. So I'm interested in seeing if there's a way that we could try to find some language to work around that, because the other portion of this is the same thing with the insulin bill. The state of Connecticut's market is only 30% fully insured. So those bills only truly affect certain people that have insurance, and the majority of people have ASO plans, and they don't see any relief. Actually, the cost gets shifted from the fully insured portion onto the ASO insured. So it's unfortunate. I think we need to try to find a way to work around the cost of these products and trying to get, as Representative Mesker said, I guess we need to raise our voices more, that we can't continue to be the stepping stone of research for the rest of the country. So I just wanted to say thank you for bringing your story, because I totally identify with it, lived it, still kind of live with it. I still haven't even gotten a new EpiPen yet, so, and need multiples. But I'm just concerned that we find language that we can try to help everybody with. And I'd be definitely interested to talk to you and work with you in any way to try to find language that we can accomplish that in.
Totally. And I was I'm a fairly new legislator myself. And I think one of the difficult parts about this work is that we know that we can't help everyone, which is why I usually say my favorite word is and, right? That this is not a work of or, this is a work of and that it can be true that we can help the folks like we have in the former insulin bill, and that this one should be modeled after. And we can still work on the cost of medicine, and we can work on the outrageous costs that pharmaceutical companies use for things like marketing and bonuses and so on and so forth. I said my brother was a pharmaceutical rep himself, so I have seen one of my own family members benefit from that kind of compensation and work. So that's not the critique. I think the real question at hand for we as legislators to answer is it okay for us to lose our neighbors for a fairly inexpensive drug that has been, as Representative Mesker has mentioned, fairly unchanged for the last 50 to 80 plus years in which it was designed? And like, how many people do we want to lose for what's going to set up a fairly commonplace medicine? My answer would be none. That's what my answer would be.
I'm with you. I too, I think it's predatory. There are certain drugs, I think that it's just predatory pricing because it's needed. So thank you again for bringing it forward. And, I'd gladly talk to you anytime about trying to expand it somehow.
Awesome. Great question. Thank you so much, Representative.
Senator Wong.
Thank you, Madam Chair. And Representative Phipps, thank you so much for sharing your thoughts and your story. And what really struck me is the joy that you talked about taking the photo of your epi, because that's what healthcare is so powerful, because it's life and death. It's an essential part of what we need to protect ourselves. So I completely agree with you on that. And I want to thank Representative Comey for her supporting comment. And I want to acknowledge Tricia Donovan, who has been a tremendous advocate. It is predatory pricing. And this is beyond the pall. This is exactly why the pharmaceutical industry sometimes gets a bad rap, because the important work that they do are essential. The innovation, life-saving efforts, all acknowledged. But when you see something like the EpiPen evolve in pricing that has no basis or rhyme and reason, it really is predatory and political. And I actually am familiar with the history of this, where a federal statute was enacted to favor certain players in that entity. So I really want to thank you for pointing that out. And also speaking on behalf of so many others, parents and individuals impacted by food allergies. I have a son who's 21 years old, and since the day he's been born, we've had to buy the EpiPen. And the fact we have seen the prices increase from $55 to now nearly $600 is unconscionable, right? And the fact it is not a product that has a infinite life cycle. It has an expiration date over a period of time. And what's important for people to know is the fact that if you are a parent of a child with allergies, you need to have one at home, but you also need to purchase another one to be based in the school in which they're at. And when you have to front the dollars, when there are no appropriate insurance coverage, and I think that's what's important when we talked about earlier, that we need to control and manage healthcare insurance costs, because this is an example. The fact that people with health insurance coverage can get this EpiPen and pay the copay at a small dollar amount, they can get that as a life-saving product for their loved ones. For those people that don't have insurance, the out-of-pocket expenses that you describe so effectively, Representative Phipps, is exactly why we need health insurance reform, but one that's sustainable. So we're doing a lot of talk and telling you that we appreciate you bringing this to the forefront, and along with so many others that are telling the story, because this EpiPen experience, I talk about it all the time. This is outrageous price increases, and it's got to be contained. So I fully support your advocacy, and I want to thank you for testifying.
Thank you, Senator.
Representative Comey, do you have another question?
Yeah, I'm just grateful. Actually, Senator Helling said a lot of what we were going to say. I mean, the epinephrine itself is just $2. It's the device, and I just wanted to clarify when I mentioned Auvi-Q. Auvi-Q is an incredible product. It is a speaking auto injector. It is wonderful. It is small. It is friendly for kids. My kid just gave it to himself over the summer for the first time. It's not threatening. It's not a huge needle like the EpiPen. So there is some incredible work being done to make products better. And I didn't want to sort of call them out, but as we remember with the Mylan Epigate is actually what it was called, where the prices rose 400%, while it was the only product on the market. So that's another reason, Representative Phipps, that I'm so grateful for you to be able to bring this forward and to be with you, work with you on that. Thank you.
Great. Thank you, Representative Phipps, for coming in.
Thank you so much, and I appreciate the accommodations.
So I just was informed by our clerk that we have passed the first hour of our committee meeting, and how the speakers are going to be called going forward are the first hour is reserved for legislators and agency people, and we then rotate in the public. So we do have, so I'm just going to read off the next 4 speakers so that people can prepare, because if you are looking at the speaker list, we're going to have to rotate. So the next person is Neil Roberts, followed by Representative Turco, followed by Paige Mahoney, followed by Representative Pat Dillon. And with that, let's hear from Neil Roberts.
Hi, everyone. Thanks for having me. Can everyone hear me? Yeah. Okay.
Yep, we can
My
hear
name is
you.
Neil Roberts. I'm from Burlington, Connecticut, and I'm the Executive Vice President for the Schuster Group, an employee benefits agency here in Connecticut. I've worked in the healthcare industry for the last 18 years and then advised over 200 clients in the state, both private and publicly funded clients of all different funding and sizes. In addition to working in the sector, like you, I'm also a consumer of healthcare and a purchaser of health insurance. I do think that one thing we can all agree on from hearing these testimonies is that we all want affordable and accessible healthcare coverage for ourselves and our families. However, when I read the bill, House Bill 6447, I don't really see a solution. The bill simply shifts costs to the payers and consumers of the products, and those underlying costs don't change. So here are some facts about healthcare economics that I think are vital for consideration. And underlying provider expenses and participant utilization are the key drivers of the cost of healthcare. Nothing in that bill addresses that. The bill only increases costs to one group of the constituents to subsidize costs for another. And the bill simply mandates who will fund the option. The Affordable Care Act should prove to be a sufficient lessons learned, I think, for that approach. The bill ignores the fact that most payers in the state have embraced and are implementing true value-based healthcare products that reduce costs and increase the quality of outcomes. Good public policy would promote competition through deregulation and embrace true move to value healthcare and a free market. I think that the state really has 3 levers to achieve the goals that they're looking to do in this bill. Fees for service to pay health providers more in line with Medicaid, taxes raised to subsidize coverage, and assessments directed to insurance companies and therefore to the consumer. None of these will achieve affordability. All of them are bad for the economy. The state's mechanism for forcing a provider to accept lower costs will immediately cause a provider to shift the cost to the commercial insurer, and thereby increasing costs to the employers. The bill also exempts itself from some of the rules, regulations, assessments, and taxes. And so, thereby permitting the body to be free from the burden of the costs that it's imposing on the legitimate participants in the healthcare marketplace. The state thinks that it has to assert some purchase power here. And when I look at the state, run plans currently, ironically, the state of Connecticut employee health plan is the most expensive, one of the most expensive health plans in the state. And the partnership plan is, relatively insolvent. As a taxpayer, I have really large concerns with this negligence. When you look at the history of these government-run programs, and their performance and increasing cost, and we're here, trying to expand it. So, in Connecticut, we have economies of scale. We have 6 payers in the state, and they employ tens of thousands of people. And I just feel like that this is a real cost shift we're affecting one group of constituents to subsidize another. And I think that discourages competition in the market. So thank you for your consideration.
Thank you, Neil. Do we have questions for Neil? Senator Wong.
Thank you, Madam Chair. And Mr. Roberts, thank you very, very much. And you offer a context as we talk a lot about the health insurance solutions, but I think you represent a viewpoint that don't always get heard in the debate, which is you as a benefits counselor on the grassroots of helping consumers get the information. And I think one of the concerns I have with the governor's bill is the assessment or tax on the various insurance products, and the fact that it potentially will be redistributed to business policies. Maybe I'm just being a little bit kind of sensitive to redistribution of costs, but what is your experience on that type of a program? The cost is going to go somewhere, right? And also, where do you see this kind of program as it impacts the consumer in getting information, as you provide so much of it to people on a very complicated and complex issue?
Yeah, thanks for the question. So I'm an underwriter by background. So, when I consult with the groups, it's mostly on a fiscal basis. So we're always managing a budget. And so costs are, it's helping employers manage their biggest asset, which is their people. And, I think this bill, really ignores, the pressures that the commercial market and the private sector is facing with healthcare. I mean, they're in the same boat as, the public sector as well, with the rising costs and in some view, the unsustainable rise, which I agree with, of some of the components of healthcare. So, from my perspective, I think that, again, it's a blatant, increase of costs in one area to then, if you push on the balloon, it's got to come out somewhere else. And I just, I don't think the bill really addresses what the true problem of cost is with healthcare. I've heard a lot about the pharmacy side, which I'm not here speaking towards today, but that is probably a good start in trying to understand how that happens. But in general, I don't believe in price ceilings. I do think that a competitive market kind of solves itself in some regards. And we do have economies of scale in the state of Connecticut. We have 6 carriers that are at parity with each other from a network perspective, and they're competing for a small slice of the state for membership. And I would prefer a look to deregulate some areas where they're forced to pass through many of the assessments and taxes that this body is considering.
Yeah, and my second question is, you work with insurers, and at times they have a well-deserved bad rap because they're always the people saying no and all the rationales of why people aren't able to get care and coverage. But in your experience working with not just the 6 carriers that you talked about, but also with Medicare programs and government entity programs, who would you still rather be able to do business with from a consumer as well as a product availability standpoint? Because one of the things I've learned is we have Medicare, Medicaid products, but we also have a supplement of Part B, Part C, Part D, Part F to supplement what is provided. So the idea of a government program isn't always as it's promised. Would that be a fair statement?
Yes. Yeah, absolutely. And I agree. It's not healthcare is definitely not a one size fits all. I mean, it's even within my own family, I look at my healthcare needs versus, maybe my sisters or my parents, and, really everyone has different healthcare needs. And so, employers are really tasked with that. I work specifically with mostly larger group employers. And so, there are options in the market, aside from just the 6 payers on a fully insured basis that, employers need to get creative. And I think they have, and they've been forced to. But again, I think, some of the creativity and innovation that's come out of, that market and some of the cost containment ideas that are available to employers are not born from government policy. They're born from, private sector developing these products to gain a market share.
And I think my last question would be from a standpoint of regulatory. Every single one of the products are reviewed by the Department of Insurance and meeting compliance, right? And would you say, how many years have you been in the business?
18.
18. So you have seen, prior to the Affordable Care Act, forever its challenges to be, one of the benefits for me has always been that pre-existing conditions are now required to be covered. Is that not a critical, essential element of health insurance coverage right now, that there is no going back and it is an essential human right on that?
Yes, I agree to that.
Right. And
On the pre-existing condition alone. Yes.
Right. And any possible consideration that would create an adverse selection in an insurance product is something that is tantamount to going back significantly. Would that be fair to say?
Yes.
Thank you. Thank you, Madam Chair. I appreciate your time, and thank you for your service as a liaison and interaction for many people that are experiencing challenges in health insurance, and getting them answers and feedback and collaborating with them. Thank you very much. Thank you, Madam Chair.
Thank you, Senator. I'm just going to jump in for Representative Wood, Chairwoman Wood. Representative Nuccio.
Thank you, Madam Chair. I'm sorry, sir, did you say you were a underwriter or an actuary?
Underwriter by training.
I
But I
love a
work
good underwriter in a
field
conversation like this.
as a broker.
That's okay. I really appreciate an underwriter in a conversation like this. So you brought up, well, first of all, to Senator Wong's point, I actually think the state of Connecticut, I could be wrong, but I'm 99.9% sure that pre-existing conditions were covered in the state of Connecticut prior to ACA. We already had legislation that said that we could not discriminate against pre-existing conditions. So you're right, it does go back a very long time. But that wasn't my question for you. So you brought up a very good point. The state's plan is often touted as, a more efficient, not efficient, but a less expensive plan. But part of that is, in fact, due to the fact that the very first thing most of these, actually all of these legislations have done is exempt themselves from it. So all of these assessments and premium fees and all of these other things that get passed on to regular insurers are not applicable to government plans. The first thing they do is exempt themselves. So thank you for bringing that up, because I think that it's a very important piece of all of this to understand. And with all of these pieces of legislation, like you said, it's going to shift costs from one to the other. If you talk to providers or anybody else, if Medicare pays 80 cents on a dollar, they're recovering that 20 cents on another populace. So thank you for bringing that up. Would you say the drug portion of this bill, though, are you in favor of the drug piece of the legislation?
My own personal principles to that is I still, I understand that drugs save lives, and that, we want access for people. We want it to be at an affordable rate. And I do think there's a place for, some of these programs, but, I also see the private sector side, and there can be competition, and that's what we've developed, at least at my agency, is, you're not forced to work with one PBM. You're not forced to work within the confines of one option. And so there are many products out there that can solve for that through competition. So, I don't believe in price fixing. I just think that it affects supply and demand in the market. And I would prefer it to be a freer competition.
Thank you. Thank you for your input. And thank you, Madam Chair.
Thank you, Representative. Any other questions from Mr. Roberts? Okay, seeing none. Thank you so much for coming.
Yeah, thank you for having me.
Okay. Next on the list, we have Representative Turco. Welcome to the Insurance and Real Estate Committee.
Thank you very much for having me, Senator Lesser and Representative Wood and Senator Wong and Representative Pavlik D'Amato and all of my colleagues. Really great to see you, and I thank you for this opportunity. I'm here to testify on Senate Bill 1004. This is an act concerning dental and vision insurance coverage for children, stepchildren, and other dependent children. And I know some of you, I see Representative Dayton here, and of course, Senator Lesser, and many of you are familiar with this bill. It's been in front of the committee before. I strongly supported it the last 2 years that I was on the Insurance and Real Estate Committee. But I know some of you are new to the committee, so let me just tell you why I think this is a very important bill, and I'm hoping that you'll pass it out of the committee and we can get it all the way through the House and the Senate on the governor's desk this year. This bill helps young people in every single one of the communities we represent in the entire state. It's working towards helping expand access to affordable and vital dental and vision services to young people who cannot get these benefits from an employer. Now, State Representative Michelle Cook is going to share with you, if she testifies today, and I know you have a lot of other people that are going to testify, some personal stories about young people who either after graduating high school, after graduating college, going out into the workforce, didn't get a job that offered them dental benefits, vision benefits, and some of the life-threatening illnesses that resulted because of that. They weren't able to afford chronic treatments that they needed. They weren't able to get preventative oral health care that they needed. You put that off for many years, it will catch up to you. Not having proper oral care can result in heart disease. It makes it, it's necessary for treating diabetes and other conditioners. I see we have, Senator and Dr. Anwar here who can educate us on how important oral health care specifically is, but vision too. So we have an opportunity with passing this bill that will allow individuals, young people, to stay if they're able to on their parents' insurance policies until the age of 26. This already happens with medical health insurance, as you know. In Connecticut, we passed this in 2008, and then a couple of years later, the Affordable Health Care Act did this for the entire nation. If you graduate from school, you can, if you're under your parents' health insurance, you can stay until you're 26, and then hopefully at that time, you can get your own insurance through an employer. But dental and vision, for some reason, weren't included. And they should have been, because they are healthcare as well. And there's dire consequences if somebody is not getting the care they need in those areas. So I've submitted written testimony, goes into some more detail. I know you have a lot of people testifying today that will tell you personal stories about why this is important. I've spoke to many constituents in mine in Newington, young people without dental insurance, that this will help. And I promise you, it's going to help every single person. It's going to help individuals in every single one of your communities, and it actually will help save lives. And how often can we really say that a push of that green button, a yes vote, is actually saving lives of our constituents? So I open it to any questions, and thanks again for this opportunity.
Great, thank you. Any questions? Thank you, Representative Turco.
Thank you. Have a great day.
I made an error, so I'd like to apologize that I skipped over John Burkhart from Pfizer. Is John available? So John Burkhart is next, followed by Representative Dillon. Okay, we'll come back to John. Representative Dillon.
Thank you, Madam Chair. I was waiting. And thank you, Chairman and ranking members and esteemed members of the committee. I'm Representative Pat Dillon from the 92nd District in New Haven. I'm here to testify in support of Raised Bill Senate 1008. You may have gotten my testimony today. We were in environment yesterday for 12 hours, so I was challenged today. But this is terribly important because as time went on during this pandemic, it became clear that at least in the United States, there was a disproportionate toll being taken on communities of color. And I think as public policy makers, it's really incumbent on us to unpack that and to figure out how it happened. One of the things that I learned when I was researching this summer was that this little device, a pulse oximeter, which some of you may know or not know, and I'll hold it up, which is very common and available, whether it's approved by the FDA or not, because it's so common, was very often being used to discern the acuity of the condition of the patient. And sometimes decisions were being made on that, medical decisions. As long as 2005, it was clear that if with a pulse oximeter, the measurement is less often accurate if your skin is brown. And that really has nothing to do with anyone's bad intent. It's simply the science of it. The light pulses through your skin. And unfortunately, nothing was done about it. This is most important when it comes to insurance coverage, which is why it comes here. I'm not seeking to regulate the device because a lot of that really went out the door, especially when the FDA law changed in 1997. You can get this on Amazon, and it may not even be a good quality device. What we're concerned about is Medicare decides whether or not how sick you are based on your blood oxygen. And 90 is very often the cutoff. Unfortunately, if this device tells you 90, it's really an estimate. And that may mean that you're deprived of home oxygen. Because many private insurers copy Medicare because it's easier, it seemed to me as a state legislator, there are limited things we can do. But one thing we could do is to say that you cannot deny care to an individual of a service that would be otherwise covered unless based solely on the reading from the over-the-counter device, the pulse oximeter. That doesn't mean that everyone has to have arterial blood. It doesn't really tell any doctor what to do or any hospital. It does say, though, that if you get a blood ox of 90, it may very well be 86, and you may deserve care that you're being denied if there's a rigid algorithm. So that's what the language does. And I need to say, after I consulted with some people, I was really advised by a number of people not to do legislation. And the reason is there was so much skepticism about vaccines that people were afraid that we would scare people. And as the pandemic wore on, it seemed to me, and especially in December, when an article in the New England Journal of Medicine, which I linked in my testimony, demonstrated that African-American patients in a very large study were 3 times more likely to get an inaccurate reading. It seemed to me that we were at risk of denying people of badly needed care. I can't claim that resulted in their death, but that's not the only outcome. They could end up with severe illness going forward or some kind of heart damage. These can provide tremendous comfort to you. They were a comfort to my family during my father-in-law's illness. We were able to get a reading from him every day, and we had an idea what was going on. So that I don't want to disparage the devices, but we need to make sure that we don't overstate their importance and that we understand their limitations. If you have any questions, I'll be happy to answer them. And thank you very much for having.
Thank you, Representative Dillon. Senator Lesser.
Thank you, Madam Chair, and thank you, Representative Dillon. We're, as you had stated, in the middle of a health equity crisis, in the middle of a healthcare crisis, and this is a small, important issue that you raised, and so I want to thank you for that. Just had a question about some of the testimony we received from the Hospital Association. They recommended looping in the Department of Consumer Protection, which regulates pharmacies and pharmacists, and then also suggested as well making sure that the bill doesn't just apply to insured people, but to all patients in the state. Are those suggestions that you would view as friendly changes?
Well, as I mentioned, Senator, really since 1997, when the FDA statute became more of a marketing statute than a safety statute, there's been more direct marketing to patients. That's when you started seeing prescription drug ads on television, and there were a whole lot of complex changes in the law. Partly a consequence of that, and partly because they're easy to manufacture. When it comes to regulating these devices, I think the horse is out of the barn. I mean, we could very well, as a matter of courtesy, include the consumer protection people in Connecticut, but it's unlikely they'll be able to do very much. I mean, when I was worried at the end of March about what was happening in New York, I got one of these devices. I ordered one from Amazon. I didn't get it until May because there was such demand that was almost as bad as a mask. But I wouldn't have known necessarily. I could buy something whether it was FDA approved or not. And that was really why I took the course of making sure that no one is denied care, and also trying to provide information to providers. So I did not do that. I was more concerned about preserving life and reducing debility. But if the chairs and the committee want to do that, that isn't necessarily something that's essential to me. It's just that I didn't think it was needed.
Thank you.
Any other questions? Great, thank you, Representative Dillon. Okay, did John Burkhart come on?
Hi, yes, can you hear me?
Oh, yes, thank you, John.
Thank you. I had a little technical difficulty earlier, so apologies for that. Dear co-chairs Lesser and Wood, ranking members Wong and Pavlock D'Amato, and all the members of the committee, thank you for inviting me today. My name is John Burkhart. I'm head of the site for Groton's R&D in Pfizer in Connecticut. Pfizer is proud to call Groton home to research for 62 years and is currently Pfizer's largest R&D center anywhere in the world. More than 2,700 R&D professionals work at this site, as well as the New Haven Clinical Research Unit. Every medicine or therapeutic that Pfizer develops comes through our Groton facility at some point, and many were discovered right here. This past year has been like nothing we have seen in our lifetimes. When the COVID pandemic struck, Pfizer colleagues immediately went to work. We formed research and manufacturing teams and created distribution partnerships. We collaborated to help solve this unprecedented public health crisis. Since receiving emergency use authorization from the FDA, Pfizer has shipped the US more than 50 million doses of the Pfizer-BioNTech vaccine, and we're on track to deliver well over 300 million doses by the end of July. In Connecticut, we have shipped 1.4 million doses. I'm proud of the role Pfizer and thousands of our colleagues in Groton's continue to play in bringing our COVID-19 vaccine to the world. Currently, our Groton site manufactures the critical lipid component used in vaccine production, and we have contributed to over 113 million doses. With that introduction, I'm here to respectfully oppose House Bill 6447, an act creating the Covered Connecticut program to expand access to affordable health care. While we can all agree that the title of the bill is something to which we aspire, this legislation assumes incorrectly that there is disproportionate spending on prescription drugs. It wrongly asserts that innovative manufacturers should be penalized, and naively assumes that biopharmaceutical manufacturers determine the price that a patient pays at the pharmacy. Here in Connecticut, spending on hospitals and physicians accounts for 60% of healthcare spending, whereas drugs only account for 15%. Administrative fees and insurance company products account for over 1/5 of healthcare spending. This legislation singles out the biopharmaceutical manufacturers who are delivering life-saving innovations
3-minute
and
warning.
ignores inefficiencies in the drug supply chain. Excuse me, my phone rang.
John, do you have
Which allow
like 15
minimum-
minutes? If you just want to wrap it up, that'd be great.
Okay. The middlemen scrape off 42 cents on every dollar spent for prescription drugs in the US, and it fails patients by not lowering the price. The price setting diminishes incentive for us to invest in R&D and penalizes us for these efforts. Pfizer stands ready to work with the legislature to develop solutions that help patients better afford their medicine. I'm asking you to reject the price controls and address the systemic problems. Thank you for the work that you do, and thank you for inviting me here today.
Thanks, John. When you say middlemen, who are you referring to? Are you referring to PBMs or referring to more?
Yes, thank you. It's to me, it's a murky middle that involves probably all of the above: insurance companies and pharmacy benefit managers, or PBMs.
And so you believe that dealing with the middlemen would drastically reduce cost?
Oh, could you say that again?
Do you believe that dealing with the middlemen, whatever entities that may be, would help reduce cost?
Oh, I believe it's complex, and that list price of drug is a small part of the overall picture, and that something that's more holistic about looking at pricing and looking about what patients pay at the pharmacy counter would be a more productive way to go.
Thank you. Senator Lesser.
Thank you, Madam Chair. And I guess I can't have a gentleman from in charge of research at Pfizer in front of the committee without saying, first of all, I think all of us want to thank your company for its work in helping us get through the biggest healthcare crisis we've ever had to deal with as a planet. So thank you for that work. One of the things that I'm struck by, though, is obviously we have been the beneficiary of a huge amount of pharmaceutical innovation, but that the places in the pharmacy market where you've seen huge increases in drug spend are not necessarily aligned with innovation. Are there steps that we could take to, more closely align innovation and market rewards? I know that other countries have different approaches. Are there steps that Connecticut or the U.S. could take that would more closely align innovation? And
yeah, that's a great question, and I have benefit and pride in working for a company that's highly innovative. So over 80% of all of the products that we have in development would be, first in class. They would be the first drug to hit that target and bring transformational care to patients. So, we are very much interested in tying benefit to patients and innovation to pricing that might be, that a patient pays for what they're getting. And a big part of that pay is for the innovation that R&D has created. And the interesting examples with the EpiPen, for example, are in stark contrast to that.
Right. So what do we do about that? Because the EpiPen has been the same for 30 years and the price keeps going up. Whereas your company is investing in new vaccines, new treatments. Obviously, we want to reward that R&D, but to my mind, I look at it, the EpiPen, I see a market failure, right? The market is not responding in a way that, either because of regulatory barriers or something, the market is not responding at prices over time. So,
right.
We're feeling frustrated. We just heard folks about EpiPens. How do we fix that?
Yeah, I think it's a great point that there are various levels of innovation, and it illustrates the complexity about what you're dealing with. And so I think it gets back to really an interest to sort through that complexity and look for real solutions. Here's an example of that complexity. I don't know how it would play out in the bill. Is we are looking at a booster dose of the vaccine. We're looking at a new construct that would address the South African variant as an example. Is that a new product, or is that the existing vaccine? Is it going to be easy to solve that problem of treating new variants? Is it going to be very difficult? We don't know the answers to some of those questions. They're very technical in nature, and there's complexity of biology. We don't know how those will play out. So I wouldn't want to be, hamstrung by a legislation that's written for generics, but then is applied to, this very complex type of technical situation that I've tried to outline. So we need to sort through that.
Okay, but you don't have a specific proposal for us to look at right now.
I'm the R&D guy, so I do not. People in the company are, perhaps working on that. So I'll make sure that they are aware.
I think I speak for everyone on the committee, Democratic, Republican, what have you. We think we all want more money going into R&D, right? That is our edge as a country. And I think my frustration, and I suspect that's true of other folks on the committee as well, is that in some cases, there's a lot of rent seeking and not the kind of R&D. And so there are pockets of innovation. You are at the center of one, no argument there, but we want more of that. And I think the question is how to align that. So I don't know if other folks from the regulatory side are coming in after you, but we're still looking for potential options. And I certainly appreciate your testimony.
Yeah, thank you. Your questions illustrate that complexity very well.
With one question, and I apologize, I will turn it over back to Chairman Wood. I understand that there were some manufacturing issues with EpiPens that were specific to some parts manufactured by Pfizer. Do you have any insight into that specific issue?
That's a good question, and I do not have insight into that.
Senator Juan.
Thank you, Madam Chair. Mr. Burkhardt, thank you so much for being here. And the fact that we have a site, head for it and the R&D coming to testify in front of us, we're indeed very honored. And obviously it denotes the seriousness that your organization considers this proposal and impacting your ability to do business. I think it's really important for us to acknowledge and appreciate what you said in regards that there are bad actors that move away from the model of value to innovation and a fair market value for what you do. I really appreciate you saying that, because in talking to the many scientists that I know, you have one mission, and that is to research and innovate life-saving solutions. So I want to acknowledge that and not get lost in regards to some of the bad actors that taint the pool. That being said, I do want to ask, from a standpoint, what do you think would be a alternative solution to containing prescription drug cost, and what has Pfizer done in that regard? Because you are keenly aware, nearly 62 years in the state of Connecticut, and we want to make it another 62 years. But what are some of the concerns that you have and thought processes as an organization to contain cost and deliver care? I'll give you a great example, right? Your work right now in collaborating with state and federal authorities to deliver your COVID vaccine. There's tremendous demand. You could be price gouging on this. You're providing a fair share cost to an incredible community service. What solutions can you share with us from the grassroots and the significant shareholders?
Sure. The kinds of things that that I'm hearing discussed, it gets back. Probably it's key that there's value for the patient, and that patient pays for performance. That the drug delivers the value, and that's what's being reimbursed back to us. We are entirely sensitive about prices that patients are paying at the pharmacy. We are concerned about the nearly half of the cost that the patient pays that doesn't come to us. We discovered, manufactured, and developed the drug or the treatment, and then nearly half of the revenue is going to those who did not. And so I think this gets back to a holistic approach to looking at where does the money go, how can we structure payment for patients so that our drugs can get to them. Okay. And I do not pretend to think that that's an easy problem to solve. It certainly is not.
Listen, Mr. Burkhart, you could find an incredible solution to the COVID vaccine, which to me is tantamount to putting a person in the moon in less than a year. But even you wouldn't want to dare to go into solving the health insurance cost basis. So you're very indeed much smarter than all of us.
As a scientist, I would not.
Well, I, as I said to the governor's staff, and this is a long-standing solution, and it's an entire ecosystem solution. I would simply offer to say this: the best thing I could leave you on this whole conversation, and it is not lost on me the significance of having you testify from your busy schedule, is that the offering by the governor's office to have their door open to you and to the leaders of your organization to engage in a conversation. So the willingness to collaborate and talk about creating solutions is the positive thing that I could leave with you. The other thing I want to acknowledge is the fact that Mr. Ken Hisco, who is your head of government affairs, has been instrumental in being in touch with people. Not only was Pfizer instrumental in being the first out with regards to a vaccine that will save many lives, but your work in collaborating with government entities in your rollout and distribution, you don't hear a lot about it, but your organization and all your various entities work so very closely to make sure that the product is delivered to entities that need them. So I wanted to send out kudos to you, your organization, and Ken for their great work in communicating with all of us. Those are the things that don't get heard. So thank you. Madam Chair, thank you for the opportunity to give a big thanks to a Connecticut institution that's really saving lives. So thank you, ma'am.
Thank you, Senator. Representative Nuccio.
Thank you, Madam Chair. Good afternoon, Mr. Burkhart. How are you?
Yeah, fine. Thank you.
Good. I would like to also reiterate what Senator Lester and Senator Lesser and Senator Wong said, and thank you for the work that you've done on the vaccine. You mentioned something that I wrote down immediately in regard to generics. Do you think your company would be more amenable if this legislation focused more in on the generic market and established drugs, while still giving you the latitude to be able to create a cost structure for R&D for newer drugs? Would that be more amenable to your company, you think?
Look, I probably shouldn't pick and choose parts of the legislation, for that, particularly on behalf of others. But going, back to some of the earlier commentary is, keeping innovation in mind, transformative treatment to patients. Those are the things very much on our mind. And this gets to that complexity that I think we were talking about earlier about pricing, co-pays, middlemen, et cetera. So I think there's something there. I'm not sure exactly what it is.
So I find that interesting, because the stuff that we talk about and that we definitely focus in on is, of course, epinephrine, insulin, drugs that have been around for a significant amount of time, where we've seen the cost structure increase. And there are also drugs that are, they're life-saving, life requiring drugs. So to see those drugs go up as much as they do, those are something that would fall into the generic realm. While innovation, R&D in the pharmaceutical area is probably one of the most important R&Ds that happen. So you don't want to stifle R&D. So you mentioned that you're only seeing 40-something cents on the dollar at where you are. So
we are seeing the 58%.
Oh, you're seeing the 58%. Okay. All right. And would you have, I know you said you're not the finance end of this, but we all talk around the water cooler. So is there anything that you could think of that would help to bring the costs in line? Are you suggesting that you guys should see more, or that we should reduce the costs depend on the structure of who's getting what?
Yeah, I think it's just a convoluted structure between what we publish as a list price for a drug and what the patient pays at the pharmacy. There's a muddy middle there that I haven't studied in great detail, and have uncertainty about it. And I think if we all studied up on that and looked at that with a view to benefit patients, that would be really good.
All right, great. Thank you very much for your answers. I appreciate your time.
And one of those things that you'll hear people discuss is the rebate. So we're under pressure to increase list prices and then rebate to the PBMs, increasingly large prices. Could that go to the patient? Wouldn't that be a winning day for a patient to receive the rebate that we are paying?
I agree. The PBM market, there's definitely room in there, I think, in regard to rebates. So I encourage you to bring that, if your company comes forward to speak to the governor, to bring that idea forward. Thank you for your time. I appreciate it.
Thank you.
Representative Meskers.
Yeah, I want to thank you for your testimony. My sister runs a mesothelioma foundation. The advances in cancer research, the advances in medicine need to be championed roundly and supported profoundly. There's no question that I have a tremendous amount of respect for the research component of the pharmaceutical industry. I think the questions that we ask you tend to be those questions which are difficult beyond belief. We start talking about pricing and we can't figure out what the retail and wholesale price and profit margin is, because there are 4 different hands in the middle. And then we go to international drug pricing and we find that there are material, significant, profoundly different prices for the same drug which is manufactured in India or in China and sold in, you know, New York or London or Geneva or Rome or Toronto. And we all see the same stories about people driving across the border to get basic medicines because they have trouble. So I think the bill represents our attempt to deal with one aspect of that pricing mechanism, which is the pricing of existing drugs, which suggests that, you know, those increases in prices there'll have to be other revenue sources to fund research, you know, which come through U.S. tax policy, which come from grants from the U.S. government, where a lot of that research is ultimately funded and owned. And I just feel that we're at a breaking point, that you're in front of us because the insurance industry is at a breaking point. We talk about a 7% compounding rate per year, or 8%, or 9% on the insurance bill, which is a combination of hospitals and pharmacies. And with those kind of compounded rates, people are going to be spending more. You know, they're going to be spending $30,000, $40,000, and $50,000 a year for private insurance to cover their costs. So until we figure the comprehensive cost containment, we're all in the same boat. And I'm sympathetic to the industry, and I'm sympathetic to the industry's concerns that they're being targeted. But we've got we've got basically three components. We've got the insurance industry, which everyone loves to hate, which is about 10% of the bill. 90% of the bill is split between pharmaceuticals and hospitals. And those costs in the United States are approximately twice what they are in most of the OECD countries. So there will be pressure one way or the other for cost containment. I think the governor's attempt is reasonable on the pharmaceuticals. I'm sure if I wouldn't be standing here supporting if I was in the pharmaceutical industry, but I just don't see a way around it. I think it's a rational approach to try to improve things. But I thank you for your testimony.
Any other questions? Thank you, Mr. Burkhart, for joining us. We really appreciate your time.
Thank you for having me.
Next is Representative Jillian Gilchrist. Is Representative Gilchrist here? Okay, we will go to Paige Mahaney.
Madam Chair?
Yep.
Hi, I'm Colleen Brunetti. I'm with Representative Gilchrist today. I don't know if she has control over the account from her end, but we were here and waiting.
Okay, you can go and you have 3 minutes. Thank you.
All right, thank you very much. Good afternoon, everyone. I'm here to speak in support of Senate Bill number 1003 regarding copay accumulator models. Before I start, I just want to take a moment to thank Representative Gilchrist for her unwavering support to me over the last 3 years on this issue, to the committee for hearing from the public today, and to Senator Anwar for putting forth this bill. 13 years ago, I was diagnosed with a rare, progressive, and incurable lung disease called pulmonary arterial hypertension, or PH for short. Back then, average survival rates gave me 3 to 5 years to live. Since day one, I've been under the care of excellent specialists at UConn Health Center. I've beaten the odds by taking a variety of aggressive and very expensive medications. Up until 4 years ago, I was able to access the incredible cost of these medications using a variety of assistance programs, including manufacturer copay cards. To give you an idea, before insurance, my medications will easily fall in the $250,000 a year range, and that's before I see a doctor or get a test. All of that changed when my insurance company flipped to an accumulator model while we were also on a high deductible plan. Suddenly, the medications I could once afford became more and more out of reach. My personal out-of-pocket costs ballooned to $7,400 or more, all due in January for one copay of 1 month of one medication. Because my overall yearly costs are so staggering, even if I had implemented that copay card and it wasn't applied to my high deductible, I was now on the hook for that money no matter how you sliced it. Insurance companies have found not only a way to squeeze more money out of costly patients like myself, but from where I sit, it looks like they are double dipping. They now fully benefit from the copay card amount plus my high deductible. I'm no longer the beneficiary of the copay card program as intended, and instead a huge and very wealthy company is. To me, this feels like a new way to discriminate against those with costly pre-existing conditions. It feels morally wrong to say the least, but it remains legal unless we change it. I'd like to look at some overall issues around copay accumulators to the public at large. I've reviewed the current language on the bill and I'm heartened by its broad nature. I want to emphasize that some bill language in other states has referenced generics, and I want to encourage the committee to continue not to do so. In the rare disease space, generics rarely end up being truly cost-saving for patients, and we in the PH world have seen several patients physically impacted for the worse when forced to make a switch. In my 4 years working on this copay issue, I've often heard insurance companies, pharmacy benefits managers, and manufacturers try to banter back and forth over high cost of drugs, ballooning healthcare costs, and finger pointing over who is ultimately responsible for this part of our broken healthcare system. My response to this is that conversation is misplaced on this issue. When that is the focus of these copay accumulator conversations, the patient remains the collateral damage. If we want to address industry costs, I encourage them to do so elsewhere, like in other bills discussed today. The job here, specific to copay cards, is to protect and support the patient. Should copay accumulators stay in play, there's a real fear that patients will be forced to ration their medications, abandon prescriptions, and ultimately increase higher risk and costs because they can no longer afford their medications. There's an even higher risk of these issues for vulnerable and underserved populations who already have significant income and access challenges. From my research, I know you'll find a great deal of public support to do away with copay accumulators. In conclusion, I want to thank you again for the opportunity to address you today and wholeheartedly encourage the passing of this bill doing away with copay accumulators. Connecticut has long taken a lead in proactive patient protections, and we have the opportunity to do so again now, helping countless individuals and setting precedents for states around the country to follow. Thank you.
And I just want to say, I'm sorry I was late. Thank you to the committee for allowing Colleen and myself to testify.
Thank you, Representative Gilchrist, and thank you, Colleen and Ms. Bernardi, for your story. Do we have any questions? Representative Farrar.
Thank you, Chairwoman Comey. Colleen, thank you so much for being here today. I know that you and Representative Gilchrist have really led the way, and with Senator Anwar's bill, I am hopeful that this year could be the year that we not only help you, but so many folks in your particular situation, which again, at the end of the day, you're just trying to get healthcare and stay alive, and that should be a simple approach. I had one question because you referenced some other states and the language that was in our bill, and I wanted to make sure to clear up why it was important, it sounded like to you, that we do not include generics in this bill, since that does show up in other states.
Sure. So let me have some data for you here. Let's see. So generic drugs, according to NORD, the National Organization for Rare Diseases, account for nearly 90% of all prescriptions written. But the manufacturer coupons incentivize brand name drugs, the fear that is the case. The majority of copay assistance programs are for drugs that have no generic equivalent. So in the rare disease space, you often either have no treatment or only a couple, and there are not generics. So allowing for generics doesn't necessarily help in that sense. And they go on to say that the 13% of branded drugs for which generic equivalence products were available accounted for only 0.05% of all prescription fills. We have also seen time and time again, because there are generics for pulmonary hypertension drugs now, that patients either not saving significant amount of money that would impact their overall ability to pay, or in fact, their costs have gone up substantially because not on a copay accumulator model, the copay cards no longer exist with generics. So it's a fairly nuanced issue, and we just have not found that relying on generics to cut costs for the rare disease space has been helpful.
Thank you for sharing that, from your own personal perspective. And then, as you said, what's been seen nationwide, and as someone, who is not in, the circumstance that you're in at this moment, and is just getting to know, as some other members on this committee might, about copay accumulators, how would a patient even come to know that these exist?
So it very much seems to depend on who your insurance carrier is. And what we know for certain is that it's not always very transparent. So if you called and said, I'm shopping plans X, Y, and Z, do they have a copay accumulator attached to them? It might not be called a copay accumulator. I found 3 different companies with 3 vastly different names for them. So the rep may very well say, no, we don't, when in fact they have something that is the equivalent. So it makes it very difficult for patients to make an informed decision and choose the most cost beneficial plan for them.
Thank you for noting that, because I think in navigating healthcare, you know, we often lose sight of sometimes not just how difficult it is to seek care, but sometimes, as you noted, that things could be called very different things with different providers, and we could be really missing how this can play out in our own lives in regards to cost of care. I just want to thank you, Colleen, again for persisting in this bill, not just for yourself, but so many others. And I really look forward to supporting it and encourage my colleagues to do the same. So thank you, Chairwoman.
Thank you, Representative. Senator Lesser.
Thank you, Madam Chair, and thank you for sharing your story, and to Representative Gilchrist for being such an incredible advocate on this issue. I do want to just also note, you mentioned that Senator Anwar introduced legislation on this, and that's true. But I also wanted to point out that Senator Looney, who's the Senate President, introduced this specific bill as well. So I just wanted to make sure that Senator Looney got some credit for that as well. But it's all good. There was some comment that we got that from industry that said that copay accumulators were prohibited a boon for prescription drug companies. Obviously, this is a fight between drug companies and PBMs and insurers. I didn't know if you had anything for us to sort of get our heads around this, because we see patients like you who are obviously hurt by this practice, and always the fear whenever you're talking about health policies. Why is it that consumers are in the middle of these guys?
Well, we have perhaps the quietest voice at the table quite often. It's difficult to get a patient who will be able to come and do this and speak to folks like yourselves. We don't have large lobbyists, and the numbers are so staggering that I think that the reality of what it looks like for the average American family, or worse, the low income family, is hard to catch unless you start to hear individual stories. But to me, as a patient, all I know is how this hurt my family and what it did to our budget. And I don't have a lot of sympathy for the finger pointing, because as it gets batted back and forth, we're not going to solve high and ballooning drug costs by addressing copay accumulators. We're going to help patients and help families by addressing copay accumulators. And so I would like to see the conversation very compartmentalized, because yes, there is absolutely a place to talk about all of those things, but the issue here is what is happening right now to Connecticut families.
Thank you very much. Thank you for your testimony.
Thank you.
Thank you very much. Any other questions? Well, thank you for coming to visit us, and continue your good work advocating for this and other policies that will hopefully improve the quality of care that you get and affordability. So thank you. Thank you, Representative Gilchrist.
Appreciate the time. Thank you.
Senator Lesser, would you like me to continue on as chair?
You're doing a great job.
Okay. Okay, next up, we have Paige Mahaney.
Yeah, hello. Hi, I'm here.
Welcome.
Great to see you.
Go ahead.
So good afternoon, Representatives Wood and Pavlik D'Amato, and Senators Lesser and Wong, and members of the Insurance and Real Estate Committee. My name is Paige Mahaney, and I'm head of research for the U.S. for Boehringer Ingelheim Pharmaceuticals, and I'm here to testify in opposition of Sections 6 through 8, House Bill 6447. Boehringer Ingelheim is a private company owned by the same family for more than 135 years. We discover and develop innovative medicines for humans and animals, focusing on patients with the highest unmet medical needs. BI established its US headquarters in Ridgefield, Connecticut in 1971, and it's the largest headquartered pharmaceutical company in Connecticut with more than 2,000 employees in the state, and we are adding jobs in R&D over the next 3 years. R&D is at the heart of our company. We reinvest approximately 22% of our net sales back into research and development to ensure future innovation for patients. This bill will not help patients. I get it. Patients are exhausted with the health insurance system. I hear it from my friends, I hear it from my family, but this bill will not impact what a patient pays at the pharmacy counter. It oversimplifies an extremely complicated healthcare system. For the vast majority of patients, the cost of a drug is controlled by their insurance plan. So a price cap on pharmaceutical companies will not reach the patient because, as you know, patients don't buy drugs from the pharmaceutical company, they buy them from the pharmacy. However, the unintended consequences of this proposal are significant and could really hurt patients because it could stifle future breakthrough therapies. Therapies that are being developed today truly have the potential to transform patients' lives. However, R&D is costly and lengthy. It takes more than 15 years and $2.5 billion for one drug to be discovered and be launched. These types of bills risk industry investments in new therapies for the patients who need them the most. For example, Boehringer Ingelheim is pursuing research in schizophrenia, a patient population with very high unmet medical need. This population also faces very significant socioeconomic challenges. Incarceration rates are very high, and many have a hard time finding jobs and staying employed. In addition, many are in the Medicaid population. Medicaid has penny pricing. This means that we make only pennies on medications sold in Medicaid. And in some cases, believe it or not, we actually pay Medicaid to ensure that our medicines are available to patients. With bills like these, we might be forced to reevaluate our investments and redirect them away from patients like those with schizophrenia who truly need them. So in closing, I'm actually very proud of our lab scientists at BI. I cannot tell you how diligently they've worked advancing their research, even at the height of the pandemic in their labs. And they've also worked very hard to identify therapies for COVID-19. It must be said that without the dedicated researchers in the pharmaceutical companies, both in Connecticut, and my colleague from Pfizer spoke earlier, and around the world, our future in a world with COVID-19 would look very different. I want to thank you very much for your time, and I'm happy to answer any questions.
Thank you very much, Ms. Mahaney. Any questions? Senator Huang.
Thank you, Madam Chair. You're doing a great job. Great to see you up there doing this as a chair. Dr. Mahaney, thank you very, very much. And I appreciate you acknowledging Pfizer. And I know in the scientific arena, the competition is very real, but the respect for what you do as colleagues is even more sincere. So I appreciate you acknowledging. But please tell us, what are the things that you are doing as an entity, as an organization in fighting COVID? Because it's not just Pfizer with a vaccine, but it's all of our pharmaceutical and biotech companies that are advocating and supporting in this united fight.
Yeah, so thank you very much, Senator Wong, for that question. First of all, I think back, and I think it's really important. I think back when the pandemic first hit, and I don't know about you, but I was afraid to go to the grocery store. I was afraid to open the boxes that came from Amazon that were sitting outside because I was afraid that I might get COVID from the boxes. But the scientists in our labs came into the lab every day, risking, their health in order to advance the therapies, ongoing research in oncology, ongoing research in immunology, and for COVID. So we have an antibody, an inhaled antibody in the clinic to combat COVID. And we're also looking for antibodies that could combat the variants, the South African variant, for example, the Brazilian variant, for example. And in addition, we have therapies in the clinic to combat the acute respiratory distress syndrome associated with COVID as well. So our tissue plasminogen activator, for example, is in phase 2 to block the blood clots that you've probably heard about associated with COVID-19 and acute respiratory distress syndrome. So we are working very hard along with many of our colleagues around the industry to just help patients through this very difficult disease.
And my second question is you are a family-owned business.
Yes.
The two families, Boehringer and Ingelheim, German-based. So obviously, as a multinational organization, and in Europe, there is pre-established kind of drug control systems and cost basis, as well as a unique health insurance kind of a management protocol. You have a foot in both systems. I would very much welcome your perspective to see how we could learn from your German parents and counterparts to be able to translate some of that prescription drug cost savings and state kind of collaboration to fixing this problem, because we want to work with you, not simply blame you.
Thank you very much. I appreciate that. So I know that it's really tempting to compare our systems, to compare the German system, for example, with the US system, but they're very, very different. And I have to say also the same disclaimer as my Pfizer colleague, I'm also the research person. So I've been working in pharmaceutical research for 25 years. So I'm not as close to this question as maybe some of my colleagues. But still, I do know that the German system has a single payer, and they lack many of the, what did my colleague call it, murky middlemen that we have in the US. So I think that that's one very, very important component. We have a much, much more complex system. But the other thing that I think it's really important for everyone to understand is that the German system determines the value of drugs at the forefront for patients. And many drugs that we have on the market in the US are simply not available in Germany. And I think that this is very dangerous as we are entering more and more a world of personalized medicine. We are talking about in oncology now, but even beyond oncology, we want to match the right drug to the right patient. And if you think about a disease, let's say, let's think about a disease like cancer. There's not one type of cancer. There are so many types of cancer, and we want to match the right drug for you. So I think it's very important to understand that the German system determines which drugs can be available based on value to the patient. And let me put this into perspective. My husband is on cholesterol medications, and these are not personalized, but my husband's on cholesterol medication, and he had to go through many different statins in order to find the one that worked for him. He finally found the one that lowered his cholesterol, and the insurance system that he was on removed it from their formulary. So as soon as he was only able to be on it for a month before it was removed from it being available to him. And this is kind of a system that we might want to think about in Germany because they determine value in that way.
That's a very insightful comparison, and it's important for us to get comparisons. That being said, there are tremendous lure, and I studied and understood that the public option or a state takeover or a one-payer system is alluring, and there are efficiencies, but at what cost to innovation? And what has made the United States system so unique in the world is the fact that our system, and maybe it is a factor to our cost, but we have the innovation and the desire to create the best, the fastest, and the pursuit of excellence in healthcare. And that's why sometimes when we talk about creating solutions and containing costs, we talk about it, at least I talk about it a lot, that healthcare is deeply personal, that
It
it
is.
doesn't fit in a theoretical analysis. And so I appreciate that contrast, but because it's important to point out that when people make the promises that you will get the same level of care, the
Right.
same providers, the same type of physicians, the reality may be the marketplace says no. And that can't be a promise that we're making to overpromise and draw people in, because the reality of the marketplace has its effect. So I appreciate that. And I'm going to say it as a compliment, as I do with every research scientist. It must be obviously very, very important to BI to have their chief scientist come and testify in front of a bunch of legislators. It'd be like going to the dentist for me, I guess, in some cases. So I really want to extend my appreciation and also offer that in the governor's office testimony earlier, that they are receptive and open to a dialogue with all of our important businesses, and particularly for my colleagues in Western Connecticut, Pfizer being one of the biggest employers and economic contributors there. It should not be taken lightly. So thank you very much, and I appreciate your time. Thank you, Madam Chair.
Thank you very much.
Thank you, Senator. Senator Lesser.
Yes, thank you, Madam Chair, and thank you to the doctor for your testimony today. Appreciate the discussion. One thing I missed in your initial testimony, you did mention steps that Boehringer Ingelheim might take to reallocate resources if this bill were to pass. It was some reference made to the Medicaid program, and I just wanted to see if you could sort of expand on what you said. Is that should we interpret that as a threat? I'm just trying to
No.
what you were talking about.
So I was just trying to use as an example, and for patients where the health economics, such as patients with schizophrenia, in the example that I used, there is that risk. It's certainly not a threat. We're committed to psychiatric diseases, and actually BI is one of the few pharmaceutical companies that has actually remained in research in psychiatric diseases for the reasons that I described earlier. So I just use that as an example. Some of the solutions, I agree with my colleague from Pfizer as well. I think value-based contracting is very attractive. Again, we want our drugs to work in the right patients, and we think that patients should pay for performance. And I also very, very much agree with my colleague from Pfizer that, we have to provide very high rebates to some PBMs just to get our drugs on their formularies for patients to have access to them. And those rebates are not passed through to the patient. They see none of those rebates. And if that could be changed, I think it could be a huge benefit to patients.
So in 2011, Germany adopted, I hate to pursue my colleague Senator Wong's line of questioning about the German system, but because he did raise it, I have to ask. Germany passed the Pharmaceutical Market Restructuring Act, and there is a name in German that I'm not going to even begin to attempt to pronounce. AMNOG is the acronym that allows manufacturers to freely set the prices of newly authorized drugs in their first year on the market, but then it does what you just suggested, provide a value-based contracting through what's called a benefit assessment during this year. And that is the basis for price negotiations between manufacturers and representatives of the various nonprofit health insurers in Germany. Is that model something that could work here? There don't seem to be evidence of increases in launch prices, and I don't know if drugs have been pulled off the German market. But is that something that would be helpful? As you suggest, we should look at value-based contracting.
So I'm not 100% familiar with that case, but I do think that you have to be careful how benefit is assessed. How is value assessed? And I believe in the German system, value is assessed based by the government, not based on the patient's value. And we want the value-based contracting pay for performance being based on, we want the drug to work in the patient, not be assessed by the government. And that's very, very dangerous.
I guess I don't know who would. Obviously, everybody wants a drug to work in a patient. That makes sense. But are you saying that the patient is going to be setting the prices? I'm not sure how would value-based pricing work?
Well, it's overall performance of the drug across a patient population. I don't totally understand how it works. I'm sorry, Senator Lisser, but again, I know in Germany they have a comparator for the drug, and that comparator can be quite arbitrary. So for example, for an arthritis drug, the comparator can be physical therapy, not another drug on the market. And they could use that as a comparator to determine value. So I think it's very complicated. It seems on the surface like it's attractive, but there are details there that really don't benefit the patient.
Well, thank you, Dr. Mahaney. I appreciate it, your testimony and the discussion, and I have appreciated the conversations I had with a number of folks over at BI, and
great.
Look forward to more testimony. Thank you, Madam.
Very much.
Thank you, Senator. Representative Davidson, thank you for your patience.
Of course, thank you. Nice to see you there, Vice Chair, Acting Chair. I just wanted to follow up. I unfortunately didn't get a chance to listen to Pfizer's presentation because I was on another committee meeting, but so I'm going to go back and listen to that. But thank you for coming, Dr. Mahaney. And I'm just wondering, has your organization done studies across different jurisdictions around the world where they can prove that restricting drugs is hurting patient outcomes? I mean, do you have any? I guess one of my concerns is, I've been CFO of very small pharmaceutical early stage R&D companies, and I understand how much we put into companies to find first molecules that work and then take it to the next stage. And it seems to me what I've learned in my time living in the U.S. is that the U.S. is funding, the global R&D for all drugs. And, what I'm hearing from you is that while other jurisdictions are limit what drugs that patients can have because of their setup in terms of how their insurance is set up in terms of either single payer or public option or private insurance. And so I'm wondering, is there any sort of studies that show that patients' outcomes are not at the optimum because of this? And have you been able to do any studies as a pharmaceutical company?
So thank you for your question. I'm not aware of those studies, and many of my comments are more anecdotal. So please take them that way. But coming back to the right therapy for the right patient, I think it's very, very important to go down that path. I've heard of anecdotal stories about, oncology drugs not being approved because they only gave 5 months, 6 months more survival. If you are a cancer patient and you could benefit from that patient and get 6 months more progression-free survival, for example, I think that's a benefit to you. But in some jurisdictions, they don't have access to those types of life-saving, even if it's only for a few months or a year, life-saving therapies. So again, I want to come back to the individual patient and the choices that they have to make.
So in kind of going down that road, do you think that the pharmaceutical company should have global price structure for maybe sort of standard drugs that is equivalent no matter which jurisdiction you're in? And then premium drugs for those that can afford to pay for the better medication. Is that what you're suggesting?
No, I'm not. I'm not suggesting any solution across countries. I'm just warning of if we go down some paths, for example, the German system, that our selection of drugs could be severely limited, and you might not be able to get access to the drug that will benefit you or even save your life. And so that's to me as a researcher, we focus on the value of that our drug, the benefit that it really gives to patients. And we do not want to discover drugs that only incrementally change patients' lives. We're really focusing on very transformative improvements in their lives. And in many cases, we are developing drugs where patients have no other options, where access to our drug is literally the difference between life and death. And so that's, from a research perspective, that's what drives us to get up in the morning every day and go into the lab, even though we face very, very high rates of attrition.
Yeah, well, thank you for your work that you do. It is so important. And, you know, we've all seen when the world comes together and develops a vaccine, it can be done. And I'm really hoping and optimistic that the world can come together and find a cure for cancer or something else, because I do think if we all work together, it would be great. But, you know, I still have an issue with the fact that, you know, because I live in the US, I have to pay more for my medication than everybody else in the world. You know, I spent quarter of my life in the UK, and I never had an issue with receiving subpar drugs because of the NHS system. I was had better treatment in many instances that I've had here in the US. And so that's really the issue that I have, is that we have to pay so much more. And, you know, salaries aren't significantly more, and, you know, our health insurance doesn't cover it. So, you know, I'd like to figure out how we can get there and really make a meaningful difference to Americans and to people that live in Connecticut to lower their drug cost. You know, it's a huge concern. So thank you for your testimony. It's all food for thought.
Thank you. Thank you.
Thank you, Madam Chair.
Excellent discussion. Representative Meskers.
Thank you very much. Thank you, Dr. Mahaney, for your testimony. Your concern in relation to drug prices and the ability to raise prices, I assume, is fundamentally focused on your ability to do your research and fund your research. So you put us all in a horrible dilemma, basically. Your reference in the insurance industry and in medication and formularies actually speaks, to my mind, against your position, in that the formularies get shifted because the price of the underlying medications goes up, which is fundamentally what we're arguing, or you're arguing for, is to be able to use the baseline medications, raise the prices to fund the research. I'm not making a value judgment on the drugs you're researching or the qualities of what you're trying to achieve. The problem in the model is that I have people who have multiple sclerosis, who are constituents of mine, who finally found a stabilizing medication, and whatever pharmaceutical company owned it decided they needed to raise the price to a level that the insurance companies decided they wanted to kick that medication off the formulary so that they could control the rise in insurance costs because of what they had to pay for that medication. So I think we're talking about two fundamental issues. One is the ability of somebody like yourself, shall I say, the Mother Teresa of doing research, bringing good deeds to life and trying to save people in new and innovative ways. And what we're trying to deal with on the other side is, how do I prevent Representative Phipps or make sure that he can afford his EpiPen or his insulin or his basic medical costs. And so you're kind of in my crosshairs, not because of what you do, but if our pricing model on funding research and innovation is either buying up or developing baseline drugs and raising the price 7 to 10 to 15% a year to fund the research. And I'm not telling you I'm looking to outlaw it. What I'm saying is it's a fundamental problem if I'm going to put the research funding on the back of my retail consumer, and which comes through the insurance bill that goes up by 7 to 10% a year. We end up with a structural issue that's just horrible. That to your mind, we're not going to solve that schizophrenic issue, and to my mind, the guy with insulin is going to end up with a diabetic attack. So, and I don't think either of us has that answer.
No.
And I think your concern is maybe that I'm using a blunt tool to try to attack the issue, but we'll go back to the fundamental. When I look back at it, and I don't think it's the governor was my clarion call, but the governor said 10% of my cost is insurance, but the insurance company is just pushing water around the squeegee around the drain, and 90% of the cost is the hospitals and the pharmaceuticals. So I have to figure out how I do the pricing model. And then when I step back, akin to Representative Dathan's commentary, I've got a 40 or 50% price differential between Europe and the United States for my pharmaceuticals, and the outcomes are not materially different. Now that doesn't say I won't accept a private option. I think a private option is very interesting. The issue is when I can import my drug from London, or I can import my drug from Canada, because they're all manufactured ultimately in India and China. If I can get my prices to the same level of the rest of the free world, then I kind of feel like I'm on the competitive edge where you're finding your funding, and hopefully you're raising your price across the globe to get the pricing for the revenue to do your research, versus I'm telling my guy down the block or the lady down the block with multiple sclerosis, you're going to lose your medicine or your formulary because we've got to fund it. We've got to fund the research out of what you're paying for the medicine, not the guy or the lady in London or in Geneva. And that's the structural issue. So this may not be the ultimate solution, but that's why my dilemma is. And there's nothing I want to say negatively about how you do your research, what you do, how you price. It's the way the market is set up in the United States that this is a solution to raise funds for capital research. The problem is it's on the back of my constituents and the constituents of the United States. And I think it's a fundamental flaw. But, I think what we can do to facilitate your concerns, I think we should have that conversation. If there's a way we can talk about where you see the problem, is it a blanket objection to these caps in drug prices, or are you worried about your innovation?
Oops, I think you went on mute, sir.
So, or is it a concern about, I'm wondering if the fundamental concern is on long-term drugs that have been developed, that you're capped on what you can return, or is your concern about recouping your investments on a rollout, and therefore that you can't take the price hikes as the drug reaches, because there's a question about mature drugs versus innovation.
Yes.
That we may need to address. And if we can look at something like that, I don't understand why I want to pay 20% more for an aspirin or for EpiPen or insulin. But if you find a schizophrenic drug that we're still delving market share penetration, recovery of your cost, I think that's a separate dialogue to have. So I'd love to have that.
Can I
Sure.
respond, please?
Yeah.
So
Sure.
I think our concerns, and this is a great dialogue, and I please use us as a resource. Any of you, we'd love to have some of these conversations. We've got a great team that has more answers than I do. But So, but my concern is twofold. Number one, we want solutions. We do want solutions, but we do not believe that this bill will make a difference for patients. Again, because how we set our prices, and don't get me wrong, we don't want to do, I think the EpiPen example is a terrible, terrible actor, and we're not asking for license to be able to do that at all. But we do want to find solutions that the patient will feel. And we do not think that this bill, I'm sorry, will make a difference to what the patients pay at the pharmacy. That's number one, because as a researcher, I'm absolutely focused on what benefits the patient.
Right.
So that's number one. Number two is I just want to tell you that the emerging science that's available for new drugs, again, remember the horizon, 15 years, but the new science that's emerging right now paints a picture of just what's possible for drugs in the future. Regenerative medicine, for example, that could become a reality in the near future. Meaning, let's say for osteoarthritis, many of us have debilitating back pain, knee pain. Instead of having to get knee replacement, you could have a regenerative approach where we inject maybe a protein into your knee and you regenerate cartilage. That could be a cure. Regenerative medicine for pancreatic cells, to regenerate the beta cells in the pancreas to cure diabetes. I mean, we've talked about these things as kind of science fiction for many years, but this science is on the horizon, and we don't want to quash this innovation that could be available to patients. And my researchers are working very hard to bring this innovation to patients, in the next few years or next 15, 20 years. I don't want to say few years, but in the next span of a drug research and development.
We're not disagreeing at all. I think that but you put me in the dilemma.
I know.
Because the dilemma is, what do I do about drug prices today? And your answer to me is, how do I fund my research or question? And I understand that. So my point is, I have a dilemma that I'm going to fund your innovative research on the back of the guy who needs his insulin shot or his EpiPen.
Yeah,
And it's
I
not
think
you.
that they're
You're
two.
not manufacturing.
Yeah,
What I'm saying is,
I think it's two different buckets, but I just think that.
so we have to figure out how there needs to be a dialogue about where we go with.
Exactly.
If you have an issue with pharmaceutical caps and prices, I can't accept a blanket ability to raise every pharmaceutical price by 7 to 10% a year to fund research, because that's telling everyone who has base needs that there is an issue about whether or not they can afford that medicine. So that's the dilemma. I don't expect you to have the answer.
Thank you. Thank you. I do not. But I do say that the system is hugely complex. And I agree with my colleague from Pfizer there. And there's a lot of people in the middle that we don't see.
Like, look, and again, I salute you for the research, what you bring forward, the hopes you bring to us as a people, to us as a nation, and to the human race for that type of research. There's no way I could be critical of that. I just have to figure out whose pocket we take it out of and how we can do it efficiently. So thank you.
Thank you, Representative Meskers and Dr. Mahaney. Thank you for visiting with us, and we look forward to continuing the conversation.
Wonderful. Thank you so much.
Okay, so next on our list, we have Ted Doolittle from the Office of the Healthcare Advocate. Following Mr. Doolittle, we will have Susanna Craig, and then we will be into our list of the public names, which we are at number 13 out of 44. So have a bit of a ways to go. Go ahead, Mr. Doolittle. Thank you.
Thank you, Madam Chair, and good afternoon, Senator Lesser, Representative Wood, Senator Huang, and Representative Pavlak-D'Amato, and other honored members of the committee. I am the head of the State Office of the Healthcare Advocate. And for those of you who haven't heard of it, I just want to tell you briefly what we do. We help people like yourself, your loved ones, who are having trouble with any type of health coverage, you're fighting with your health insurance, be it Medicare, Medicaid, Husky, you've got a claim denied or something of that nature, you got a billing problem with your insurance, we can help folks in Connecticut with those problems free. We have a staff of nurses, attorneys, paralegals, and others who are here to represent you. So if you or a loved one is struggling with any of those issues, please don't hesitate to contact us. And I know that the members of the committee are familiar with our services. It's been a long hearing already, and you have a lot more to go. You've had a rich discussion, and I know you have more. I just wanted to highlight really quickly two items that are in our submitted testimony. One with respect to Bill 6586, and the other with respect to Bill 6447. Just real briefly on the 6447, I've made this point to some of you in person, and I'll make it to you again in public today. Reinsurance is a difficult tool to use properly. If it's used alone without in conjunction with other supports, it can result in financial harm to those who are subsidized on the exchange. That is to say, it can result in more out-of-pocket expenses for the folks between 250 and 400% of poverty. So please, as you're considering reinsurance, I'm not saying don't do a reinsurance. We have to design it in such a way that you bring supports to the people whose out-of-pocket costs are going to be increased. That's my point on 6447. Be careful with reinsurance. You don't want to harm our subsidized enrollees. The second point, again brief, with respect to 6586, which deals with prior authorization. I want to leave the committee here with one simple question. What is prior authorization and why do we have it? And I'm asking you, why, in fact, do we have utilization review? What I mean is, why do our treating doctors get second guessed and indeed vetoed by other doctors who you're secondary to the real mission of the medical profession. But I don't want to cast aspersions on anybody. I meant that just as a humorous comment. What I'm saying is the insurance companies, why, if they don't trust a doctor, should they keep that doctor in network? That's the question I want to leave you with. Why, if the insurance companies don't trust a doctor, should that doctor be in network? That is why, if you're discussing prior authorization and things of that nature, you need to really go deeper. And this bill just gets into the issue a little bit, scratches the surface. You need to go deeper and think, why do we need our doctors to be second guessed by other doctors? Our suggestion at OHA is to move away from the modern scenario of utilization review toward utilization review that's based at the provider level, not at the claims level. In other words, the insurance company should not deny individual claims. They should look for practice patterns that are unacceptable, and then they can educate that doctor. If that doctor changes the practice, good, they can stay in network. If that doctor once educated that he or she is not following the best practices, then remove that person from the network. So that's why prior authorization is ripe for review. I commend the committee for taking up the bill and thinking about it, but go deeper and think about whether you need to delve even to the next level down and determine that perhaps Connecticut should start to experiment with some new types of no denial or low denial health plans where the insurance companies go ahead and trust the doctor. If the doctor deviates from practice standards, then educate that doctor. And if they don't, if that doesn't result in the result that you, the insurance company, want, then remove the doctor from that network. That takes the patient out of the equation. The patient is no longer acting as a pawn between two usually large, financially powerful organizations. On one hand, a provider organization, and on the other hand, the insurance company. Those are my comments that I want to leave you with. Again, I know it's you've got a lot of work ahead of you, but I just wanted to highlight those two thoughts, both of which are in our testimony, but I wanted to take a chance to pick them out for you. Thanks so much, Madam Chair. I'm available for any questions.
Wonderful. Thank you very much for your testimony. What you're suggesting is thinking outside the box, and that's what we love about the office. Can you, is this being done in other places? Is this something that is there in other marketplaces or in other states, that sort of thing?
Well, it's first cousin to a lot of things that you might be more familiar with. Centers of excellence, for instance, where the insurers are moving people to the what they know is a quality institution. Tiering, you had a discussion about tiering before. Where again, you're trying to increase the cost for folks that go to lower value care. This is the same animal, Representative Comey. It just takes it a next level further and takes the patient out of the equation, makes it so that the providers are getting utilization reviewed, but not the claims. That, to directly answer your question, while it's related to those other concepts, it's not being discussed. I think it's incumbent on Connecticut. We claim to be the insurance capital of the world. We should take these innovations seriously and show the world why we're called the insurance capital. So that's my answer.
Thanks very much.
Thanks for all your work. You guys are doing a great job, great service to the state. And I appreciate everybody's time this afternoon.
Thank you. Senator, stick around with Senator Wong. You have a question?
I do. Thank you, Madam Chair. And Ted, thank you for being here. I did have a little trouble hearing you, but I'll go begin first by offering a public service announcement touting the Office of Healthcare Advocates and what great work you and your staff do to help those in need. You are one agency when we talk about sometimes the bad PR relationship of insurance companies. You are the one entity that we recommend to addressing and redressing concerns. So thank you very much, Ted. Can't say enough about the great work you all do. That being said, you've pointed interesting on an affordability issue. Are those individuals whose income levels are 250 to 400% above the federal poverty level, that kind of make them ineligible? Can you talk a little bit about that dynamic and where the real pressure points of affordability is really kind of focused on? Because sometimes we present in our presentations and our advocacy a different dynamic in population, but talk about that. The population is 250% to 400% above the federal poverty level that really is impacted by the affordability issue.
Yeah, thank you for that. I removed my headphones in hopes that perhaps you could hear me a little bit better.
Clear.
So the way the ACA is set up is that Medicaid is the pre-existing solution for our families with lower wealth. the Affordable Care Act expanded that. It raised the income level, in other words, added people to Medicaid, and that's where the bulk of people that are covered by the ACA come in. But then it starts to, after that eligibility phases out with income, you get into what's called the subsidized population. And that's this population that I referred to that ends at 400% of poverty. And by the way, 400% of poverty, it can be up to 104,000 for a family of four. So it's a lot of Connecticut, if not most of Connecticut. The folks in that band, Senator Huang, have to pay either copays and deductibles or premium or both. And they have to pay more and more as they go up to 400. And then at 401% of poverty, so if you're a family of four making 105,000 instead of 104,000, you get nothing. It goes down to goose egg. But the point is, you're asking about that vulnerability of the population that is subsidized. That's families that are probably double income, working hard, but they're buying insurance on the exchange. I'm on the exchange board. I regret to say that there's not even a low deductible plan. I mean, all the plans are above the IRS limit for high deductibles, and that gets pretty doggone unaffordable when you get a family of four. So that's the subsidy population that winds up through the complicated method that the ACA uses to establish premiums. They get hurt if the overall premium goes down. And I don't want to go into why, but that's why if you're doing insurance, you have to bolster that with some new support to the families between 250 and 400%, because they're going to get hurt and in some cases seriously financially hurt.
Thank you, Ted. And you know, you were getting usurped by a attractive baby in the backdrop. So thank you very much for that clarification. I will also close by thanking for your openness and your collaborative in trying to find solutions, where you acknowledge Senate Bill 842 as well as the Republican bill of Senate Bill 1006 and the governor's bill of 6447. None of them presents a silver bullet in your testimony. All of them have merit, and that truly for us, all of the strategies need to be collaborated to create a better solution. So I want to acknowledge that your open-mindedness, your offer of taking bits of every good piece, that not one side has all the solutions. This decision is far too important for us to be able to make a mistake on. So I appreciate, Ted, all that you do, and please extend to your staff or what they do in the Office of Healthcare Advocate. Thank you very much. Thank you, Madam Chair.
Thank you, Senator. Everyone else all set? No more questions? Thank you so much, and we look forward to continuing to have dialogue with you throughout our public hearings. Okay. Next, we have Susanna Craig.
Susie Craig from Mental Health Connecticut here. Thanks to Senator Lesser, all members of the committee. Want to give a special shout out to Rep. Dathan for her support on HB 6588, the provision around peer support services. So I'm going to help shift the conversation a little bit, but I do want to say that I appreciate the theme of today of innovation and health equity and cost savings, and really digging deep into ways that we can improve the quality of healthcare in Connecticut all around. I think no one would argue that mental health is not just a priority for those who are receiving services, but it's important for all of us across the state, especially after the year that we've all been coming off of. So Mental Health Connecticut is a private nonprofit. We are community-based. Everything we do is recovery-oriented and trauma-informed and evidence-based. So we're not the only ones. Many agencies and other groups across Connecticut are rooted in this approach to mental health care. And if you don't know about peer support services, although I know many of you do because we've been advocating for this for quite some time. And I want to thank you for your support over the years around that. Peer support is, an essential part of healthcare teams. It's one that is something that Connecticut is really behind the curve on. So the provision in this bill would allow for a task force committee to be formed to study the reimbursement of peer support services in Connecticut, and would also obviously include people with lived experiences and people from the peer support community to make sure that we arrive at decisions that will really help expand peer support in healthcare teams. I think, like I said, Connecticut is behind the curve here. Over 41 states make peer support reimbursable. This is something that is work that is happening in Connecticut. But as far as ensuring that we elevate the importance of peer support as a workforce, which, obviously benefits the workforce as well as the people that need the services. One thing that is really important to understand is that when we're talking about decreasing costs in healthcare, peer support services have been shown I can share many case studies and a lot of data that it prevents hospitalizations, rehospitalizations. It helps people in moments of crisis to find non-medical pathways to treatment. It has been shown over and over again to reduce costs, to improve health equity across the board. So this is something that I know Senator Lesser and Rep. Dathan and many others are very much behind. And I just want to offer up Mental Health Connecticut's support and anything that we can do to help funnel resources or information or data that you need to make sure that this becomes a priority and that we finally get this this passed in this session. So thank you very much.
Thank you, Susie. Representative Dathan?
Thank you very much, Madam Chair. And thank you, Susie, for your testimony. I just lost you. There you are. Thank you very much for your testimony. It's great working with such knowledgeable folks like yourself in this. I've just started this fight in the last 2 years, and I'm glad to be on this road with you. Really wanted to talk about some of the roles and that was in the initial bill regarding the task force. And if you could maybe give a little bit of discussion around how you see those experts and why those people are so important and should be involved with a task force on this.
Sure, absolutely. And I don't have the list in front of me, but I do know that, it's important to understand that having folks with different lived experiences and the mix of that, from young adults to folks from the substance use side to the quote unquote just mental health side, really is really important to be representative. I think that is at the root of the work. The reason why a peer support is important is because it is a non-medical intervention. It is someone who walks side by side with someone on the healing journey. So to have those different experiences and to help share exactly what that journey looks like, it does need to be a mix of folks who have been at this, who have been trained, who have been at this for a while and coming at it from those different aspects. So I would love to work with folks, and if we want to go back and forth on the appointments and the different aspects of the community that need to be represented, we can do that to make sure we have our bases covered for sure.
Sorry. Are you aware of any organizations that do hire peer support specialists, maybe hospitals or other towns that hire this, and what sort of experience and knowledge are they looking for when they?
Sure. Yep.
bring
Great.
people?
So Manel Connecticut hires peers. We hire them in our Waterbury program, the Independent Center, which is our 9 to 5 club day program. And, we're always including in our hiring practice, making sure that folks know that when we hire anyone in our organization, we're looking for people with lived experience. But what's really interesting about peer support is that they are throughout the system and in a multitude of different ways, right? So I know there's testimony from the Connecticut Hospital Association. They're in great support of this. So peers are used in emergency rooms. Peers are used, with town social workers on anywhere there is a direct care team. Peers are used not in place of, but as a complement to the folks on the medical team. So it's in a variety of situations, specifically to help get at crisis, but then also in any part of the recovery journey, right? So it really, it helps ensure that person going through recovery has a trusted partner, someone who has, walked in their shoes, if you will, and has been there, maybe not, directly the same situation or the same scenario, but they can be there to have the conversations and obviously in a fully trained way, show up in such a way that helps that person get what they need, not what's offered to them, right? I think that's really important to understand about our very complicated healthcare system is there are a lot of services and there are a lot of things that people can have access to. But the burden is on the person to figure that out. The burden is on the individual to find those things. And depending on what backyard they happen to be in, what they have access to. So to have someone who has walked that path, who has gone through that who can say and almost short circuit, hey, you know what? It sounds like you could really benefit from this. Let's try this, right? And again, back to the healthcare costs. Helping people get what they need early on in the process is extremely important to prevent heading down the wrong pathway in hospitalization, to being traumatized from the system, which can happen, right? So making sure that they have access to what they need to help lower costs and get people, access to the available services that are the right fit for them, not just what happens to be up there and on a website and something that they have to, spend a lot of time and stress and anxiety trying to navigate on their own.
Absolutely. You hit the nail on the head, because sometimes it's having the regular support is what's key. I have a constituent who unfortunately lost their son, and they thought their son was going down the right road, was, involved in a peer support group service would have been really beneficial, because what seemed like, this young adult was going through, working through things, seemed like everything was going right. But someone who has that lived experience might be able to perceive and have a little bit more know-how and ask the right questions and be able to intervene in a way that, maybe a parent or a friend cannot, because they haven't been through those experiences. And unfortunately, in my constituent's case, it was very sad result. And, if only he would have ended up in hospital. So that would have been good. So thank you so much, and really appreciate your advocacy here. And I look forward to taking this to the next stage.
Thanks so much, Rep. Thanks for your support.
Thank you, Madam, for your indulgence.
Oh, thank you. Thank you for you've been working so hard on this, as well as Senator Lesser. So thank you for your advocacy on this and bringing this to us. Representative Farrar.
Thank you, Chairwoman. Hi, Susie. Nice to see you.
Good to see you.
Yes, just following up on what Representative Dathan shared, I certainly have heard from several families in my district, really about kind of two challenges, I think. One, which, we've talked about in this committee a little bit prior and shows up in a range of committees, which is really the lack of mental health providers out there, be it psychiatrists or social workers, sometimes that folks who are in crisis feel like they can access. And then secondly, one of the things I often hear is once someone is, in a crisis moment, is in a situation where they might have been in residential or hospitalized, really losing structure as they leave that type of program. So can you kind of speak to how peer support, not like, to me, I guess when I think about it, I feel like it could address both of these challenges that we have, in our mental health care system right now, with really just the lack of folks in the market overall to serve these needs, and then what folks need as they come out of residential or hospitalization.
Yeah, those are great questions. So, I mean, if you think about it, this is nothing new, right? AA, peer support, folks with lived experience, this has been around for a long time. And I think what's critical to this is a lot of really understanding that the recovery journey, which you probably hear a lot and maybe gets, is kind of feels cliche as a term, but it's used in that way because it is a journey, right? And any journey is a roller coaster ride, which goes up and down and up and down. So the more stability, the more support, the more that someone is with you walking along that journey to help you at different points when different things happen, is critical. Something that Mental Health Connecticut is actually researching ourselves and really digging into is understanding how at a big scale we're addressing the social determinants of health. And key to the social determinants of health is this idea that there is no wrong door, right? There's no wrong door into looking at everything around the individual that needs to be addressed to ensure they get what they need to take on their long-term health and wellness, right? Which again, benefits everyone from cost savings to making sure it's the right service utilization, to making sure that someone can take on their own health and wellness, right? So having that stability, and having someone with you on that journey is critical. I think you're probably seeing other, trends around community health workers, similar kind of approach, right? Community health workers who have lived experience and are a peer, that's a win-win. Those are folks, again, that are in the community that are walking side by side with someone to help navigate the system. So all of those things are trends and very progressive places where Connecticut really needs to go to get at all of these many issues in the healthcare system that everyone's facing. I can't hear you up.
I just wanted to say thank you for commenting on that, because you kind of provided a bigger picture on how this model relates to what we're trying to do with community health workers, or how we're trying to look at, again, really more preventative measures that not only address costs, but have greater outcomes for the patient. And I know, similar to Representative Dathan, several of my constituents who have, young adults who are, in really a cycle that feels often unmanageable, right, for them as an individual and as a family, that this type of, not just having access to their current protocols for their healthcare, but really having access to this type of model could make the difference for them. So thanks for sharing it with us. Thanks to Representative Dathan for her leadership. And I look forward to learning more as we go along.
Thanks so much. I really appreciate it. And just one more really quick thing. Some of the research we've been doing is around inequities, systemic racism, oppression, and what is at the root of all of that. And what we're finding is probably something pretty obvious and something that others I know have done extensive research on. And at the root of that is cultural mistrust. So I don't think it can be it can be said, and I know it's been talked about a lot today and in other committees, that really any way that we can bring equity into the system, so making sure that people are paired up with folks from similar cultural backgrounds, languages, like looking at all of those things along with lived experience really has to be looked at as well. So I just want to make sure we get that in there as a priority too. Thank you so much.
Thank you, Susie.
Thank you very much. Okay, seeing no more questions. Thank you very much. Thanks for sticking it out.
Thanks, Rep. Thank you.
Next, we have Barbara Ann Tuzzolo.
Good afternoon, Rep. Comey. Thank you so much for letting me be here today to speak with you all. Good afternoon, Senator Lesser, Representative Wood, Senator Wong, Representative Pavlak-D'Amato, and distinguished members of the Insurance and Real Estate Committee. Thank you for the opportunity to testify in support of House Bill 6588, in particular, Section 5, which would establish a task force to study mental health insurance coverage for peer support. My name is Barbara Ann Tuzzolo, and I reside in Stamford, Connecticut. I have lived with mental health diagnoses since I was 19 years old and have been employed in a peer support role for the last 15 years, almost 7 years now as a peer provider for a state agency. I began wrestling with mental health challenges in adolescence, and my parents ensured I had excellent private providers who saw me through high school and most of university. Once on my own, I fought hard to finish my degree, extricate myself from an abusive marriage, and parent my young child. Even with wonderful clinical services, I felt as if I were alone in a dinghy, paddling furiously to stay on course in the unpredictable seas of bipolar disorder, anxiety, and rock bottom self-esteem. It was exhausting and lonely. I was referred to a recovery and wellness program at Demas's Western Connecticut Mental Health Network, Torrington branch. There I met Vicki Jean and Mary Fitzpatrick, two state employees who openly shared their mental health struggles to support the individuals with whom they worked. With their support, my mind opened to the very real possibility of mental health recovery. You see, I was a very good patient. However, none of my providers had ever suggested that I could have more or that I could be more. From my understanding through Vicki Jean and Mary Fitzpatrick, I saw more opportunities for peer support, even though options for a single mother in a rural area were limited. I continued to take advantage of Western's recovery and wellness programming. I wanted to be a part of helping others discover recovery as well. I wanted my peers to know that life could be so much more than taking medication, making it to doctor's appointments, and staying out of the hospital. And I gratefully have been doing this work for the past 15 years. My life is full and has meaning. I am happy and I have purpose. There are so many stories about the power of peer support and recovery. Please know that I am not an exception. In the fiscal year 2019, my agency served almost 5,000 clients and had a workforce of 359 employees. 8 of us were in the peer role. 8 peers out of 359 employees to serve 5,000 clients in Southern Fairfield County. The businesswoman in me knows that the number of peer supporters on the payroll makes sense because we don't add anything to the bottom line. Our services, no matter how hard we work and what good of a job we do, are not billable. However, I also know that peer support is evidence-based, cost-effective, and touches places in recovery that are difficult for clinically minded supporters to reach. The people of this state cannot afford for peer support to be brushed aside any longer. This proposed task force will bring Connecticut one step closer to giving its citizens with mental health challenges the full complement of recovery supports they deserve. Thank you all for your kind attention, and I am, of course, open to any questions about my lived experience or my work experience in the peer role.
Thank you so much, Barbara Ann. I think what struck me was really well, the sincerity of your story and your desire to help folks. I just have a couple of questions. You're saying that that currently it doesn't add to the bottom line, your services. How is it funded? Is it grant funded, or is it piecemeal money funded together for?
So I've worked as in the peer support role in 3 different entities. I've worked for NAMI National, not NAMI Connecticut, NAMI National, and my work for them for 3 years was grant funded through AstraZeneca. And then I worked as a program manager at a recovery and wellness center in Waterbury. And my work there was again grant funded, but through we had one grant through the state of Connecticut. That agency that center has since closed because it lost its funding after I had left. Currently, I work for the state, and well, you're aware how that gets funded.
I hear that, yeah. I hear that over and over, is that you know, the organization piecemealing that money together is really tough for organizations, and they would have to be really fully committed to keeping the positions hopefully going. And I think also that, you know, a lot of times peer support is so important because families, you know, experience, you know, mental health issues together, right?
Absolutely.
So,
absolutely.
So having somebody outside to be able to support the person that's struggling, or vice versa, if it's a family. I mean, NAMI supports the whole family many times, but to have someone that someone can speak to outside of the family and not feel like they have to fix everything, and that can so important, I think, process, and just to the healthy processing of what so many, how you've lost so much, you know, how things you've lost so much, and that sort of thing. So, Representative Dathan.
Thank you very much, Madam Chair. And thank you, Barbara Ann, for your testimony. It was really heartwarming, and really means a lot to hear from folks like yourself that have been there and done it, and makes me really happy that I'm working on this bill. Just wanted to check in with you if you have any, I mean, we've talked a lot about people with lived support or lived experiences. How do you think we can ensure that the industry, that peer support actually are qualified to do this, that we get the right people out there doing the job?
That's a really great question, and I'm glad you're asking, because I've been working on this now for 5 years, and that is a problem here in Connecticut. And one of the greatest barriers to getting peer support reimbursable is that we don't have a consistent product in Connecticut, because there are different entities that train, there's different entities that give certifications. So Medicaid or the insurer doesn't know what product they're reimbursing for. And that's why it's so important that we develop this task force. I'm definitely not asking that we just, blanket check the box, it's reimbursable now, because I want to know as a consumer of peer support services, what am I getting? Not that we have to be McDonald's. I mean, a peer supporter doesn't have to look the same, because we all do very different jobs. But the basic training and having a centralized one standard test, just like any kind of credentialing, is super important. And all that will come up in the investigation and the work that the task force does if it is created. And I'm so excited for that work to come because, as I said, I've been working on this for 5 years, and yes, thank you.
Yeah, I mean, absolutely. I think that's one of the things that I worry about the most. I mean, you know, when you're going to get professional help, you know, seeing a psychiatrist or psychologist, for example, you know that they've been through a certain level of training. And really your choice is not to verify the fact that they've had that training. It's more of a personality fit. Can my family or me work with this person to help me? And that's really what we want individuals to be able to not have to think about the sort of qualification aspect and more focus on the personality aspect of the relationship. So thank you so much. And thank you for your discussion today. And please feel free to reach out to me if you have any questions or I can help you with this bill or anything like that. Thanks a lot. Thank you, Madam Chair.
You're welcome. Thank you, Barbara. All set. I don't see any more questions. Okay, next would be Ashley Starr-Frechette. Hi, Ashley. Welcome.
Hi, thank you so much. Good afternoon, Senator Lesser, Representative Wood, and members of the committee. My name is Ashley Starr-Frechette, and I'm the Director of Health Professional Outreach at the Connecticut Coalition Against Domestic Violence. CCADV is the state's leading voice for victims of domestic violence and those who serve them. We have 18 member organizations, and we serve nearly 40,000 victims of domestic violence each year. I'm here today to ask for your support of House Bill 6590. This proposed bill seeks to protect survivors of domestic violence from insurance discrimination by preventing insurance companies from denying or refusing coverage on the basis of abuse. This bill addresses a crucial barrier to accessing basic needs for victims and survivors of domestic violence. Currently in the state of Connecticut, insurance companies can use domestic violence as an underwriting criterion for property and casualty insurance, disability, and life insurance. They're able to do this by accessing records of medical treatment for injuries and conditions resulting from current or former abuse, counseling services, applications for restraining orders, calls to police. All of this is discrimination against victims of domestic violence. By allowing Connecticut insurance companies to access documentation of survivors' efforts to obtain help from abuse, we are penalizing victims of domestic violence and impeding their ability to disclose and receive much needed supports. CCADV works every day to educate medical professionals, police officers, and courts across the state on how they can help support victims. So if we end up using the same tactic against these individuals, how are they supposed to seek safety and get those supports that can help them to move on with their life and get the basic life necessities that they deserve? Connecticut, we strongly believe that Connecticut needs to update their policies and support victims and survivors. As a reference, the National Women's Law Center report card currently categorizes Connecticut as having weak policy because our state only prohibits discrimination in one form of insurance, which is health insurance. There are only 5 other states in the United States with this poor of a rating. 26 states have laws protecting survivors from discrimination in all 4 types of insurance, which is what I'm asking from you guys today. And finally, this bill would also add the necessary protections for the LGBTQ community. This is something that's very important to CCADV. Being able to access all forms of insurance and IPV services are essential gateways to safety and survival for all victims and survivors, regardless of sexual orientation and/or gender identity. We strongly urge you to support survivors of domestic violence and the LGBTQ community in Connecticut by passing HB 6590. Thank you very much for your time today. And if you have any questions, please don't hesitate to reach out.
Thank you, Ashley. I have a question regarding just what you've been seeing, what the field has been seeing with the COVID pandemic.
Thank you for that question. I'm in reference to this bill. I don't know if we have any specific situations yet where we've seen instances where they've had discrimination regarding this. But in general, throughout the COVID-19 pandemic, we did see quite a strong increase in the number of calls to our hotline, especially with increased concern around financial stability, housing, resources for children, et cetera. So kind of that increased isolation really causing not only those who are currently being abused, but those who have kind of that PTSD of that isolated feeling that COVID has now caused, increasing as we've gone throughout this pandemic. So yeah, unfortunately, we have seen an increase there.
Yes, thank you. And I think that sometimes too is we've not been able to move around as easily during pandemic. And you know, I've had constituents call me with questions from their car because you know they're just not quite unsure what's going on in their house and they want to have a little bit of privacy. So
yeah, that's been really common throughout this whole thing. Is we get those calls of like the one time a day when they're able to go to the store or something like that. So yeah, that inability to know who's behind that computer or that phone when you're making those calls has been pretty prominent.
Well, thank you for your work and for your advocacy on this. Is there anyone on the committee that has any questions? All right, we'll say hi to the team and thank you very much and look forward to see you again.
Thank you.
Thank you. Number 15 is up next. We have Paul Pescatello from the Connecticut Bioscience Growth Council. Mr. Pescatello, yeah. Yes.
Yeah, hi. Hi, good
How are you?
afternoon.
Good to see you.
Thank you so much for having me. Again, I'm Paul Pescatello, Senior Counsel at the CBIA. I'm also Executive Director of the Bioscience Growth Council. I'm here today to speak in opposition to Section 6 through 8 of HB 6447. The bill's drug pricing provisions are problematic on at least 4 fronts. First, HB 6447 artificially sets prices, and unfortunately, however well-intentioned, government price controls never work. Second, the bill undermines innovation at a time when we most need innovation. Third, the bill works counter to our economic development goals. And finally, HB 6447 incorrectly assumes that drug prices are a principal driver of healthcare inflation, when in fact they're not. Now, no one likes or happily responds to rising prices, but prices reflect the cost of inputs necessary to make a product. If the inventor of the product, in the case at hand, a medicine, can't recoup its costs when it seeks to transition from a laboratory prototype to actually producing the product in quantity for patients, the inventor simply won't produce or will produce a lot less of the product. When government sets prices, whether for flour, gas, apartments, or medicine, you name the good, the result is less of the good. In countries that artificially set prices, shortages occur frequently. Fewer drugs are available and the newest medicines are slow to come on the market. In 2018, for example, of the 270 newly approved FDA medicines, only 52% were available in Canada. Only 60% of new cancer drugs were available in Canada. 6447 disregards as well what drives biopharma innovation. Especially now, as we emerge from the COVID-19 pandemic, we should validate, not undermine, the biopharma business model. In the past 12 months, we witnessed how important and effective this biopharma business model is. Companies marshal their innovation prowess, put aside other projects, and focus their research and development infrastructure, and in less than 1 year, came to deeply understand the novel coronavirus, develop a safe and effective vaccine to prevent COVID-19, and manufacture and distribute 116 million vaccine doses in the US so far. This performance, what biopharma delivered, was made possible by the industry's unique research and development investment profile. It takes on average $2.7 billion and 10 to 13 years to bring a new medicine from lab concept to FDA approved drug. Most lab concepts fail. Only 1 in 1,000 research projects result in an FDA approved drug. The cost of valuable but ultimately unsuccessful research projects is borne by the few drugs that do make it to pharmacy shelves.
3-minute warning. 3-minute warning.
Okay. To innovate and take on risk of such magnitude, companies must have confidence that they will be able to price their products freely and in such a way that they will be able to recoup their costs and profit from their investments. Price controls will stifle authentic innovation and cause cures and treatments to be postponed or left undiscovered. Since companies would be limited in their ability to adjust their prices, 6447 could have the ironic effect of increasing drug prices, as well as potentially making prices in Connecticut higher than in other states. Artificial limits on price increases would incentivize companies to price their medicines higher and higher in Connecticut from the start. Finally, 6447 mischaracterizes what is driving healthcare inflation, despite the fact that study upon study has shown that prescription drug prices as a proportion of healthcare costs have remained remarkably stable for 75 years, consistently at about 10% of each dollar spent on healthcare. The bill is premised on a misguided belief that drug prices are a significant driver of healthcare costs. In fact, biopharma innovation is the way out, not the cause of the healthcare cost crisis. As expensive as some drugs appear, paying for all the R&D that made them possible makes profound public health sense. There are many examples, but to cite just two quickly, consider statin and monoclonal antibody medications for heart disease or hepatitis C drugs. In each case, the innovative medications are far cheaper than the chronic hospitalizations, surgeries, and disability they replace. 90% of healthcare is something other than drugs: hospital stays, surgeries, doctor's visits, pharmacy benefit manager, middlemen, insurance, administration. If drug prices were fixed at their level today, the biopharma innovation engine would stall, but healthcare inflation would continue to rage on, driven by all the other cost drivers in the healthcare equation. I'd be happy to answer any questions you might have.
Okay, wonderful. Thank you, Paul.
Just rushing through that. So.
I know, the time flies. Representative Meskers.
Yeah, Paul, I want to thank you for your testimony today. I think we'll fundamentally have to agree to disagree on the structure of pharmaceutical costs. The percentage of the dollar over the last 75 years may be the same, but if you compound the absolute dollar in expenses for our medical industry, you will find both the hospital industry and the pharmaceutical industry are the major beneficiaries of that growth. Now, the innovation in the industry is extraordinary. I don't think anyone disputes that the research and the foundation and the cures and the lives saved and the benefits from the vaccine, et cetera, are widely visible and available to all of us. So I salute the industry for that effort. The bottom of that industry, or the base of that, has been taxing the American public or charging the American public for the research and development and the advertising costs for the pharmaceutical industry. We spend two, 3, and 4 times more for our pharmaceuticals than anywhere else in the free world. That model is a model that provides both the revenue stream for the profitability of the pharmaceutical companies and for the advertising. All of us sit at home and we get bombarded with advertising for a whole host of base medical cures or base medical treatments. None of that is helpful. None of that is helpful to us as an industry. So it's important that as we go forward that we see what we want to do in the business model. I think the initiation of a tax on the increased rises in the pharmaceutical industry is very important consideration for us. I think the question becomes, who funds pharmaceutical research? And in the current model, it's American citizens and the residents of Connecticut who are funding that research and development for the benefit of the world. I'm not suggesting that the market should be a controlled market to the extent that a free market would give us the ability to import drugs freely from around the world. I have to purchase my drugs at the local CVS. I can't go over to Toronto, I can't go over to London, I can't go over to Geneva. The prices I pay are exorbitant. The idea of capping some of that cost and seeing how we move forward on, I believe it's a reasonable approach. There's a difference in the economic model. I'm a firm capitalist, but as I can buy a hammer, a wrench, or a car in Brazil, Korea, or anywhere and import it freely, and I cannot do that with a pharmaceutical that's manufactured in essentially India or China for the most part, I can't import them into the United States except through my pharmaceutical company and pay 2, 3, and 4 times what they pay in Canada. So I don't want to see medical rationing. I'm concerned about what you're worried about in some of the limitations, but I frankly don't see this as an attack on the pharmaceutical industry. It's just an approach to how we begin to deal with the pricing issue in the US versus anywhere else. So I'm more than willing. I know that was a soliloquy, so I'm more than willing to hear, what your concerns are. I mean, I think I've approached it from an alternate view, and if you think that it's fundamentally flawed, I'm more than willing to listen.
Well, I'll let my testimony stand, and my written testimony goes into a little bit more detail. But again, I think we all benefit from that research and development greatly. And again, that research and development, I think there's so many examples of as expensive as some drugs may appear, they are much cheaper than the things they replace. So if you take hepatitis C, ultimately leading to a liver transplant of hundreds of thousands of dollars for the healthcare system, and you have a drug that for tens of thousands of dollars is curing the disease.
Well, thank you. I appreciate that.
Okey-dokey. Representative Nuccio.
Hi there. Sorry.
Hello.
5 different things going on at once here. So I was just wondering, listening to your testimony there, do you have an alternative for us to consider?
Well, again, I guess I'm pushing back on the issue that the cost of medicine is a huge driver of healthcare costs. I think people are frustrated with the cost of healthcare overall. And again, there's so many other drivers: hospitals, insurance. In some sense, medicines are the most transparent part of the healthcare equation. I mean, consumers, in the sense that consumers see what they pay for it. Going into the hospital for a surgery, it's unbelievably cloudy exactly what you're being charged and how much it ends up costing you. Drugs, fortunately or unfortunately, people see in the way in the insurance plans, especially the high deductible plans, work. People are feeling the costs of those drugs more severely than they have in the past. But again, I would dispute that they're a driver. And again, they're actually the research and development. We benefit so much from that, and we benefit from how it reduces overall healthcare costs.
Thank you.
Okay. Any other questions from the committee? If not, we will move forward. Thank you so much, Paul. It's good to see you again. Okay. Next, we have number 16, Laura Hoke from the National Multiple Sclerosis Society.
Thank you, Representative Comey, Representative Wood, Senator Lesser, and members of the committee for allowing me to testify today. I am here virtually as a proponent of Senate Bill 1003, a copay accumulator program ban. MS is an unpredictable and often disabling disease of the central nervous system. Symptoms vary from person to person, and they range from numbness and tingling to walking difficulties, fatigue, depression, pain, blindness, and paralysis. MS is also a very expensive disease to live with and treat. Disease-modifying therapies, or DMTs, are the drugs that are used to manage an MS disease course, and they are approximately 75% of the cost of treating MS. Early and ongoing treatment with these DMTs is crucial in managing disease course and in preventing the accumulation of disability in MS patients. But while there are more than 20 DMTs on the market, there's only generics for one of the brand name medications. None of them are interchangeable, and there's no way to tell which drug is going to work best for which patient. And as Representative Meskers mentioned earlier, which I appreciate, MS medications are extremely expensive. As of 2020, the average brand price for an MS DMT was over $91,000, and 5 of them are priced at over $100,000. At least 40% of people living with MS rely on some kind of copay assistance program. So when copay accumulator programs are put in place, preventing patients from getting this assistance applied to their deductibles, they face longer and higher out-of-pocket costs, often in the thousands of dollars. Not only prevents them from accessing needed medications, but it can prevent them from seeking out other treatments that they would have otherwise gotten, doctor visits, MRIs, rehab facility access, in favor of accessing their medications because they cannot pay for both. So this National MS Society has called on all stakeholders in the prescription drug supply chain to come together and find real solutions to the escalating prices. We understand that it is an issue, but taking away this program in the meantime, taking away copay assistance in the meantime and preventing it from counting towards the deductible is not the solution. Until there is real reform in the system, patients are relying on copay assistance to get through their day, month, year, and pay down their bills. And taking it away would prevent them from accessing the care that they need. And I'm happy to answer questions or go into additional detail on that.
Thank you, Laura. Any questions from our committee? Laura, thanks for coming out and speaking. We appreciate you sharing your story. Next up is Kim Ora, followed by Danielle Morgan.
Good afternoon. Hi, everyone. Thank you, Senator Lesser, Representative Wood, Comey, Meskers, and members of the Insurance Committee. I certainly want to be respectful of your time and we'll get to our main concerns as we have been faced with in the recent years. My name is Kim Arrow. I am the president of both Aetna Ambulance and Ambulance Service in Manchester. I'm also the vice president of the Association of Connecticut Ambulance Providers, also known as ACAP. As you all know, this has been an incredibly difficult year. Ambulance providers were certainly on the front line around the country. Our two companies were no different as we transported over 7,000 COVID positive patients. Many were from the most infected nursing homes in the state. In the height of the first wave, the state also asked ambulance providers for transportation assistance with Medicaid patients that were not being provided transport by other providers due to the lack of PPE. We complied with that and continue to do so during the remaining 12 months. We also responded to the request from many hospitals to transport COVID patients home because no family members wanted to come get them early on. I am telling you this because even though we play a huge part in the patient care, especially this past year, we have a very small voice in the healthcare continuum and are often overlooked and ignored. I am here to ask all of you today to be our voice and our advocate for what we have faced with some of the largest health insurance companies that we work with. During the height of COVID, we received a significant increase in denials and refusal for payment because we did not receive an authorization prior to transport. Some of these were for emergency transports through the 911 system. I ask you all, how does this seem practical? All I can say is good luck in obtaining an authorization, especially if you call 911 on the weekends or after 4 p.m. Needless to say, we responded to all those calls and we will continue. However, we are still battling today to receive reimbursement from some of those insurance carriers. In recent years, insurance companies have become increasingly strict, and during this past year, in the middle of the pandemic, they became even worse. One of the largest health insurers, Medicare, has the strictest guidelines and policies for proving medical necessity for an ambulance transport. Yet they do not require prior auth for any transport, and in fact, during the pandemic, have loosened some of their guidelines for this. I have to tell you, I was terrified for our staff in the first few weeks of the pandemic. But I became even more scared thinking in the weeks after the first couple months that we may not be able to provide a paycheck to them because some of the impractical changes the insurance companies were making to deny reimbursement. With already low in reimbursements, as well as denials and refusals to pay, we are also experiencing further reimbursement challenges due to the many managed care plans and the increasing volume of them.
3-minute warning. 3-minute warning.
I'm sorry?
3-minute warning.
Okay. Many of those patients over the age of 65 end up receiving bills for their ambulance transports This is very concerning to me because the volume of these have doubled in the last 3 years. Our patient care reports that we support, our CRUISE document, support medical necessity. And the hospitals and the skilled nursing facilities often support medical necessity as well. If the documentation supports that and the work that is completed, why should we have to fight so hard to get paid? Physicians get paid if patients do not show up for an appointment. However, we can spend 2 or 3 hours on a transport of a critical patient and that is very frail and weak and may not be able to get paid for it because we didn't get the proper authorization prior to transport. None of this makes sense.
Thank you, Kim. Thank you for your testimony. Just you went over the 3
I'm
minutes.
sorry.
No, it's fine. So you are testifying in support of the prior authorization bill?
Yes, that is the bill that we're providing our testimony, but not supporting prior authorization.
Right. And so is your group, kind of behind on collecting a lot of this money that you thought would be coming in based on the services that you've been performing?
Yes, we are still battling collecting bills back from June, July, August, like in the beginning of the pandemic. It's getting worse in the last few years from all providers requiring the prior authorizations.
Well, what happens as this number grows? I mean, what does this mean for you being able to offer these services? I mean, it's kind of scary that you're waiting to be paid from something from last summer.
Exactly. That is the greatest concern. I mean, during the height of the pandemic, there were several that just turned up the dial, I guess I'd say, in making these restrictions even stricter. And it wasn't appropriate. We were on the front line, working our hardest every day, and to pull that on us during that time. And I said, Medicare loosened their controls during this time, and the others have not. It holds up the system. It requires a lot of extra paperwork on the front end, and it doesn't always guarantee payment. There's a couple of them that will wait 2 weeks before we even get the authorization. And in some cases, we don't get it, and then it's denied.
You've already performed the service.
Yes, we will not hold up transport. We're not going to hold up, transporting a patient to their appointment or a discharge to a nursing home. I mean, the throughput of these hospitals during this time is critical.
Right.
So,
it almost feels like you're being taken advantage of in this situation.
Yeah, it's frustrating. I just paid for a doctor's visit that I had to cancel, unfortunately, 2 weeks ago, $50. I paid for it. And I was, as I was writing this, I'm thinking, I have to pay for that. I didn't go. That makes sense. But we will do a transport that can sometimes take 2 or 3 hours with critical patients and not get paid. We're a small piece. So we certainly appreciate anything you can do to be a bigger voice for us.
Great. Well, thank you. Do we have any questions? Representative Delnicki.
Thank you, Madam Chair. And Kim, I can speak first person about the high quality of services that you deliver, because we have ASM in South Windsor.
Oh, thank you.
You guys stepped up to the plate and provided us advanced life support services when we were only having BLS.
Mm-hmm. Thank you very much for your support.
And I've got to tell you, I am very concerned about that, because at some point in time, if you aren't receiving authorization, are we going to run into a situation? You guys would never do it, but other services that are basically not getting the authorization they should get and not getting the payment they should get. When is that going to start endangering people's lives that need that transportation? I don't know if you want to comment on that.
No, exactly. I mean, we certainly don't want to ever have to make that decision. And I just can't stress enough. I mean, Medicare is the most strict, and they do not require this. So the fact that the insurance carriers have started this in the last few years or several years and amping it up and being stricter this past year and the worst year has been the most difficult. We are experiencing continued volume declines of about 15% right now. That's difficult, you know, to sustain, and then to have this drag in payment that can be 6 months to a year. It's just not fair. And I'm also, I just want to stress too, I'm very concerned about the increase in the, it's ballooned, these managed care plans for the elderly. I think a lot of them are getting swooned into the cheaper monthly premiums. However, if something turns for the worse in their health situation, and our services are one of them that are constantly going to the copays, and they get shocked by it. And it's troubling. I think a lot of them are getting swooned into these managed care plans and not knowing what they're getting into. And it's going to be a more significant problem in the years to come. It's already doubled in the last 3 years.
Well, you're located in Manchester and I'm in South Windsor. And of course we have Berry Patch, which it seems like you folks are going there 4, 5, 6 times a day, literally, to respond to situations over there. And anything that we can do, I mean, make the suggestions that you feel are appropriate, because I sense from the good chairs that there is a level of concern there also. And I commend Representative Wood for her concern on the issue.
Thank you. Our testimony that we submitted was presented by Greg Allard, who is the Vice President of American Ambulance. So it's under Ambulance Association. So if you could read the language changes that we recommended in that letter, that'd be appreciated.
Well, again, I thank you for coming forward, Kim.
Thank you.
And I thank the chair for an opportunity to have a dialogue here.
Thank you.
Thank you. Thank Kim Arrow. I'm sorry, I said your last name wrong. Thank you
No
for
worries.
coming on and sharing that with us. We appreciate it.
Thank you very much for your time.
Next up is Danielle Morgan, followed by Marian Mansky.
Thank you. Good afternoon, Senator Lesser, Representative Wood, Senator Anwar, and Representative Comey, and honorable members of the committee. Thank you so much for giving me the opportunity to provide support for House Bill 6588. All aspects of the bill are completely delightful, but I'd like to call particular attention to the section that will prohibit, hopefully, the 90-day compulsion to prescribe psychotropic medication. The psychiatric APRNs brought this concept forward several years ago, back in 2019, it became live in House Bill 7261, and then again in 2020 with House Bill 5250. Representative Doucette, Representative Cook, and Representative Steinberg carried these forward. Thank you so much. We've had great energy by my representative from Guilford, Sean Scanlon. There's been this horrible standard of care over the last many years by the insurance companies, the third-party payer system, compelling all providers, whether you're a psychiatric nurse practitioner like myself, or a psychiatrist, or a geriatric physician's assistant, when you write a 30-day supply for a psychotropic medication, after that 30-day fill, providers are compelled to then write a 90-day prescription. And this is fraught with problems, as one could imagine. We like to make medical decisions based on lots of individual factors, based on individual patients. And when third-party payer systems are not privy to any of those factors, it's definitely not appropriate in all situations to write a 90-day prescription. And insurance companies are compelling us to do that on a global perspective now. So we'd like to have the ability to make those individual clinical decisions, and when it's appropriate, certainly provide a 90-day prescription, and when it's not, to provide a simple 30-day fill. So that's what we'd like in the language of this bill, and it's absolutely perfect. I'd like to take a moment too to just absolutely laud Representative Dathan's use of peer support counselors. I work in a methadone clinic. I'm a member of the medical staff of a methadone clinic and have worked for the last 20 years as a psychiatric addictions nurse practitioner. And I've worked with peer support and recovery counselors in all sorts of settings across the state of Connecticut, and they are absolutely integral to our healthcare team. They provide the link that I cannot provide to community-based support and recovery that destigmatizes the illnesses that we work so hard to treat. They are absolutely necessary, and a task force set up to somehow add some rigor to how we might credential them is so fabulous. I welcome participation on that task force or also any kind of support that I can provide for that. I'm a member of the healthcare cabinet. It was so great to see Vicki this morning and Ted all day. It's been a great day of testimony. So any support I would be happy to provide. And to see another shot at the Psychiatric Workforce Task Force, which I've also been welcome to provide some support on. I'm happy to provide some support again on that. So I think it's so necessary. There's a paucity of psychiatric providers in this state, whether they be psychiatrists or psychiatric nurse practitioners or psychiatric social workers. And we as folks on the inside have lots of insight about why that is. And we are happy to provide that insight to all of you folks so you can advocate appropriately.
Danielle, thank you for your testimony. Senator Lesser.
Thank you, Madam Chair. Thank you, Danielle, for your testimony. You mentioned the clinically inappropriate psychotropic medications portion of the bill. Do you have any personal experience with that or a professional experience that you want to share with me?
Sure. I have years of experience with that. And I have years of appropriate experience with that as well. I'll touch on that really quickly. Just before I jumped on, I have several patients today that I just refilled many 90-day prescriptions, people who are stable and have been longtime patients of mine and who need 90-day fills to meet their insurance requirements and have nice low copays and makes fiscal sense for everyone involved. So we're always happy to meet those, standards across the board. But I mean, I can think of a gentleman who I saw, a young man who came out of a psychiatric hospitalization, acute suicide attempt when I saw him as in his early 20s. I had been seeing him for many years and was stabilized on a polypharmaceutical regime, which is very common, many medications. And one of those medications that he came back to me in community on is very toxic in supplies greater than a 2-week supply. So many psychiatric medications that very well save your life and reduce your depression dramatically in greater supplies than 7 to 14 days can actually end your life in overdose. And when you come out of a hospitalization, you're actually at greatest risk for committing suicide. So I did not want to dispense that medication in a greater than 2-week supply. And he had a insurance policy here through his parents that mandated a 90-day prescription. And I fought very diligently with pharmacist support, actually, remember that very horrible weekend, and was not allowed to dispense that prescription in a less than 90-day supply. So his parents, who were very much on my side, which is not always the case, this causes a lot of friction between providers and patients because obviously they do not want that cost carried over to them. But his parents were very understanding and ultimately had to pay an exorbitant amount of money to accept those very small refills until we were ensured that his psychiatric stability was indeed good.
Great. Well, thank you for sharing that story with us. And it definitely, you brought up some great points for us to consider. So thank you.
Thank you, Madam Chair, for jumping into the fray. A year in, you'd think I could find the mute button.
We're all learning. I can see the sun is setting on all of our faces. So we're getting there. Next up is Marian Mansky, followed by Olivia Ranks.
Good afternoon, everybody. I am Marian Mansky. Senator Lesser, Representative Wood, Senator Wang, Representative Pavlak D'Amato, and members of the Insurance Real Estate Committee. Thank you for hearing me today. I'm here today on behalf of the American Dental Hygienists Association in Connecticut I'm also the associate professor and the director of the dental hygiene program at the Foden School of Dental Hygiene at the University of Bridgeport. And I'd like you to support Senate Bill 1004. Oral health, as we know, is a major contributor to overall health. A lot of people don't understand that, but if oral health is not good, then our overall health is not good. And what happens with people who are that 26, that age 20 to 26 or 18 to 26-year-olds who don't have dental insurance, it ends up being kind of tragic for them because they have this time period that they don't have any opportunity to obtain dental health, oral health, and they end up with problems by the time they do get the insurance. And it kind of shocked me that medical insurance was till age 26. I remember my own children, we had them on our plan till age 26, but dental is not there. And what most people don't understand is the impact of poor oral health impacts the rest of the body, and it is of concern. So it's sad to see that these adults who typically present too late once they do obtain insurance have a lot of treatment that needs to be done, and it actually exceeds lots of times what they have in their own insurance, so they end up paying out. And providing that coverage would alleviate any kinds of gaps in care and also reduce the cost of care for them. Because if they had the maintaining of the dental care from up until age 26, when they are, able to obtain their own dental insurance and be gainfully employed, then there would be no gap and there would be no real major dental concerns. So it is amazing that the statistics that show that this age group is affected, and who would think, we're the cavity-free generation, aren't we? We all grew up with fluoride in our toothpaste and we didn't get cavities, but what's happening is a lot of dental problems are being presented when one doesn't get regular dental care. So a lot of times this age group won't even seek jobs because their teeth are in such poor repair, they have poor self-esteem. And according to the Center for Disease Control and Prevention, $45 million in productivity is lost in the United States every year due to untreated oral diseases. So we're looking at this population that has like a gap moment, and we want to make sure that they are able to be on their parents' insurance, just like medical, until that age of 26, if they have to. If they don't have to, they don't have to, great. But a lot of people do, and it would be quite helpful to them. And it also would reduce the cost of overall dental care. As I said, oral health is strongly correlated with total health, and without one, there isn't the other. So these unmet needs, we feel like that having this little gap time and still having them covered would reduce their risk, reduce the total costs. And as dental hygienists, prevention is our core. That's who we are. We want to make sure our patients are healthy, and if they're healthy, that overall dental health, their overall health is okay also. So I urge you to extend this dental coverage on family plans to young people up to the age of 26 as needed by the individual. And I thank you for the opportunity to provide testimony regarding this critical care issue. Thank you for your time. I hope you support SB 1004. Thank you.
Thanks, Marion. Representative Comey.
Thank you. Hi, Marion. I just wanted to say hello.
Hi, Robin. How are you?
We could probably wave to each other outside our windows.
Yes, that's true.
Thank you so much for your work. I think that we forget, or we don't think about the fact that dental decay and oral dental decay is the #1 preventable children's health chronic disease that we can prevent. So getting them in a routine early and then continuing on as they go off to start their young adult lives, I think could not be a more critical time, I think, to continue on those good habits. Thank you for your continued efforts to enlighten us on issues in your industry, in your field, and hope to see you on the grocery store.
Yes, my pleasure.
Thank you, Marion.
Marion, thanks for joining us today. Next up is Olivia Rinks, followed by Michaela Thistle. Michaela Thistle is up next, followed by Hillary Felton Reed.
Hello, can everyone hear me okay?
Yeah, we can hear you.
Great. I've had kids on Zoom all day, so sometimes my internet is a little spotty. My name is Michaela Fissel, and I'm a registered voter in Windsor, Connecticut, and I'm also the executive director at Advocacy Unlimited. I also co-chair a work group of advocates seeking billable peer services in Connecticut. I'm testifying today in support of Section 5 of HB 6588. This section will establish a statewide task force to study insurance reimbursement for peer services. Advocacy Unlimited is a peer-led nonprofit. This means that we provide education, advocacy, and support using our direct lived experience navigating mental health, addiction, and trauma. We promote individual growth, human rights, and systems transformation through what's called holistic, peer-led recovery supports. Since our incorporation in 1998, we have remained committed to offering these supports, and we are the largest designated peer-led training organization for those seeking employment as recovery support specialists. I just want to note today that you're taking two important steps through enacting this legislation and task force. First, you are choosing to bring Connecticut to the forefront of recovery orientation by establishing a task force with equal representation of those in recovery. This will require that you remain committed to appointing individuals who identify as having direct lived experience. My only ask is that you add 2 additional seats and make 1 adjustment. Create 2 distinct seats, one for Advocacy Unlimited and one for Connecticut Community for Addiction Recovery. AU and CCAR are distinct organizations that have the longest standing experience with training and education of peer specialists in the state. By having only 1 seat, you are limiting the scope of expertise. Second, create an additional seat for a person who is working in peer services as a certified peer recovery specialist, also known as a CPRS, which is a certification offered through the Connecticut Certification Board and has a distinction best represented by a CPRS. Replace the appointment of a representative of the Department of Children and Families with a representative of the Department of Mental Health and Addiction Services. DMIS is the current administration that is most involved in the delivery of peer services and funding of these services. DCF, I'm not sure if maybe that was just a bit of maybe a typo there. Since 2004, and through the leadership of past Commissioner Kirk of DMIS, Connecticut declared our commitment to recovery orientation. This was a critical step forward, yet there are 2 components of this system of care that remain underfunded and as second-class priorities.
3-minute warning.
Michaela, if you could just wrap up the sentence that you're on, we'll move to questions.
Thanks so much. This legislation will prioritize each of these components of care and will lead us forward in a much needed dialogue. Thank you for taking the time, and I am grateful for your commitment and service to the state of Connecticut. I'm available to answer any questions and can certainly be available as you continue to work through this legislation and move the bill ahead. Thank you.
Thanks, Michaela. Did you submit written testimony? Because I didn't see it.
I did. It got in a little bit late. I apologize
Okay,
for that.
that's fine. We'll look for that because you did bring up some great points that I think we need to review, and I just don't want to have that lost. Representative Dathan.
You asked my first question, Madam Chair. Thank you. Just wanted to clarify within your written testimony that you're submitted, that you did highlight some of the changes that you spoke about in your testimony.
I did.
Okay, great. That'll be really useful. Second question for you. In your professional experience, just wanted to talk about accessibility. for peer support services. Can you elaborate on that for me?
Yeah, there continues to be a gross inequity within the state of Connecticut and accessibility to peer services. As a previous Medicaid recipient, I know that I have much greater access to comprehensive recovery resources that are often available in what's called a local mental health authority. And this remains the experience today. So accessibility to peer services are not available to individuals who are within a private insurance carrier. And so it is important that we continue to investigate this inequity because we know that individuals themselves with access to peer services will step forward in their recovery and become contributing members of society. And the research shows that as it's an evidence-based practice today.
My little mouse was running across the screen there. Thank you for that. You know, I really do worry about the referral process because I do think that, you know, if we aren't addressing the accessibility, especially for Medicare, Medicaid recipients, then, you know, we do run the risk. I mean, the cognizance of this committee is insurance, but I do worry about that as well. But in terms of, you know, referrals, you know, we want to make sure that people who maybe even on different insurance plans will be able to use this service because it's only, you know, as good as the people who are able to access it. And that's really my concern, you know, with the whole referral process and also just different accessibility in different parts of the state, because this isn't a Fairfield County issue or a Hartford issue. This is an issue that everybody has, and we need to make sure that no matter where you are in the state, you have the accessibility, and no matter, you know, what kind of insurance you have, you do have the access, because, you know, we've seen through other presentations that these sort of services actually save money. So if you have any other comments about referrals, I'd love to hear that.
Thank you so much. You speak so well to the current state of affairs here in Connecticut as it relates to accessibility to peer services. And in regards to referrals, you know, we've done a great job here in Connecticut and in some areas of the country with creating an opportunity for residents to be able to access behavioral health services directly by calling their health insurance provider. Through often just like a 1-800 number or 188 number, 888 number. And they themselves can say, hey, I need some help right now. I'm struggling. Can you provide me with a list of providers within my area? I would hope that self-referral is the option for accessing peer support as well. That we don't need to go through a clinical kind of diagnostic protocol in order to access that level of support. So that would be my recommendation.
That's good. I mean, I think you're more apt to get people using the service if you take away that barrier. So it's a good point. Thank you so much. And I do hope that when we see your testimony, you have your contact details there, because I might reach out with additional questions. Thank you for your testimony, and thank you, Madam Chair.
Thank you, everyone, for hearing me today. It's nice to see you.
Thanks for coming, Michaela. Next up, we have Hillary Felton Reed, followed by Stephen Schultz.
Hi, good evening, everyone. Senator Lesser, Representative Wood, Senator Wong, and Representative Pavlak D'Amato, thank you for the opportunity to testify before you today. My name is Hillary Felton Reed, and by way of introduction, for those of you who know me from my work on other issues, or those of you who don't know me, I work with Susan Halpin, whom I know many of you know very well, and I'm here today to testify on behalf of the Connecticut Association of Health Plans. I'm here to speak on House Bill 6588, an act concerning mental health care and substance abuse services. Over the years, the association has worked with the state on many pieces of legislation to improve access to mental health and substance use disorder treatment, as evidenced most recently in 2019 with Public Act 19-159. As awareness of behavioral health treatment grows nationwide, so too has a focus of health carriers on the issue as they work with providers, consumers, and policymakers to balance access, quality, and cost. With respect to sections 1 and 2 of the bill, we recognize the language is more defined than previous year's versions. Still, we cannot support the language or the requirements without further discussion and a better understanding of the problem at hand. Most would agree that behavioral health treatment is not a one-size-fits-all solution. We support efforts to minimize and prevent medication misuse and abuse. However, whether it be inpatient treatment, outpatient treatment, home-based treatment, or some combination thereof, each patient responds differently. Prescriptive treatment and coverage requirements laid out in statute impede the ability of carriers and clinicians to adapt treatment protocols in line with clinical appropriateness. Further, drug development and research are consistently changing, with new drugs coming to the market all the time. Setting specific coverage policy in statute refuses to recognize that some drugs, or potentially new drugs not yet on the market, may very well be best prescribed in 90-day quantities, and such policy may be better for the consumer. Thus, we urge caution in adopting a one-size-fits-all policy. In addition, with the cost of pharmaceuticals ever rising, it is irresponsible and not in the interest of the consumer to statutorily prohibit the ability of carriers to manage such costs. We urge strong consideration for potential unintended consequences of this legislation, and we welcome the opportunity to discuss it with you further. And one last point, we know that the bill also establishes 2 task forces, which have been spoken a lot today. And we would appreciate to work with the committee on both task forces. We appreciate that the Peer Supports Recovery Task Force does have an appointment for a health insurance carrier, and we look forward to that discussion. And we hope that there can also be one on the task force to evaluate provider networks as well, should it move forward. Thank you for your time today.
Thanks, Hillary. So I just want to be clear. So you are not supportive of the 90-day supply being reduced?
So we are requesting that we have some additional discussions with the committee about this legislation. We feel that right now it's not necessarily specific, which circumstances that might be applied to, and we would, there may be some circumstances where 90-day supplies are beneficial to the consumer. It prevents the consumer from having to revisit the doctor as frequently. And the woman Danielle who spoke earlier did mention that there are individuals where their illness is managed very appropriately, and a 90-day supply is appropriate for them. And there may be instances where that is not the case, and we would be happy to discuss that further with the committee. I think we are just trying to make sure that we have a better understanding of which circumstances those are and which drugs might be more dangerous than others. Currently the language applies to all psychotropic drugs, and we would just appreciate a better understanding of exactly the situations that the legislation seeks to address.
Okay, because let's definitely have that discussion sooner rather than later, because it is a mental health, bill, and really, concerning the opioid epidemic and having these psychotropic drugs in such a large supply for someone that may need only 2 weeks. And, I think we're all working towards that effort. So would definitely like to further talk with you about that. Representative Meskers.
Thank you, Madam Chair. I'm just Hillary.
Hi, Representative.
Welcome. Good to speak to you for the first time. I'm just going to complain because my chair has stolen my thunder. So I'm confused as to your objection, as it talks about the healthcare provider deciding that the outpatient, what's clinically appropriate or inappropriate. And I think that harks back. It's so funny that I was at the exact same point. Both pain medications like opioids and psychotropics, I assume can potentially have either recreational use or can be left around for misuse. So, you know, I think there's probably a way to work that through, but I'd love, you know, my experience walking into a doctor is the only place I get exactly what I need is for an antibiotic. And I run out at the exact point of my 11 pills or 5 pills or whatever. But everything else seems to come in quantity. So I hope we can work out with you on that in getting that you know, fine-tuned. You also mentioned a potential problem in the first 2 parts of the measure? Or was that the print one?
Those sections are the sections that you were referring to, Representative. And if I could just respond briefly, since the opioid epidemic was mentioned, and I will say that that is a very good example where carriers actually have supported quantity limits for opioid pain relievers because there was very good evidence that opioids were contributing to a very significant addiction crisis that none of us wanted to support. So, you know, I completely agree that there are situations where it would be necessary. And as mentioned, we would like to work with you on the legislation. We certainly understand the concern with dangerous misuse and abuse of medications if supplied in large quantities. And we appreciate the fact that you're open to further discussion, and we're open to that as well. So
perfect. And my concern will be, you may or may not be able to answer that now. My concern would be that the pharmacy benefit managers, that there's an issue in terms of the payments and the rebates related to the quantity that's issued. So I want to make sure that there's not an incentive structure that's encouraging anybody to push out larger quantities than are necessary. And so so it'll be a combination of figuring out where you guys sit with that, and then figure out, are there opaque incentives to issue larger versus smaller sizes based on the rebates that are potentially available? Because I just don't want our citizens who are taking psychotropics and presumably could have issues. I don't want them to be flooded with the wrong medication. So that's our concern. So I look forward to talking to you on that, and thank you for your testimony.
understood. Thank you.
Thank you, Hillary. Up next, we have Stephen Schultz, followed by Kelly Ryan.
Thank you very much. Thank you, members of the Insurance and Real Estate Committee. I hopefully can be pretty short. I know you guys have had a long day. My name is Stephen Schultz, Director of State Legislative Affairs for the Arthritis Foundation. I'm speaking to our support of SB 1003, which ensures all co-pays count. It's the bill that you've heard some testimony already before, and likely maybe after, around accumulator adjustment programs, which don't count third-party payments such as co-pay assistance from counting towards a patient's cost-sharing requirements, such as their deductible or cost-sharing requirements. Just want to focus really on an element of the discussion on this issue that focuses around generics, and point out that about 99.6% of medications that receive this type of assistance, that's the subject of accumulator adjustment programs, according to a study, were brand name drugs without a generic. And so in addition to that, as a patient gets on a medication that has this type of assistance, they do go through things like prior authorization, step therapy, things that ensure that this is the right medication for them and that there are no lower cost alternatives that are out there. So most of the cases where patients get on, go through these protocols, assistance is really their only option left to stay on their crucial medication. And then one of my last elements is that it's important to note that there are extremely similar bills to this that have been enacted in West Virginia, Illinois, Georgia, and Arizona. In addition, there's about 20 other states that are trying to enact something similar to Connecticut this session. And then lastly, I'll just say, if you're looking for a bill that's going to by itself fix drug prices, as you have this discussion today, SB 1003 is not it, but it is something that can fix the problem of cost sharing being shifted onto the patients while a larger discussion on drug pricing is taking place. So for that reason, I hope you continue to work and support this important effort. Thank you.
Thank you, Stephen. I don't see any questions, so we will move on to Kelly Ryan, followed by Kara Gooding.
Thank you, Representative. Good afternoon. My name is Kelly Ryan, and I'm Deputy Vice President for State Policy at Pharma. We represent the nation's leading biopharmaceutical manufacturers, research-driven manufacturers, some of whom you've already heard from today. I'm here to express our opposition to Governor Lamont's proposal as contained in sections 6 through 8 of House Bill 6447. As we've talked about, the proposal would establish a price control on all medicines, imposing significant penalties on sales above a statutory threshold. I submitted more detailed written testimony, and we've talked about this a lot today, so I'll just quickly raise a few points and I'm happy to take any questions. There are a number of reasons why this proposal is concerning and not the right answer. It raises legal concerns from both a dormant commerce clause and a patent law perspective. It could stifle the kind of innovation and flexibility that is so important, not only to drug development generally, but as evidenced clearly by what we have been through this past year. Talked about that earlier today. But I'd like to focus on the important point that this proposal does not address what patients pay at the pharmacy counter. This is heavily influenced by insurance plan design. The growth of net drug prices, which reflects rebates and discounts, has been in line with or below inflation for the last 5 years. Specifically, brand medicine net prices increased 1.7% in 2019. But this is not what your constituents are feeling at the pharmacy counter. Instead, they're subject to high deductibles and coinsurance, which are based on the list price and not the significant rebates and discounts that are provided by manufacturers to plans and PBMs, something that's unique within the healthcare system. These discounts totaled $175 billion in 2019. In 2012, that number was $74 billion. So just in 7 years, that gap between list and net price has grown over $100 billion. Plan design continues to shift the burden to patients. In the years from 2012 to 2017, the percentage of commercial health plans that require deductibles on prescription drugs rose from 23% to 52%. And even outside of a deductible, insurance covers a lower share of prescription drug costs and hospital costs. On average, patients pay about 4% out of pocket on hospital costs as compared to 12% on drug costs. We've already heard today about the impact of pharmaceutical spending and the complexity of the supply chain. I'd like to reiterate a point raised earlier that nearly half of spending on brand drugs goes to entities in the supply chain other than the innovative manufacturers that develop the medicines. Instead of acknowledging the reality of the supply chain and all of the factors that influence how patients access their medicines, the governor's proposal includes a short-sighted and legally questionable price control. It sends exactly the wrong message to the innovative companies who are producing cutting-edge medicine and steering us through a pandemic, while it doesn't actually help patients. So we support reforms that are in the best interest of Americans, lowering patient costs, ensuring access to medicine, protecting innovation. And we've been at the table with this committee and others for a number of years talking about these solutions and are happy to continue to do so. But Governor Lamont's proposals in this bill, it's just not the answer. I'd like to thank you all for the thoughtful discussion on this issue all day. And I'm more than happy to take any questions you have.
Kelly, thank you. I mean, I think that what we have learned from today is that we have a lot of discussing to do and how to make this the best. I'll turn it over to Representative Meskers.
So Kelly, thank you very much for your testimony. So I'll put you in an awkward spot in your testimony, in that you're telling me I'm shooting the messenger and not maybe killing the message, or something, some metaphor to that extent. So I guess my question is, if the pharmacies are not where I should be going for my residents' medical costs, for the cost of the drugs, what's my resolution here? Because all I know is that as I sit here as a representative, that we are dealing with a compounded cost on both hospitals and pharmacies that's unsustainable.
Understood. And my response to that would be, I'm not going to sit here and say, don't look at us, don't talk to us, it's not us at all, right? That's not what I'm saying. I want to be clear about that. What I am saying is just looking at list prices like this bill does, imposing a price control does not solve the problem that your constituents pay at the pharmacy counter, right? There is a very long chain of folks in the middle, as we've seen by this huge gap between list prices and net prices. And earlier you talked about having a constituent that had an MS drug that was taken off the formulary and made the assumption that it was because, the list price went up. Well, that's not necessarily the case. It could also be because the plan is trying to drive a bigger rebate and they get a better rebate from one or the other. Basically, access, formulary inclusion, all of those factors may or may not be influenced by list prices. And so just focusing on that, the way this bill doesn't solve your constituents' problem when they walk into the pharmacy in their deductible and pay, $10,000 for a drug when the plan is getting a 40% rebate on that and they're paying more than their own health plan is.
I hear you. I guess, my problem is I sit here and look at drug prices that are spiraling out of control. Is any of the research I've done is that when drugs are approved for consumption and for sale in the United States, the FDA approval process and the pricing encompasses expensing the costs of research and development. So presumably the purchase price on day one covers research and development. And yet I've got a spiraling cost structure that is overwhelming my constituents. So I'm not against my pharmaceutical industry making their fair share or being able to do their research. But if we start with the issue that research and development is paid for within the authorization from the FDA, I have to question whether or not how I control the prices. Your suggestion is I should be looking at the pharmacy benefit managers more than at the pharmaceutical companies. That's what I'm hearing.
As part of the whole conversation, right? I'm not trying to just say don't. Right? I just want to be clear about that because this.
Okay.
They say, everybody's pointing fingers. I'm not trying to point fingers. I'm trying to say you need to have a comprehensive conversation. And an issue that you've raised a couple of times today, I think you're spot on, right? American consumers are shouldering the burden of research and development for the rest of the world. Like that's absolutely the case. We agree with you on that. My federal colleagues are more well-versed than I am as a state policy nerd in that respect. But I mean,
it's unsustainable. Thank you.
It's unsustainable, but this bill doesn't solve that problem, right? We need to work on some trade agreements and we need to deal with that. But you're absolutely right. Americans are paying for the innovation that's benefiting the rest of the world.
And I've had this conversation away from the pharmaceutical companies with the insurance companies.
Mm-hmm.
And the insurance companies, and I was in banking all my life. I worked on Wall Street, so I'm not an anti-insurance company. I said that the insurance company is stuck as the orchestra leader between the hospitals, the pharmaceuticals, and the client and the constituent that I have. And we're compounding at 7% a year. At some point, very shortly, I think I qualify for a 30-something thousand a year Social Security payment if I get there, God willing. My insurance cost, if I have to purchase private insurance, will exceed that price in the next 2 to 3 or 4 years. So we are getting to the point where private insurance will fail. And not that I'm advocating for a public option because I have serious concerns, but when the industrial base of the United States has to pay $45,000 a year to insure an employee, we're all going to have a problem about where is the private sector in this equation. And I honestly think that, I think you and I will disagree or agree to disagree in the short term that this is the first attempt I'm seeing in good faith to do something with the absolute prices or the profitability between the pharmaceutical companies and the pharmacy benefit managers to extract an expense for the rising cost of drugs that's going to go somewhere to subsidize the Affordable Care Act. So I think it drags it back into the equation. It may not be the most elegant way, but I frankly find a lot of, I can understand the rationale as much as you dispute it, but thank you for that.
I understand. And we can agree to disagree in the short term, but I think your sense of the bigger problem is not off base by any means.
No, I think $3,000 a month with a $10,000 annual deductible is not insurance. It's catastrophic insurance, and that's the problem.
We would agree with that.
Great, Kelly. Thank you.
Thank you.
Next up is Kara Gooding, followed by Indra Srivastava.
Hi, can everybody hear me?
We can hear you.
Good evening, members of the committee. My name is Kara Gooding. I'm the Director of Case Management at Bristol Hospital. I'd like to thank you for the opportunity speaking with all of you this evening in support of House Bill 6586, an act concerning prior authorizations and healthcare provider contracts. There are several clinical circumstances in which the hospital is required to obtain prior authorization, all of which can be confusing and time consuming. The two types of authorizations we deal with in case management are authorizations for inpatient hospital stays and authorizations for short-term rehab. The authorization process for inpatient hospital stays consists of sharing clinical information with the payer in order to establish medical necessity for acute inpatient hospitalization. Each insurance company has their own process for sharing clinical information. For example, Anthem, Aetna, Cigna, and United Healthcare all require clinical information to be faxed. This requires printing the medical record and submitting the record via fax to the appropriate case manager. The case manager reviews clinical information based on their criteria set and issues either an authorization or denial via return fax. Faxing clinical information creates delays, mostly due to fax machines being down, busy fax line, printing issues, and pages being lost as they're sent within each payer system. There is a solution. Connecticut Medicaid has direct access to our electronic medical record. Patient information is uploaded into their portal for payer review. This allows for a more timely review and authorization determination. If Medicaid can do it, why can't the rest of the payers? Authorizations for short-term rehab, also known as post-acute care, is where we see long and preventable delays. There have been times when we have spent hours trying to navigate the payer's automated call system. To request a short-term rehab authorization, for example, with Anthem or Aetna, it requires a phone call to the pre-certification phone line, which in most cases is not answered, and we are instructed to leave a voicemail, and the payer would then have to call us back with further instruction. Once we receive a return call, we are asked to send clinical information again via fax to the insurance case manager handling the authorization. Anthem does not provide weekend or holiday staff to accept and review authorization requests. However, Aetna does provide staff during weekends and holidays, but on a limited basis, which really means if a patient comes in Friday afternoon, in most cases, authorization will not be obtained until Monday or later. Again, there's a solution. Medicare fee-for-service and Connecticut Medicaid do not require a prior authorization for patients to move over to short-term rehab. If clinical criteria is met, then the patient is entitled to the benefit, eliminating authorization delays. We estimate that the prior authorization adds $154 million of cost annually to the Connecticut healthcare system. At the very least, shouldn't there be rules and focus on making sure the prior authorization process is appropriate and efficient using 2021 technology? I don't understand how insurance companies reporting billions of dollars in profit haven't upgraded their IT infrastructure to make the prior authorization process more efficient and timely for their members. On the provider side, we are incentivized by CMS to do so 10 years ago. Now we would be penalized if we hadn't implemented electronic medical records. How is it possible that nobody is holding commercial insurance companies to the same standard? Thank you for your time.
Sarah, thank you so much for speaking and sharing the story. I think it's really important for us to hear, what you're dealing with at Bristol Hospital in terms of how this bill can be helpful to you. Any questions from the committee? Kara, thank you. Next up, we have Indra Srivastava, and I apologize for pronouncing your name incorrectly, followed by Dr. Andrew Lim.
Do not worry. Good afternoon, the committee. And my name is Indra Srivastava, and I'm the head of manufacturing science and technology at Protein Sciences. It's a Sanofi-owned company. My career has been dedicated to innovation and the vaccine development. Proteins, and I'm here to testify to oppose the House Bill 6447 because we believe that it will stifle the innovation that will prevent the development of innovative vaccines and medicines. There is a lot of diseases that are going on. I think we are all experiencing the challenges with COVID as one example. Protein Sciences is a vaccine biopharmaceutical company which is based in Meriden, Connecticut since 1983. Since 2017, the company is owned by Sanofi. We have a small staff. We have about 100 people. 70 people are dedicated for the scientific jobs and projects, and 30 people are dedicated for the commercial vaccine production. Our goal is, our mission is to save lives and improve the health of the people by developing innovative vaccine. One of the innovation that came out of Protein Sciences is the development of recombinant influenza vaccine Flublok that is approved by FDA since 2013, and it is available to the public. In a recent clinical trial study, what we have shown here is that the individuals who received Flublok, they were able to be less likely to get influenza compared to a quadrivalent vaccine that was based on the inactivated virus. It's an old technology, so there is an advantage of using new and improved technology. Also, Protein Sciences is also researching and developing important new vaccines by providing both the scientific data and breakthrough, as well as resources that are reinvested in developing the next vaccine, treatment, or cure. In 2020, Sanofi invested about $6 billion in research globally. For instance, Sanofi has also entered in a partnership with the GlaxoSmithKline for developing a COVID-19 vaccine as part of the Operation Warp Speed. We all know that the vaccine for COVID-19 is really, really needed. Also, the virus is mutating. It is mutating constantly. And so we need to focus on the technologies that we have currently and beyond the technologies that can be used for taking care of that mutant virus and the vaccine. I think Protein Sciences is critically suited because we are producing the vaccine for influenza virus, which mutates every year. So this platform needs to be maintained and strengthened. So Sanofi is also committed to addressing concern over the rising healthcare cost with our pricing principles, first implemented in 2017. Sanofi's fourth annual pricing report is already included with my testimony to give you an idea that we are responsibly pricing medicine. Just to give you an example, in 2020,
3-minute warning.
Okay. In 2020, across its portfolio, Sanofi has an average aggregate list price increase for 0.2% and aggregate net price decrease of 7.8%. And most important part is that they're stifling the innovation will create vaccine shortage, and vaccine shortage will lead to the outbreak of serious diseases. And also, if the shortage continues, then it will also impact the development of the vaccine, which is critically needed for the new diseases. Just to give you an example.
Thank you very much for your testimony. We've hit the 3-minute mark. We really appreciate you coming on and waiting for your turn. So
no problem.
Any questions from the committee? Senator Wong.
Thank you, Madam Chair. And Dr. How do I say it? Srinivasan?
Say it. Yeah, this is close. No problem.
Well, I just wanted to thank you. I know we acknowledged Pfizer. We acknowledged, obviously, Boehringer, but it's also important to acknowledge your work. Obviously, Protein Science is one of the largest flu vaccine providers. And it's important to note that during this pandemic, through personal hygiene and safety protocols and mask wearing, our incidences of flu are significantly lower. But prior to that, I wanted to acknowledge that you, as a Connecticut-based company, now being a part of Sanofi, have always been very engaged in the protection of individuals and through your science and help. I know in this building, in the legislative process, we're going to have a very lengthy debate about the merits of vaccines. For me, I want to be clear, vaccines, I believe in vaccines. I believe in the science of it, but I also believe in individual choices. But I wanted to acknowledge and thank your organization for your work in providing healthcare in the flu aspect. So Thank you, Madam Chair, but I just simply wanted to thank our bioscience, biotechnology companies. Thank you.
Thank you. Thank you, Senator.
Thank you for doing that, Senator Wong. Next up, we have Dr. Andrew Lim, followed by Dr. Dennis Ferguson.
Hello, good afternoon. Can you guys hear me okay?
Yes, we can.
All right, sounds good. Thanks for having me. Thanks for allowing me some time tonight. My name is Dr. Andrew Lim. I am the Medical Director of Emergency Medicine at Bristol Hospital. But more importantly, I'm a frontline ER physician in the Bristol community. Thank you for the opportunity to address HB 6586, an act concerning prior authorizations and healthcare provider contracts. Bristol Hospital supports HB 6586, which provides a vitally needed solution to the pervasive abuse by health plans of the prior authorization process. In my role leading the emergency room here at Bristol Hospital, the prior authorization process has a major effect on patients awaiting transfer to a short-term rehab facility. For the patient's safety, it's often best not to discharge them directly to home, especially if they are living alone or don't have family to provide assistance. Challenges with prior authorizations often occur on a Friday night or the weekends when appropriate staff from the insurance company are unavailable to approve transfer to short-term rehab. This results in the patient having to stay overnight or even over the weekend in the emergency room until the insurance company approves the physician's recommendations. There is also an overlooked downstream effect that occurs in all hospital emergency departments as a result of this pending approval process. Many patients awaiting prior authorization for short-term rehab are at the highest risk for complications from COVID-19. They will spend days either in a private room or a hallway in the emergency room. This puts other patients also at risk due to room unavailability and crowded waiting rooms. In addition, this puts healthcare workers at increased risk during a time when staffing shortages were already the norm due to COVID-19 illness. As a result of COVID-19, the entire healthcare system has been stretched to the limit. Doctors, nurses, and hospital staff have really stepped up during this extraordinary time to care for our community. During the same time, the insurance companies need to step up and support us who are working tirelessly while at the same time endangering ourselves in the mission for caring for others. The American College of Emergency Physicians, or ACEP, affirms the principle that patients should receive prompt emergency care regardless of payment source or ability to pay. ACEP asserts that prior authorization rules instituted by third-party payers must not pose a barrier to patients seeking access to timely emergency care. ACEP further asserts that insurance companies have an obligation to pay for necessary evaluation, stabilization, and/or transfer, that an insured patient should be granted the expectation of coverage when seeking emergency care. HB 6586 provides a needed solution to the abuse by health plans of the prior authorization process. There is value to prior authorization, but we're finding that many health plans are using it routinely for procedures with established standards where there's no history of questionable use. Connecticut's insurance laws do not protect patients and providers from prior authorization abuses. HB 6586 sets a pathway by revising current statutes and implementing new provisions to create standards, transparency, and accountability in the prior authorization process. Please approve this bill so Connecticut hospitals can continue to provide safe, high quality, and affordable healthcare to the patients and their families. Thank you for allowing me to speak today.
Dr. Lim, really glad that you're here, and thank you for doing what you do. It looks like you are still at the office, so we appreciate it. I'm just a little concerned with the process for prior authorizations when patients need to be moved to a facility, like using fax machines, and if it's off hours. I just feel like, is that really the case in 2021?
Yeah, correct. That's definitely, a lot of the challenges is technology and not having staff on the other end to kind of confirm the authorization. So, the ER tends to be a safety net. And, clinically, I always try to do the right thing, and our team always does the right thing. And if a patient needs to go to a nursing home, rather than discharge them or have them wait in the waiting room, we keep them where we can continue to care for them until we have that kind of final destination set. And unfortunately, in some cases, it can be, depending on the day, if it's a Friday, that could be a Saturday, going into a Sunday, which takes up a needed space or a needed private room for someone who may be critically ill coming in. So that's definitely one of the challenges that we've had to contend with over the last year.
Why is this still an issue in this day and age? I mean, I'm sure you have complained about it and asked for this to be improved. Why are we still using fax machines? And we have apps and all kinds of technology now to streamline this. Is there pushback from the insurers? I mean, I'm assuming that's what it is. I don't know if you even know that because you're dealing on the front lines and not really dealing behind the scenes.
It's a really good question. Kara Gooding, who spoke before me, could probably speak more about the finer details. I know that that's something she's been pushing for in terms of a more streamlined process for communication. From my standpoint, oftentimes I rely heavily on our great case managers to kind of work the ins and outs and know the system. But oftentimes what they do have to come back to me with, the kind of the bad news that, hey, we're going to have to, watch this patient overnight. They're not going to go anywhere, at least until the morning and maybe not even the next day because of, this poor communication and infrastructure that we're given.
Great, thank you. Representative Pavlak D'Amato.
Thank you, Madam Chair. Thank you, Dr. Lim, for your testimony. Appreciate you taking the time out of your busy schedule. I know Section 3 of the bill discusses prior authorization, or I think, it says delineate circumstances where prior authorization is not permissible, such as when a treatment or procedure is performed in the middle of surgery or procedure that the health plan has already authorized. How does it work now if you're in surgery and you have to do something that wasn't necessarily pre-authorized, and it, doesn't it fall under an emergency situation that is going to doesn't need prior auth? How does that work?
To be honest, I don't know. My specialty is emergency medicine, so it's a situation I haven't come across.
Okay. Yeah, and I should have asked Kara that question. I probably have a couple others for her as well.
I think Kara might still be on the call. I don't know if there's a way to kind of let her back in. She might be able to.
I can contact her. I'll send her an email. But are there any other situations that you can think of that, we want to make sure that this is thorough. So
Sure.
Are there any other ones that maybe aren't covered or that are especially important to you in the bill that you want to make sure goes through when it comes to the topic of prior authorization?
Yeah, I mean, that's really, that's really the biggest part that kind of hits home for us is, during COVID, it was so, I mean, I speak in the past tense, but obviously we're, hopefully on our way out of it, but obviously we're still in the middle of a pandemic. And one of our biggest goals was to make sure that we could take care of patients safely, and that involved social distancing. So, it was unacceptable in my book to keep people in the waiting room. And so we really had to shift our focus on throughput and making sure that we could see people in a safe environment, but also making sure that our patients felt comfortable seeking healthcare. We know that one of the big issues was people were delaying care or not coming to the ER because they were scared to contract COVID. So to be able to do so, we have to really make sure that we're being efficient and that we have processes in place to make sure that we're cleaning rooms thoroughly, that we're able to get people in the rooms quickly. And really one of the biggest challenges that we had a lot of difficulty overcoming was, what do we do with the population of patients who we were holding in the ED, for many hours and in some cases multiple nights, kind of awaiting placement, when we all knew that we knew where the patient needed to go, we just couldn't get them there. So I think this will be a big part in helping to remove that barrier to care.
All right. Thank you very much. And yeah, I appreciate your testimony.
All right. Thank you.
Thank you for joining us, Dr. Lim. Next up is Dr. Dennis Ferguson, followed by Wyatt Bosworth. Dr. Ferguson, are you on? Okay, is Wyatt Bosworth on? Yes, I can see Wyatt.
Madam Chair, number 28 is on. I just don't know if
they are
Okay,
no.
let's hold on and see if Dr. Ferguson can unmute and join. We'll give him a few seconds.
Okay, unmute.
There you
Oh,
go.
all right.
Am I
Thank
unmuted?
you. Yes, you are.
Oh. Am I unmuted or can you hear me?
We can hear you.
Okay, you can't see me, I guess. I don't see my picture. Okay. I think I'll change instead of reading what I was going to present, I could probably answer some of the questions that were of concern. I want to thank everybody on the committee for allowing me to talk. I've been a physician at Bristol Hospital since July 1977. And for the last 7 years have been the physician advisor in the case management area, which was a job that didn't even exist 2 decades ago. It now becomes a necessity because of the way insurance companies have changed things. Oh, I think I'm connected. Can you still hear me? Can you
Yes,
hear me?
we can hear you.
I'm sorry. Some of the questions that were asked to Dr. Lim, I could probably answer. But the bottom line is, over these 7 years as a physician advisor, I've seen dramatic changes. Things are happening that insurance companies are changing policies. They're almost practicing medicine without a license. And in order to take care of patients, we need the collaboration of government, hospitals, insurance companies, and community services in order to really treat them. So just a quick statement, instead of going through all the problems, the solutions are what I think we have to do is we need to have a standardized, effective process to obtain authorizations. It is true, we're still on fax machines, excuse me, and various different requirements per different insurance companies. We need the insurance companies to be able to access our electronic medical record, because many times when we get denials for coverage or not getting our pre-certs on time, they're saying they don't have the clinical information, but it got lost or the fax machine was broken, et cetera, et cetera. We've been trying to do this for 2 years now to get everything electronically sent to them, but there's been resistance. When we ask for a pre-auth, we need to get a response within 4 hours. Actually, Medicare rules state that it should be 1 hour, and then they're responsible for this, especially the managed Medicare plans. Unfortunately, the insurance companies don't follow these rules, and these rules are not enforced. And sometimes the insurance companies will take days to respond. We need insurance companies to provide 7 days a week coverage. People really get sick on Fridays and weekends, and you can't get a pre-authorization on a weekend. When we don't get a timely response, as you heard from Dr. Lim, the patient remains in our emergency department or in our hospital inappropriately. We call those avoidable days. So the patient stays in our hospital even though the physicians feel that the patient should be transferred out for, say, short-term rehabilitation. And they're not getting the proper care in the right place at the right time. I'm going to stop there because everything's been said already, so I don't really want to continue that. But just like the ambulance service, unfortunately, we haven't gotten paid for people we took care of 2 years ago. So we have lots of problems with this system, and we're very much in favor of changing it with this policy.
Thank you, Dr. Ferguson. We have a question from Representative Pavlak D'Amato.
Okay.
Hi, Doctor. Thank you for your testimony. What do you think the percentage of cases are or claims are that get rejected initially overall?
Oh, I would say, well, it varies by the type of insurance you have. Our biggest offender or biggest denier would be managed Medicare plans. And I would say that we see, I would say 10 a week, all totaled, something like that. I don't know what percentage that would be.
Well, I was going to say, then how many, though, if you get 10 rejections, how many do you think you're putting in? Do you have any idea of a number, 100, 1,000?
how many patients we have. I don't have that. I know Kara will have that information.
Well, then it may, I was going to ask Kara, but maybe from the ones that were rejected, then I'm wondering if there's resubmission, then what the percentage of acceptance or payout is on the second time around.
We go through this every case, and we have the ability to overturn, I would think, half. But unfortunately, there are some that are so obvious. What happens is the insurance companies now use a third party, Cotiviti or Optum, and after they've already been certified and approved, Cotiviti will come in and say, no, we're going to take the money back. And when we talk to the physicians at these companies, they're unrelenting, even though we have all the proof and we've actually given it to other people, and we can prove that the patient had what we said. They still resist, and we still haven't gotten paid. And it's a very, very frustrating system.
Yeah, I'm sure, especially for the patient too. I mean, they're in the real position, a vulnerable position, and expecting it to be covered and then saddled with a bill, I'm sure is, I know.
They won't get a bill. They won't get a bill from the hospital.
Okay.
For this. They do get a notice of non-coverage, but they won't get a bill from us for that. That's just not fair. It's not fair that the hospital doesn't pay for when they don't get to send them to the SNF, the skilled nursing facility for short-term rehab.
Mm-hmm.
What will happen is they'll stay in our hospital for 3 days, 4 days, and then the insurance company won't pay the hospital because they say, well, it's not medically necessary. Well, it's not medically necessary, yes, but we can't ship them out because they can't go home. It's unsafe. And yet you're not giving us the authorization to let them go.
Right.
It's even worse when they have Medicare managed plans and Medicaid. Medicaid will automatically send them there, but we need the denial first from the insurance company in order to have Medicaid pay for their nursing home.
Right. Yeah, I was just thinking about that it's just a shifting of, ultimately who pays. So I can see how, though, under our state laws, I believe, not being able to discharge somebody or having to discharge somebody from to go to a nursing home, but them not wanting to take them. Now I can see where the issue lies. So I think that's something hopefully that we can discuss and work on. But I'll definitely.
They won't go. That's right.
Yeah, I'll definitely reach out to Kara. I have a couple more questions, but I think she might have the numbers that I'm looking for. So thank you for your testimony.
She did have all the numbers. we broke it up into threes, but it's limited to be able to do that in 3 minutes.
Thank you very much.
You're welcome. Thank you.
Thank you so much for joining us. Next up is Wyatt Bosworth, followed by Mark Schaefer.
Hello, can you hear me?
Yes, we can.
Great. Well, good evening, Chairs Wood, Lesser, Ranking Member Huang, and Pavlak D'Amato. My name is Wyatt Bosworth. I'm an assistant counsel with CBIA. CBIA is Connecticut's largest business organization with thousands of member companies representing a diverse range of industries. 95% of our member companies are small businesses with less than 100 employees. I'm here today to voice CBIA's opposition to the governor's bill, House Bill 6447. While we certainly appreciate the governor's desire to stabilize the individual marketplace and expand coverage to those who currently don't qualify for adequate APTC assistance from the federal government, we are concerned about the additional financial burden such assessments will cause for the individual and large group markets. Additionally, the recent developments in Congress with the American Recovery Act precludes the need for Connecticut to fix this problem by itself. Just note that I'll just be speaking on the assessment portion of the bill. I would refer you to my colleague Paul Pescatello's testimony on the drug pricing and CBIA's position. So assessments and taxes continue to be a major driver in overall insurance costs for individuals and small businesses. Recent data I acquired from the health carriers shows that fully insured plans incur close to $360 million annually in assessments, taxes, and fees. Self-insured plans incur around $74 million annually. And this results in a per member annual cost in the fully insured market of $591 annually and $54 annually for the self-insured market. We do appreciate the language on lines 139 to 143 that essentially exempts fully insured small group plans from the assessment, but we still oppose the bill due to the financial burden that would be disproportionately levied on the large group and individual markets by this assessment. The assessment also serves a duplicative purpose due to the pending COVID stimulus bill before Congress. The American Recovery Act recently passed the US Senate and is before the House for a vote either tonight or tomorrow. This package includes some of the biggest, most monumental reforms to American health insurance since the passage of the Affordable Care Act in 2010. And if signed into law by the president, the act will achieve the same objective as the governor's bill, similar to SB 842, but without inflicting an additional financial burden on health insurance carriers and consumers in the state. So current law limits eligibility for tax credit assistance to households whose income is from 100 to 400% of the federal poverty level. The stimulus bill would remove this cap and would also limit the amount anyone pays in premiums to 8.5%, which is currently 10%. The Congressional Budget Office reports that expanded eligibility will result in 0.7 million more people obtaining health insurance to the marketplace, with over 40% of them individuals who are currently ineligible for any tax credit assistance under current law. And if you look at my testimony, I attached the CBO report that I think may be of use to all of you on this committee. So I'll just close by saying that we urge the committee to reject this bill because federal dollars are imminent to fix the subsidy cliff on the exchange, which we fully appreciate and understand is a major, major problem. But we also urge this committee to pass other measures like a reinsurance program that relies on state funds in lieu of new assessments so we can begin to stabilize the individual and small group markets.
Thank you, Wyatt. Thank you for your testimony. I will turn it over to questions. Representative Meskers.
Thank you, Wyatt. You know, I'm appreciative of the commentary and your concern about assessments and cost shifts. But as an observation, I'll repeat what I said prior, which you're representing the entire business community. A majority of them are consumers of healthcare and healthcare costs. And I think the issue going forward is going to be one of containment of healthcare costs, because it's overwhelming your industry as well as my constituents. And if a policy is costing $25,000 to $35,000 a year per employee, we're going to have issues going forward as that grows at 7% a year. So I appreciate your concern for assessments. I know that the government is coming forward with some plans which will alleviate some of that, but without directly dealing with hospital costs and pharmaceutical costs, I think we're all on a path that's inexorably going to create a problem for us. I understand the concerns. I would just respond by telling you that I'm looking for someone to address those issues, and that falls to the legislature to an extent, and whether that's the state or national legislature, that we have to do something with the cost containment, and that's not happening. So I thank you for your testimony. I appreciate your concerns.
Thank you.
Representative Nuccio.
Sorry, I couldn't find my mute button there. Thank you, Madam Chair. Good evening, Wyatt. How are you?
I'm just dandy. How are you, Representative?
I'm just dandy also. Thank you for your testimony. So I had a couple of questions I was hoping maybe you could kind of help me parse through. So CBIA, you guys have been pretty vocal about the plans that are before us. So currently we have this plan, which I think does take a step in a direction to try to start dealing with healthcare costs, but also has the punitive tax and premium pieces of it. Then we have the public option piece, And then you have, which I agree with you, I believe a lot of the pieces of that are being directly impacted by what the private industry is doing. And also this federal package is going to be very significant in the change for that. And then we have SB 1006. And I was wondering if CBIA has any, where are you guys headed for a combination or a compare and contrast of these bills, and which ones you think would be best for your members in the industry?
Yeah, I mean.
Oh, and I'm sorry, I don't mean the insurance industry. I mean your business members.
Yeah, absolutely. And while the insurance industry are members of CBIA, we are, by and large, we represent small businesses in the state that buy health insurance from those companies. So I'm here on behalf of them. And our position on public option, I'm sure. But with assessments, we just have businesses who just don't want to see the cost of their premium go up anymore. And if assessments were to go forward, I think we certainly appreciate exempting the fully insured small group market, right? Because that's the market that really feels the pain every year when it comes to premium increases. But I think, as Representative Meskers said, we really have to understand the problem with the cost of healthcare and why it's rising so much. I think CBIA, we appreciate the benchmarking plan put out in 2006. Building on the progress of the Office of Health Strategy, codifying that executive order into law so that program is here to stay, and really beginning to identify the major cost drivers, including primary care, which the bill sets at a 10% cap, which I think is integral to getting a rein on healthcare costs and keeping people more involved in primary care services. Reinsurance, that's something that has bipartisan support this year. The governor signaled his support for it. The House Speaker did. I know some of you on this committee have, and that's another important part of the bill as well. But I think the place where we become cautious is where we start to rob Peter to pay Paul, where we, where we're essentially picking winners and losers by, picking out who to levy this assessment on and who will benefit from the assessment. And, that not only hurts the people whose plans are subject to the assessment, but it also hurts the carriers that will be taxed in a retaliatory way if they ever want to expand their business out of the state of Connecticut, and ultimately lower the incentive for them to remain domiciled here. And there's thousands of jobs supported by the industry in and around Hartford that I think we need to do everything we can to make sure they stay around. So I don't know if that answered your question, but we want to expose cost through benchmarking. We want to make that information available to the public. We want to hold the insurers and the hospitals and the payers accountable. And then, we also want to take advantage of all of the federal dollars coming in. There's massive expansions to the ACA hidden in this COVID bill. Medicaid incentives to expand in states that haven't expanded, extending and expanding COBRA, extending free health insurance on the exchange to those who, received unemployment compensation this year. The federal bill does a lot, and it really removes the need, I think, for Connecticut to inflict any more harm, because it's going to achieve the same purpose in a much less fashion. So
I agree. I do think there's a lot of incentive in this federal bill that is going to change the landscape, at least for the immediate couple of years. So I think we agree on that. And I'm going to be honest with you. I know it's painful and it's ugly, but I love the idea. I love the thought that people are starting to recognize what legislation means to their insurance premiums. It's kind of what I do, where I work my real job and my other job. So for me, that was always a driver for me. When you look at all the legislation states pass in state assessment and you start to add them up, it's significant. It is very significant. And Connecticut is obviously one of the 50 plus states that do it. So the fact that people are being educated enough to understand the driver, part of the driver of their insurance cost are these assessments and taxes, that's reassuring to me, because that just means that I'm doing my job well on the other 9 to 5. But along those lines, I read the article that CBIA put out with the public option. I just was wondering if you've heard back yet from your FOIA request for the state plan.
Yeah, so we didn't ask for a FOIA request. The health insurance brokerage firm Brown & Brown, which has a number of clients in the partnership plan and really makes its money from selling coverage on the partnership plan. We rely on them to grab the FOI data from the partnership plan every year. They send the request to the comptroller's office. The comptroller sends the plan's finances back to Brown & Brown, and then they report that financial picture to their clients who've obtained coverage through the partnership plan. I think from CBIA's perspective, and this kind of came after the comptroller sent a letter addressed to me after I essentially attached the report to some testimony I submitted to the Appropriations Committee. He doesn't feel like the Brown & Brown data paints the full picture, but the thing is, it's his data. It's his data. And if he doesn't agree with his own data, I think from CBIA's perspective, we think if public option is going to be the vehicle this year, and we want to add people to that plan, we should understand fully the financial outlook of the partnership plan before we expose the taxpayers of Connecticut and the small businesses and nonprofits of Connecticut to any financial liability moving forward.
I agree, and I think it's important to note that industry has stepped up in regard to this. We've now seen both Anthem and Cigna come out to offer new fully insured plans to the small business market, which I think have more transparency, but that's a whole nother conversation. So thank you very much for your time. And at some point, I would really like to sit down and talk to you guys a little bit more about your vision on how benchmarking could help. So we could try to incorporate that somewhere.
Yeah, and then I'll be at the hearing on Thursday as well. So I'd be happy to exchange with you then as well.
Perfect. Thank you. Have a good night.
You too.
Thank you, Senator Wong.
Thank you, Madam Chair. Good to see you, Mr. Bosworth, and thank you for your past testimony. And it's important for people to know that CBIA represents not only that you represent thousands of small, mid-sized, and large businesses and hundreds of thousands of employees, and you are a consumer of health insurance products. So this is very important for your clients. That being said, elaborate a little bit more. I mean, the tax or assessment in the governor's bill is a solution of getting revenue to kind of fulfill the components of the reinsurance program. You articulate in your testimony that the $1.9 trillion package that is about to be signed, hopefully by President Biden, will allocate significant and unforeseen federal dollars for healthcare. Explain to people how that could work instead of assessing or taxing insurance products, which will end up in somebody else's pocket or costing somebody else's money. Talk about how you envision using federal money, taxpayers throughout Connecticut that pay into the federal fund and get very little back. How can we maximize that? How does that work, if you could?
Yeah, so let me just say again, it's really, really hard to overstate how big this healthcare package is for this country and specifically for Connecticut. So I'll just tell you what the individual market subsidy portions in the American Recovery Act do. So first, it fully subsidized the second lowest cost silver plan for consumers with incomes up to 150% of the federal poverty level. And second, it enhances the tax credit sliding scale for those above 150% of the federal poverty level and eliminates the 400% federal poverty level ceiling. So for example, I think someone making more than $55,000 a year, they fall off a thing that's called the subsidy cliff, right? These middle class, hardworking jobs, there's a harsh cutoff at around $55,000. This bill removes that, okay, and instead caps premium contributions to 8.5% of income instead of the 10% ceiling that was currently under law. It also greatly expands subsidies to those under 400% of the poverty level as well. So I think essentially it's doing close to the same thing that this bill aims to do, right? It's expanding coverage on the ACA, it's expanding subsidies, it's boosting up both the bottom and high end of the federal poverty level threshold, and it's doing so without imposing a penalty on large group and individual plans. Okay, so I just think it's good public policy, and our members think it's good public policy to just sit back on this one and let the federal government and this $1.9 trillion package lower the cost of healthcare by itself. Now, obviously, this bill is going to expire in 2022, right? So this is not a permanent fix. This is going to be a constant political question moving into the midterms in 2022. I'm sure it'll be a central part of all of your races in 2022 about what we do with healthcare. But for the next 2 years, the bill does exactly what 842 does. It does exactly what the governor's bill does, but without the penalties.
You're talking about Senate Bill 1006.
Correct.
Thank you. Talk to me a little bit about, I mean, reinsurance is a product that obviously the governor has put into his proposal, but also there's validation of it, right? From the standpoint, we've heard references to the Wakely report, and why, before you answer, I just want to have kudos. The celebrity of the day, Senator Lesser and the baby. There you go. Sorry, Wyatt, for interrupting you, but that being said, can you explain a little bit? I understand the Wakely report was actually a report requested by the legislature or state government, right? It was objective and as an agency. Can you elaborate a little bit on that?
Yeah, I mean, it's a credible report, and I think your caucus's bill lended great credence to the report by, using the $20.2 million allocation. That's the number that the Wakely report signified as, the ceiling for getting a 5% reduction in marketplace premiums. And it also, the Wakely report shows, and the governor's policy director, Mr. Dock, said today, essentially the federal government through pass-through funding will match state funds on a one-to-one basis. It is one of the best ways to really capture federal pass-through funding and take advantage of the funding scheme under the ACA. So yeah, I mean, the Wakely report is something CBIA has reported on. It's something many of you have reported on, and I think it carries great credibility in this discussion.
Yeah, and I appreciate explaining that, because I wanted to acknowledge Representative Metzger. I've been listening to him today. He's asked some very insightful questions, and I agree with him. Let's get to where we can contain the cost. And I think one of the challenges we have, Representative Metzger said, who's going to pay for it, right? And I think what we're looking at is not simply a state-run health plan, but solutions to minimize cost. And reinsurance is one, but talk to me about a second component, which is benchmarking. The governor, again, has kind of reiterated that by first having it be part of his executive order in initiating and having the Office of Healthcare Strategy begin the benchmarking process. Could you elaborate a little bit in regards to your role as counsel, but also an educator, and exchange with all of your members? What does benchmarking mean, and how does it really save money? And why did the governor propose it in his executive order, but also consider it now in his proposal?
Yeah, and I think one of the flaws with the bills that have been proposed to date dealing with healthcare reform is we really we're essentially shifting money around, right? We're trying to tax one entity to lower the cost for the other entity. But all of these reforms, eventually costs are going to catch up to them, right? If it's going to be $50 million this year, if pharmaceutical pricing and hospital spending and specialty drugs and specialist spending keeps skyrocketing as they do, it doesn't matter how many times you come back and pass a new assessment, you're still not fixing the underlying problem. And I think that's what Representative Metzger was getting at. And benchmarking really is a useful tool for states to identify what are the cost drivers in healthcare, whether it be pharmaceutical spending, hospital spending, specialty spending, primary care spending. And it allows the state to kind of set a benchmark, right? Let's say 3%. Costs cannot increase by 3% in the upcoming year. Insurers and payers will be held accountable through public hearings and reports they have to give to the state, basically saying if they've complied with the cost growth benchmark. This is done in Massachusetts. And if they don't comply, they're going to be under intense public pressure to get their stuff together. They're going to have to submit to performance improvement plans, be in constant contact with OHS and truly work towards reining in spending. And I think what's amazing in Massachusetts is, Governor Baker claims $5 billion has been saved by reining in the growth of healthcare costs in the state. And they've done that without ever utilizing a performance improvement plan, meaning they never actually had to penalize an insurer or a payer to play by the rules. And I think that's really fascinating because the public pressure was enough to make the insurance companies comply. And I think codifying the governor's executive order and working with OHS to really develop a robust program so we can begin to expose the true drivers in healthcare. I think that's a necessity for trying to fix any of these problems. We have to understand the problem before we can fix the problem.
Thank you, Mr. Bosworth. And I want to extend, the last time we had the exchange, your president, Chris DiPentima, and maybe I could just close with a comment that I saw online that Mr. DiPentima's comments was, we're not philosophically opposed to market competition, as Controller Limbo says, that we are opposed to putting taxpayers and small businesses at risk with a new state-run healthcare plan modeled on one with major unresolved question about its financial health. I think we're unified in that question, that ultimately, with the possible proposal, it is the taxpayers of Connecticut that is on the hook in liability. And that is one that we have to tread very carefully on. So, Mr. Bosworth, thank you very much for your work, and extend my best to your membership that represent businesses in the state of Connecticut. Thank you. Thank you, Madam Chair.
Thank you, Wyatt. And your testimony was very informative. Your written testimony is also very informative. So thank you for submitting that. I hope the committee members take time to read it. Next up is Mark Schaefer, followed by Tom Swan. Is Mark Schaefer on? Diane, is he not coming on? Okay, is Tom Swan on? Okay, Mark Zatirka, you are up, followed by Sharon Hanford.
All right. Hi, how are you? Thank you for having me here today. I am testifying in favor of Senate Bill 1003. I'm here today as a representative of the nonprofit patient organization, the New England Hemophilia Association, as well as myself, a patient living with a high-cost chronic life-threatening disorder. My name is Mark Zatirka, and I live in West Suffield, Connecticut. I was born with severe hemophilia A, which affects all parts of my life. Due to the internal bleeding that I've had throughout my life, my body is severely damaged, and I'm left with severe chronic pain. I've also come close to bleeding out on a few occasions. I have to give myself an infusion into my veins every other day at the cost of about $3,000 per infusion. I wish my medicine wasn't so expensive, but unfortunately I have no other options. While our medication is expensive, it's important to note that we do not have any generic options available to us. Hemophilia is an inherited rare genetic condition that affects an estimated 500 people in Connecticut. And due to the exponential increase in deductible costs and out-of-pocket maximums, many of us in the bleeding disorders community rely on patient copay assistance programs. We rely on these programs like our lives depend on them. these accumulator programs force subscribers to pay their entire out-of-pocket maximum early in the calendar year with one of their first prescription fills because our medication is so expensive. Very few individuals can pay the $8,000 upfront cost or $17,000 for families in order to receive their monthly shipment of medication. The argument that accumulators are needed to prevent patients from purchasing costlier brand name products makes no sense for those with hemophilia and many other conditions where no generic alternative is available. I can't tell you how grateful I am to have had access to copay assistance from the company that makes my medication. Many families living with chronic illnesses barely get by living paycheck to paycheck, and requiring them to come up with even $3,000 or $8,000 immediately if they want their child's medication is not only not fair, but it's not feasible and it's not humane. Recent research in 2 of the states that have already acted to restrict copay accumulators found there was no noticeable increase in premiums. Families living with chronic illnesses like hemophilia are not choosing their medication based on copay cards. We don't have generic medications to choose from. All pharma companies offer almost identical benefits, and benefits that are allowing families to afford their life-saving medications, benefits that allow families to remain compliant on the therapies that were prescribed by their doctors, and benefits that keep adults and children out of bankruptcy, and benefits that keep adults and children alive. So on behalf of my family and all Connecticut residents living with a bleeding disorder and other chronic illnesses, we urge you to support the passage of Senate Bill 1003 so that patients are able to fully access the cost-sharing assistance available to them. Thank you.
Thanks, Mark. My question to you is, do you need to meet a deductible at the beginning of every year in order to afford your medication?
Right, and so with lower cost prescriptions, that deductible and out-of-pocket expense isn't as radical as it is for folks with more expensive drugs. So depending on the plan, that one monthly shipment can be more than what your entire deductible is. And so some families have to come up with that price in order to get their first fill of the year.
Okay. I'm sorry to hear that, and thank you for sharing your story. Representative Metzgers.
I want to thank you for your testimony. You gave it in a very flat, calm, and clinical voice. And yet when you listen to the details and the ordeal you're through, you should know that we're all cognizant of that. And this is part of the face of what we're trying to resolve, both from the orphan diseases or those that are rare diseases with copays, with the mechanics of this, with the lack of transparency, with either cost shifts or copay shifts. And it's making a system that is picking both winners and losers, and ultimately we're all losing from it. So, know that, I think this proposal, I have to read through it. I'm not as familiar with all the details, but know that I'm inclined and favorably disposed from the testimony I've heard today. And it's part of that bigger picture, is that we need to acknowledge the fact that healthcare is becoming unaffordable. You're just the spearhead of a horrible issue that people are facing. And so I think all of us, including Senator Wong, who and I will not necessarily agree on all of where we get to where we want to get to. We both have to sleep at night with our children, with our children's issues, with our medicines. And we have to think about people like yourselves and our ability to make sure that you have fair and accessible access to what you need to survive. So don't think that your testimony fell on deaf ears. And thank you very much.
I appreciate that. And yeah, I agree. Our healthcare system has some issues and definitely needs work and things needs to be fixed. But to do that on the backs of those of us living with chronic illnesses, I don't think is the right place to start.
Senator Wong.
Thank you. And I want to echo Representative Metzger's thoughts. Your testimony was incredibly thoughtful, but it also reflects an individual who's lived with that illness your whole life. and there's a patience with you that you sense. And I want to echo Representative Mesker's acknowledgement of that. And you're right. I said it earlier on this discussion as we'll talk about it. I do believe health insurance and healthcare is a human right, and we need to find a solution to resolve it. We need to be able to provide care for every individual that wants it and needs it. So the way is, how do we find that solution? That's the crux of the problem. But your testimony and your insight and your courage in being able to spend the time to share your story is an important role and a talking point for many people that you represent. So I want to thank you for being here with us tonight and sticking it through all day. So thank you, and thank you for your powerful testimony.
Thank you, Senator.
Next up, we have Sharon Hanford, followed by Sam Hallemeyer.
Good evening, Representative Wood, Senator Lesser, Senator Anwar, Representative Comey, Ranking Members Hong and Pavlik D'Amato, and distinguished members of the Insurance and Real Estate Committee. I'm a little nervous, but thank you for allowing me the privilege to be here. This is my first testimony. My name is Sharon Hanford, and I am a woman in long-term recovery. And I am also a certified peer recovery specialist. I'm here to represent myself and advocate with my peers for support of this Section 5 of HB 6588. Peer support services are an essential role in healthcare to support the recovery process. And the peer mentor is something that can't be duplicated unless you've been in that position. In Connecticut, if we are to increase the pathways to peer workforce and improve upon recovery outcomes, we must make certified peer recovery specialists reimbursable. In my personal experience and role as a CPRS, to shorten the time, working with mental health and substance misuse clients, I have an ethical standard by which I practice and my peer support and coaching. I've gained respect for my colleagues, and I continue to be accountable and continue with continuing education credits. With Bill HB 6588, we can prevent further corruption of the peer support role and clearly define. We have the flexibility of a broad job to define the flexibility of a broader job description. We recognize that we are professionals and we've earned our credentials. We can have a fair and living wage. And peer support offers opportunity to recreate a life with joy and purpose as I have lived, and I can identify with the peers that I work with. Please support HB 6588 and help Connecticut take crucial steps towards improving our system of care through essential peer support services. Respectfully, and thank you for your time today. Sharon Hanford.
Sharon, thanks so much for your testimony. Representative Dathan.
Thank you very much, Madam Chair, and thank you, Sharon, for your testimony. It was very heartwarming and very brave of you, and you didn't look like a rookie. So appreciate you coming in and you look like an old pro. So I just wanted to kind of ask, in your experience, why do you think we should do a task force whilst we're looking at this, and what do you envision that this task force will learn?
So what I'm hoping that will come out of it is that we'll be recognized as professionals and that we'll become billable for the people that we are working for, as well as the quality of life for my life as well as my peers. So I think that it's important that when we look at the bill as a whole, that we're looking at the people who are serving the community and the people, and to unify it. I just think that it's important that we have a standard, that we have recognition, that we are uniformed, and that we bond together because we are professionals. And I've gone through, and I've been on this all day. I listened to the woman from Advocacy Unlimited, Michaela, and she talked about, the CCAR part, and she talked about the Advocacy Unlimited part. And, I went through CCAR and I received my CP recovery coach professional. And I went through Advocacy Unlimited and received my recovery support specialist. And then I went further with all the accreditations and the time and the hours that I'd put in, and I received my CPRS from the state certification board. So for me, I've done the homework, I've done the hours, I've done the work, and I provide that service and the professionalism and the ethics to my clients. Not saying that nobody else does, it just really makes it full circle as a career. So with my lived life experience and going into this as a career, it just kind of bonds it all together.
Well, that's basically what's going to be my next question is, it sounds like you've made a career out of this, and you've been through a difficult experience in your life, and it's probably very satisfying to know that you are able to build your life up based on your experience and be successful and help other people. It must feel very rewarding. So just wanted to say thank you for your work on that, because it does mean a lot to the people of Connecticut, and I'm sure your clients are extremely grateful. So thank you for your testimony, and thank you, Madam Chair, for letting me speak.
Thank you.
Thanks, Sharon. Next up, we have Sam Hallmeyer, followed by Frank Musante.
All right. Good evening, everyone. Thank you, Madam Chair, members of the committee. My name is Sam Hallmeyer. I'm Director of State Affairs here on behalf of the Pharmaceutical Care Management Association, otherwise known as PCMA. And I'm here to oppose Senate Bill 1003. PCMA is the National Trade Association representing America's pharmacy benefit managers, otherwise known as PBMs. These PBMs administer the prescription drug plans and operate mail order and specialty pharmacies for more than 266 million Americans. So PCMA, again, opposes Senate Bill 1003, which would require health insurers to count all payments made by patients or a third party towards an enrollee's cost share. These drug manufacturers encourage patients to somewhat disregard formularies and lower cost alternatives by offering these coupons to help the patient cover that higher cost. Ultimately, this steers patients away from cheaper alternatives and towards these more expensive brand drugs. The state of Connecticut, as I've heard you mention throughout this hearing tonight, is looking at cost of care drivers, and these coupons at the end of the day raise the cost of care. And here are some figures along those lines. The prices for drugs with manufacturers' coupons increase faster, 12 to 13% a year, compared to non-coupon drugs, which we see at 78% a year. Medicare has a ban on coupons at the federal level, which is considered an anti-kickback statute. And if it were not enforced, the cost of the program would increase $48 billion over the next 10 years. Coupons are responsible for a $32 billion increase in spending on prescription drugs for commercial plans. And then one more stat I have for you. For every $1 million in manufacturer coupons for brand drugs that they offer to patients, these same manufacturers reap more than $20 million in profits. So that's a 20-to-1 return. I do empathize with those that have spoken before me when they go to the pharmacy counter and they get their medication and they're hit with this sticker shock at the beginning of their plan, such as January, when they have these $1,000 copays. Supporters of these coupons say that they decrease cost for patients. And while this may be true, at the pharmacy counter, they do not reduce the actual costs overall. Additionally, coupons are temporary. The individual patient likely pays more when the coupon goes away. They are capped. Instead of being started on the formulary drug from the start, it is the manufacturer who benefits by steering that patient towards a more expensive drug, and they end up paying for that more expensive drug. If the drug companies were concerned about patients accessing medications, they should simply just lower their prices. But drug makers have determined that it's more profitable to increase copay assistance rather than just making the medications more affordable. Again, the simplest, most effective way to reduce patient costs on these drugs is for manufacturers to drop the price of the drug. I'm happy to work with members of the committee and other stakeholders on this bill, but it's for these reasons and costs that we must respectfully oppose Senate Bill 1003. And I'm happy to take any questions from the committee members at this time.
Do we have any questions? Sam, thanks for coming on. We appreciate you waiting.
Sure. Thank you, folks.
Next up is Frank Musante. Is Frank on? I don't see a Frank. Next up is Ellen Andrews, followed by Teresa Sprague.
Hi, there I am. Hi.
Hi, Ellen.
I'm Ellen Andrews from the Connecticut Health Policy Project. I'm here to, it's actually, again, I've been, it says that we support 6447, but in fact, we strongly support the tax on drugs, but we have grave concerns about the Covered Connecticut, the second half of the bill. The drug costs are growing faster in Connecticut than any other healthcare sector. In 2018, Connecticut residents spent more on drugs per person than all other states except New York. We spent 21.6% more than the US average on prescriptions, and it was prices. And it's not that we're utilizing too much. We're just, the prices are out of control and we can't afford it anymore. The higher spending is driven by skyrocketing drug prices. The Institute for Clinical and Economic Review found that in 2019, price increases for just 7 drugs cost the US health system $1.2 billion extra with no improvement in value. The governor's tax on excessive drug price increases in 6447 is one of the best options to make healthcare affordable in Connecticut. And healthcare drugs are one of the main drivers of increasing premiums, which I know this committee has spent a lot of time thinking about how to address. As for the second part, we have serious concerns about the proposed Covered Connecticut plan. And federal resources are coming, as you heard from Wyatt from CBIA, to increase access health subsidies, making the risks unnecessary. The plan to spend $50 million in taxpayer dollars to reduce Connecticut's uninsured, well, I guess it's not all taxpayer dollars, but uninsured would be developed by only 4 officials, appointed leaders of state entities not accountable to the public. Their scope in developing the plan is extremely broad, and there are possibilities outlined in the bill. There's no limits in the bill. And the provisions for public input or feedback aren't there to ensure that the proposal won't fail and won't do more harm than good. The bill's overly broad, unchecked authority invites unintended consequences. This happened in the state innovation model, the SIM model, also run by OHS, because of conflicts of interest were a serious issue. And it basically didn't work anymore. It didn't work. We spent $45 million in 4 years on SIM, and it ended up going nowhere. And I would hate for that to happen again. And this one, though, that was $45 million in federal money, which is one thing, but wasting money if you get it from increasing premiums and making it more expensive is a bigger problem. It's the current federal COVID relief bill that's close to passage includes significant changes to improve the affordability of coverage, including increased exchange subsidies and removing the income cliff that excludes a growing number of uninsured Connecticut residents. And federal policymakers have signaled that they intend to do even more. So Connecticut should wait.
Ms. Andrews, you've reached your 3-minute mark. If you could just summarize, please.
Sure. We just want to see Connecticut wait to see the impact of the federal changes before implementing a large tax on premiums to create an open-ended, unaccountable plan that could do more harm than good.
Thank you, Ellen. I wanted to just ask a question on the unintended consequences piece of the SIM plan. Can you explain a little bit about that? I'm not aware of that.
Yeah, this actually happens a lot. It happens in the public option. It's happened in many places. You could end up with poor planning, for instance, implementing a program that, improved it in some places and made it worse in others. It's, yeah, I'm sorry, it's late and I've had a long day, but I'm sure you had a long day. But there are unintended consequences lots of times when you make changes to things in ways that especially if you're not monitoring for what those might be, and there's no evidence that they're going to be looking at how this could change access to care especially in underserved communities.
Yeah, I kind of felt reading through there was a little bit of vagueness in there, so perhaps we could
a little bit
work together on that. But how would you structure something like this with more oversight? Is it having a board? Is it having, more requirements for the legislature in terms of benchmarks and things like that? I was just wondering how best to structure something so that is something that I've heard and read in a lot of the testimony. So I just was kind of brainstorming, how that would work better than how it is now.
I would argue strongly against a board. There are a lot of boards for a lot of these things. SIM had a board, a standing advisory committee that was chosen by OHS, not in the usual way, by the different legislators, from both sides and different agencies. It was all chosen by OHS to support a specific outcome. And so I would not suggest that you have a board. I think you need to get a lot of public input and hear what people have to say. And I think there needs to be monitoring and then lots of public transparency about what those things have happened. I think the bill needs to be a lot more explicit about what the money can be spent on. I mean, I heard earlier, what was it? 7 hours ago now, that they were talking about out-of-pocket costs because that might be a gap that might be not filled by the federal money. But we want to make sure out-of-pocket costs are a double-edged sword. You want to make it possible. Obviously, we don't want anything like what's happening with hemophilia patients, but there are out-of-pocket costs can help get people to think about medications, and it does keep people from filling everything. They start to ask more questions of their doctor. Well, why do I have to have this? How much is it going to cost? That's not a bad thing. And there's also a dignity to that. We've had that in Medicaid sometimes when people have testified, I'd be willing to pay, a few dollars for something. There's a dignity to it. So I think we really need to monitor for how what we might think is going to do a good thing doesn't really. And also sometimes things are put in place and they're so expensive to administer that the juice just isn't worth the squeeze.
Thank you, Ellen. Senator Lesser.
Thank you, Madam Chair, and thank you, Ellen, for your testimony. It's good to see you. I want to just go back to Representative Wood's question about your concerns about the subsidy language in this bill, the Covered Connecticut program. First is I'm recalling back a few weeks ago to your testimony on Senate Bill 842, when I believe you testified in support of the language in that bill, and they're both about the same amount. They're both $50 million. That bill has much more prescriptive authority about what the money should be used for, and also about legislative oversight. Am I to understand from your testimony that something more along the lines of the program in that bill would be a better way to go about solving presumably the same problem?
Yes, I think more prescriptive about just some guardrails around what the money could be spent for. And I do think some legislative oversight is really important, and public transparency. I'm a consumer advocate, and if you want to spend money on helping people afford insurance, I am all for that. I just think we need to be really thoughtful about how we do it. And, sometimes what you think is going to work doesn't. And so we really need to monitor. I know I sound like a broken record, but we don't do it. We just put things in place because they sound right and they end up not working.
Well, that bill, I think, is pretty prescriptive. Among other things, it directs that premiums be eliminated for persons on the exchange with incomes of under 201% of poverty, which is something that becomes a little bit easier with the passage of the American Rescue Plan tonight, but isn't fully done by that bill. So, I'm hoping that we provide enough guardrails in that bill to really make sure that we have an appropriate level of legislative oversight, and then we would have to vote on any plan. It wouldn't just be adopted. If you have other suggestions for how we can ensure adequate stakeholder engagement or community engagement, that would be helpful. Something for us to consider. And if you want to send it to the committee, I certainly appreciate it.
Yeah, that's a much longer conversation. And how do you reach out to, that goes back to like days when I worked for the Medicaid Council, how did we engage, especially communities of color and underserved populations when, we had these great ideas that we thought that were just going to solve everything for them. How do we really engage them to find out, to test it first, to see if we were as smart as we thought we were? That's a longer conversation.
One last question. We saw some testimony in the last hearing about the inclusion of racial and ethnic data collection as part of the process throughout our efforts to increase the insured rate in the state. Is that something that you think would be an important thing to write into the law?
I think that would be great to include. On that, though, again, it's sort of like the cost cap issue. I just, we can get data till the cows come home, but we do have some idea. There is a problem. We know that there are disparities, and there are tested options that are working in other places, and we could test them here. So I don't think we should wait for data. I think we should get it. We need it to see whether we're doing better to evaluate those things. But I think we should start working on the kinds of things that can make a difference as soon as we can.
Thank you very much.
Representative Meskers.
Thank you for your testimony. I think it's always good to bring to us the framework of the question of do no harm and do good, in terms of, the road to hell is paved with good intentions. So I appreciate that. So I notice here that, so the first commentary on the bill is in support of the pharmaceutical tax, basically, or the assessment on drug prices. You didn't have any problem with that. Do you have any thoughts in relation to the hospital system with a corollary like that?
Yeah, that's harder. It's a lot harder because it's consolidation and antitrust. And we had a great presentation from, I'm blanking on her name and I probably couldn't pronounce it, but from the Hastings School of Law at the University of California this morning at the Healthcare Cabinet. And they've been studying this and had a lot of ideas around, tiering and steering. There would be that large systems can force contracts where you have to put them in the highest tier, meaning the lowest copay, regardless of their prices and regardless of their quality. Covenants that physicians sign on to when they join things where they cannot non-compete, they can't leave, and when they do, or they come in with huge bonuses that are often funded by, is my understanding, facility fees at their same practice. So as a patient, you're going to a doctor and he's an independent doctor one time, and then you go back next year for your mammogram or whatever, and all of a sudden it's $1,000 more. Well, that often funds those increased bonuses that they get for signing up. There are other things within that state contracting, which is governed by state law. So, and I am not an attorney. I've been dragged kicking and screaming into the law. So I shouldn't go any further than this, but there are things within that we could do. And I think the first thing we should do is there should be a moratorium on more CONs and more approvals. We have to lower the limit for which you have to get a CON to bring more doctors into a large health system. Right now, it's way too high. And we need to, there was something else in my head, but it's gone. I'm sorry.
Related to the competitive environment, basically.
There are actually quite a few things that we could do, and she gave us more to think about this morning. So I think it needs, and I'm usually not a fan of committees, but I do think it needs a task force of really smart people, independent people to get together and talk about what would happen, because these could have unintended consequences as well. So we want to make
Exactly.
sure we're not making.
So if
more-
there happens to be a cheat sheet or summary of the presentation you got today, maybe through our chair or illustrious chairs, you could send it on to them and we could have, because, we need those, we need to finish off the ideas to do, what we're, again, no one wants to hear me go on again. It's pharmaceuticals, it's hospitals, insurance is the small end of the stick where we're paying through the nose, and we have to figure out how we get control of this.
Yes, you're right. And I'm glad you're looking at the drivers, the consolidation and the drug costs. That's the rest of it. I agree with whoever said it, is we're just shifting money around otherwise.
Well, if, and again, just not to beat that dead horse, if we double the price of insurance in the next 7 years, which is basically pharmaceutical and hospital care, and we're at 50,000 for an insurance policy, we aren't going to have a private system.
Right.
So you could argue in some ways that I'm in favor of this private system. It needs to survive, and it can't spread a cost that at 50,000 a head for insurance. It's just not sustainable. I mean, CBIA will come out and scream against the industry and against the medical industry when all of their industrials and all the small mom and pops have to pay those kinds of premiums to give health insurance to their employees. So we really do have to do something. It's important.
And consolidation has other drawbacks as well. I mean, I live in New Haven, and I used to have a choice of 2 hospitals. When I had my son, I had him at St. Rafe's. Now you don't have that choice anymore. So it does also reduce your levers to make decisions based on quality. And we heard this morning that consolidation, they always sell it as it's going to increase quality. It never does. In very narrow circumstances, does it increase quality? And there are plenty of circumstances where it reduces it.
Thank you very much.
Senator Wong.
Thank you, Madam Chair. Ellen, great to see you. Thank you very much. Now, obviously, we see the support that you have on part 1 of the governor's proposal on the prescription drugs. But what do you say to the fact that it could be a balancing point, right? Because one of the challenges we have is we have one of the best innovation and research, biotech and pharmaceutical entities in the world, as evident by our ability to create the COVID vaccine in less than a year, which is, to me, an incredible miracle. You have heard some feedback from the pharmaceutical companies as the fact that there's a contrast in regards to cost containment versus innovation. We as a country, and maybe in some ways, as said earlier, is we bear the burden of innovating at the expense of benefit to the rest of the world. Where do you create that balancing act, right? Because you've heard some testimonies today where, they've vehemently opposed these kind of restraints and cost burdens on their ability to compete and innovate. Where's the balancing point? Any?
Yeah, actually, I think there is. I think there's good news on that. And full disclosure, I am on the board of the Institute of Clinical Economic Review. It is a nonprofit based in Boston that with hot and cold running PhDs who look at comparative effectiveness research for drugs and look at on launch, and then also as they increase their prices, they've looked at that, but they also look at the launch of new drugs. What is a fair price for it? What is it worth? Obviously, we'll pay more for something that cures cancer than we would something that cures toe fungus. And it looks at those kinds of things. And then actually, and now, right now, drug companies, a new product is coming so that they could anticipate as they're putting them in the pipeline and they show some promise, which I want to get back to that actually, research and promise, that they could look at it and see what it would turn out to be worth and whether it's worth going forward for them. And that's something that we need to look at because we need to be using the dollars we have very wisely, and so do they for investors. So I do think there are places where we can get to it. I also agreed with the governor's staff earlier today that I think they should set their launch price at a fair price that captures, their R&D costs, and then just increase it by, whatever the CPIU is. And that's fair. And that's a fair process. It's something that, as a patient, you don't want to be started on a drug and then the next year at a low level just to get you on. And then the next year they go up, 20%, then I'm going to get kicked off of that drug or my premiums are going to go up. Either way, I'm in trouble. So we need to get to a fair price and it needs to start from the beginning. As far as research and development, we haven't heard anything about this, but I don't think that I used to be in a former life, I was a scientist, a bench researcher at Yale. And a lot of the people who went through my program and then also postdocs that I worked with are working in for drug companies now. And I think it's really important to understand, and many of them, the work that was done by my colleagues at the time, my other students, were spun off to drug companies because they were promising, and that was wonderful. But I don't think we recognize, all of us were funded by the NIH to do the work that we did. And I don't think that contribution, taxpayers' contributions, is always recognized and adequately included in the cost price, what the basis for prices. Because it's a huge amount. I mean, scientists and the people I graduated with who are still working in that they are the scientists who, many of them came up with the vaccines. They did a lot of the work on it and do the things that get it to a promising place where a drug company picks it up. And I think that's not captured, certainly, in the prices that then we end up paying.
Thank you. And I'm glad I asked the question. Was there something you remember that you were going to say? I just didn't. You had a moment of inspiration. I didn't want to interrupt that.
Talk about the research and the scientists. I'm a big fan of scientists. Drug companies, maybe not so much.
Okay. Now, the second part of your testimony talks about your concern with the Cover Connecticut account, right? Yeah. And we had an earlier exchange with Ms. Veltri and Johnny Dax, and I'll be honest with you. I've always been impressed and have great respect for the integrity of both individuals. But with Ms. Veltri and my work with her in the Office of Healthcare Advocates, I know she's committed, and she made a commitment that she would be receptive to looking at some audit and accountability process. And you have been involved in this advocacy circle. I have the most profound respect and objectivity that you demonstrate. Saying that, I see in your testimony that, look, I believe you, but, verify. Trust but verify.
Rarely quote Ronald Reagan, but yes, we need to trust but verify.
Right? I mean, I think that's the sense of it, is the fact that if you're using either it be federal resources or assessment/taxes or premiums or even appropriated money, you're using money. And there was always a concern. You cite some articles in regards that without transparency, without accountability, or the observation of sunlight, that things may not go as the way you should. And what you're saying in that is, because what we're looking at is pretty much a reinsurance product, et cetera. But what is it? Broad and unchecked authority invites unintended consequences due to poor planning, conflict of interest, and serious unintended consequences, as plagued by the other previous indication of SIMS. So I'm reading through that and sort of like deja vu all over again. And we have an opportunity to not engage in something and putting the cart before the horse, and hopefully we learn our lessons, either to use the federal money to be able to save taxpayers or premium payers tax, to be able to use a plan. So I read your testimony, and even though it was short and succinct, it indicates a tremendous level of objectivity and experience. And I think we all should heed some of the warnings you're giving and not rush too quickly. into any set of policies, and maybe take the best of ideas and formulate that. So I thank you very, very much for your time. I know it's late hours, but I wanted to compliment you for your insight and sharing the experiences that a quick rush to do what is in the best interest, or maybe seem the best idea, or the overpromise may come back and bite us. And you've seen that already. So thank you very much, Madam Chair. And again, thank you, Ellen, for your very, very good and objective and truly bipartisan work on this stuff. Thank you.
Thank you.
Thanks, Ellen. Teresa Sprague is next, followed by Garrett Sheehan.
Good evening. Can you see me?
Yes, we can.
Okay. Good evening. My name is Teresa Sprague, and I'm the manager of patient access at Bristol Hospital. And I'd like to address House Bill 6586, an act concerning prior authorizations and healthcare provider contracts. I would like to thank Senator Lesser, Representative Woods, Senator Anwar, Representative Comey, Senator Wang, and especially like to thank Representative Cara Pavlak-D'Amato for her longtime support of Bristol Hospital and her continued advocacy on behalf of our patients and families. Bristol Hospital supports House Bill 6586, which provides a vitally needed solution to pervasive abuse by health plans of their prior authorization process. Prior authorization is a utilization management tool to ensure that patients receive the right care in the right place in line with their benefit plan and best practices. While Bristol Hospital recognizes the value of prior authorization, we are finding that many health plans are using it routinely for procedures established standards where there is no history of questionable use. My team and I are on the front lines as we communicate to our patients that their procedures are on hold until we receive prior authorization from their insurance company. Stat authorizations are a particular burden as patients are at times left waiting for hours, sometimes in great pain and discomfort, for an authorization that will avoid costly emergency department charges. We recently had a patient that waited hours in our diagnostic area while the provider tried to get an authorization for a stat CAT scan. The patient did end up having to present through the emergency room rather than wait any longer for their authorization. Bristol Hospital registration team is extremely diligent, working weeks in advance to ensure that authorizations are updated and corrected. But there are instances when a patient has had to fast for hours, sometimes days, or even 2 days ahead of time, only to have that procedure canceled because their prior authorization has not yet been approved. This happens for our patients that come in for our testing at our Connecticut Gastroenterology Institute. We've also had patients present for their MRIs, echocardiograms, stress tests, and various other tests that were still waiting on authorization. These patients had to be advised that they could not have their test on their scheduled date because we were waiting for the insurance company to approve that authorization. This leads to frustration and further concern on the patient's part. Many times patients have already waited days and have also taken time off from work to have their test. There are times that it can take between 7 to 10 days to receive the authorization approval. Sometimes an unexpected change can result in having to get another authorization, which results in further delays for the patient. This can occur while the patient is present and ready for their exam. If a radiologist deems that a patient scheduled for an exam that does not require contrast, for instance, needs to be changed to one that requires contrast, it would be a halt in the procedure until the authorization has been obtained and updated accordingly. The need for a change approval adds extra stress to a patient who is already worried about their health and the diagnosis awaits them. Additionally, the systems and the staff at Bristol Hospital has added to address the endless authorization dilemmas are adding unnecessary costs to the health system. The authorization process reduces efficiency because the staff, physicians, and equipment have been reserved for their care.
Ms. Sprague, you've reached your 3-minute mark. Can you just summarize, please?
Just that we please approve the House Bill of 6586 so that Connecticut hospitals can continue to provide safe, high quality, and affordable health care to their patients and families.
Teresa, thank you for coming on and sharing your testimony. We have heard a lot about this, and I really appreciate you coming on and sharing these stories. It is a concern, and we definitely want to be helpful. Are there any questions from the committee? Teresa, thank you.
Thank you.
Next up, we have Garrett Sheehan, followed by Nicole Hampton.
Representative Wood, Senator Lesser, members of the Insurance and Real Estate Committee, thank you so much for giving me the opportunity today to speak in opposition to House Bill 6447. My name is Garrett Sheehan. I'm the President and CEO of the Greater New Haven Chamber of Commerce. It's been very interesting listening to all of the testimony today, and I wear many hats. I too, like CBIA, represent many small businesses, and we are always concerned about the rising costs of healthcare and how that impacts business. But I also wear a hat as an economic developer, and the biotech industry being a primary driver in Greater New Haven, and we've seen a lot of growth over the last decade of our biotech companies. So my opposition is that this portion that adds the cost structure to drug prices is something that came out, just from my perspective at least, came out of the blue and to many of our biotech companies. And it's an area that our state, the governor included, our economic development efforts have been very focused on. So I was encouraged by what I heard from representatives from pharma and many of the other pharmaceutical companies that they want to work with this committee to find opportunities to lower cost and deliver that to the consumer. My request of this committee would be to continue to work with them. I did hear Johnny Dack say that the governor will be meeting with some of the CEOs, and that's by no means to say that you should just listen to what industry says, but that biotech being a key economic driver that we've identified for the state, and specifically for New Haven, I hope that you give them that opportunity to be part of this process and hear them out. So I appreciate your time this evening.
Garrett, thanks for coming on. I appreciate your testimony. Any questions from the committee? Great, thanks, Garrett. Next up, we have Nicole Hampton, followed by Sue Halpin.
Good evening, Representative Wood, Senator Lesser, Senator Anwar, Representative Comey, ranking members Hong and Pavlak Diamato, and distinguished members of the Insurance and Real Estate Committee. And a special shout out to Representative Dathan. My name is Nicole Hampton, and I live in Norwalk. I'm a woman in recovery from alcohol use disorder and mental health. I work as a certified peer recovery specialist at Norwalk Hospital, and I am a volunteer at Connecticut Community for Addiction Recovery in Bridgeport. I also co-chair the Catchment Area Council Area 1 and 2, 3 and 4, and co-chair the Billable Peer Support Group. I want to thank you for the opportunity to let me testify on House Bill number 6588. I'm testifying in support of Section 5 of HB 6588, which would establish a statewide task force to study insurance reimbursement for peer services. Establishing the task force would elevate and formalize the discussion at a state level and make officially recognized recommendations ahead of the next session. In Connecticut, if we are to increase pathways to the peer workforce and improve upon recovery outcomes, we must make certified peer recovery specialists reimbursable. Peer support services are an evidence-based practice and Medicaid reimbursable in over 41 states for certified peers. The opposite of addiction is not sobriety, but connection. And my first CPRS connected with me in many ways no one else could. He treated me like a human being. He was empathetic, resourceful, and even my cheerleader when I wasn't cheering. This clearly demonstrates the benefits of lived experience. He inspired me to pay it forward. I went on to get my CCAR Recovery Coach Professional designation and my CPR state certification through the Connecticut Certification Board, which follows specific standards for responsibility, validity, and legal defensibility to protect the population we serve. Bottom line, peer support offers opportunity to reclaim a life of self-defined purpose. I myself work on the community care team of Greater Norwalk. I'm able to coordinate care with numerous community and municipal providers and help break down barriers and overcome setbacks experienced by the population I serve. I'm humbly asking for you to please support HB 6588 and help Connecticut take critical steps towards improving our system of care through essential peer support services. I'm open to any and all questions and respectfully, and thank you for your time today.
Thank you. Representative Dathan.
Thank you very much, Madam Chair. And thank you, Nicole, so much for coming to speak to us this evening. I know you've probably been waiting to speak to us all day, thinking you had a number 41, thinking you might be mid-afternoon, and here we are after 7 o'clock, and really appreciate that. And thank you for sharing your experiences. You know, one of my concerns about putting this bill forward was creating a task force, and sometimes things can get lost in the legislative process, and things might not happen. Do you have any support why you think, you know, a task force is the right way to go here, and how we can make sure that things don't get lost in appointments and kind of the admin that we have to do here to create a task force? Do you have any input on that?
Absolutely. The Billable Peer Support Group that I co-chair has all the relevant stakeholders coming to the table already, and we're more than interested in the committee. Would like me to provide names, I can.
I might reach out to you. I really appreciate it. And my second question really is about accessibility. I asked this to somebody else earlier, but because you represent a different part of the state and different, wanted to ask the same question to you. Based on your experience here in Norwalk or in Bridgeport or other areas, do you think this is something that people are going to be able to access and reach out and get? And do you have any advice for how we can make that more accessible?
Well, I think if it becomes billable, absolutely. Because, you know, as far as for me working at the hospital, you can only assess my services if you come in more than 6 or more times in 6 months, or if you're connected to a community care team provider. But if you're not on probation or you don't live at the shelter, you know what I mean? Or if you're not connected with one of those providers, I will not see you. Or if you come in 5 times, you come on my radar, but I'm not allowed to engage until the 6th time. So I think it would be an absolute, for me, it's a must. I mean, I have 2, you know, recovery coaches myself, along with a therapist, a sponsor. It definitely takes a village, you know, to be able to sustain long-term recovery.
Absolutely, absolutely. Well, thank you so much for your testimony and hanging in there. And thank you, Madam Chair, for letting me speak.
Nicole, thanks for coming on and sharing your story. Next up, we have Susan Halpin, followed by Mark Schaefer.
Good evening, everyone. It's lovely to see you all. Thanks for sticking it out with all of us. My name is Susan Halpin, and I'm here today on behalf of the Connecticut Association of Health Plans. There's a lot of benefits to going first, and there's a lot of benefits to going last. I would say that I want to affiliate my remarks with those of several people that came before me. I was able to most of the testimony today, but not all of it. But I was able to catch Wyatt Bosworth's testimony earlier today. And that leads me into my testimony on HB 6447, which, you know, has a lot of components that we support, as do, you know, other bills that are before the committee this session. 6447 highlights some of the most important work that needs to be done on health insurance reform. And you know, it establishes a meaningful framework for some of those conversations to be done under the Office of Health Strategy. And it also begins the hard work of looking at healthcare costs through the sections on the pharmacy and pharmaceutical pricing. That could be expanded even further than it is today, but that is in essence where we see the real need for conversation. Premiums, as many people have already reflected on today, are really just a mirror or a reflective of what the underlying cost of care is, whether that's pharmaceutical pricing, whether that's you know, hospital care, whether that's specialty services, you know, or co-pays and cost sharing, and all of that kind of goes together. And that's what Executive Order number 5 begins to look at. And that has been a very positive executive order, and we have participated on behalf of the carriers gladly in a lot of those conversations, and think that this legislation, as does 1006, really complements that executive order, and we look forward to working with folks on those sections. Regrettably, on this bill, we have to oppose the $50 million assessment for the reasons that have been stated by others very eloquently that came before me. Really, it just, you know, as I think Wyatt said, it creates a situation where we're robbing Peter to pay Paul. And the carriers are already subject to a significant amount of taxes and assessments. I mean, if you look at the bottom of my testimony, which I'm not sure whether you've had the chance to do, you know, we're already subject to a 1.5% premium tax. We are paying over $120 million in assessments today. We fund everything from the Department of Insurance to the Office of Health Strategy to the Office of Healthcare Advocate. We fund positions at OPM, at DDS, at DMIS, at DPH.
Ms. Halpin, you've reached your 3-minute mark.
Oh my gosh, already? I thought I was just getting started. Okay. So in that instance, we've hit the breaking point in terms of assessments. And just really quickly on that issue, I think one thing I want to correct for the record, there's been a lot of talk about the HIT tax that was removed, and that this is just going in place of that. That HIT tax was repealed at the federal level, and it is out of the rates that insurers have on the market today. So if there is any new assessment passed, it will be added into the rates. So there will be a direct increase as a result. So I'll leave it with that. And with one, if you'll indulge me one more second, just to talk about the prior authorization bill. When I first started in the business, one of my earliest tasks was to participate in a working group around clean claims. And there are a few people around still that remember those summer sessions over at the Department of Insurance where we walked through various aspects of a claim form, a HCFA 1500 and an ICD 910 or something like that. Mark can correct me afterwards if I got the terminology wrong, but we went through a painstaking process. It seems to me that the prior auth stuff lends itself to that kind of conversation, and we would welcome the opportunity to engage in that conversation. So I will end with that.
Yeah, I was hoping you could talk more about the prior authorization. So I just real quick, I mean, you had basically left it as in you're willing to have that discussion, but just comment on, we heard from a lot of people from the hospital systems, in particular Bristol Hospital. I don't know if you want to share your side of it, but we are hearing things like 7 to 10 days to receive authorizations, you know, people waiting unnecessarily in the ED and taking up beds, using fax machines and things like that to communicate. I'd just like to hear your side on that.
Sure. And I think it's probably, you know, a number of factors, and I'm sure there is fault on our side as well. And that's what argues, you know, for a sit down conversation. Whenever we enter into one of these types of concerns, the first thing we always want to say is, let's sit down and look at the data and look at where the issues are and what they are, where they're originating from, right? And then tackle it from there up. We have had some conversations with various hospitals over this time. This past year has been enormously trying for everyone. There were some processes in place that, as in everything else, did not lend themselves to a pandemic. The carriers waived for a long period of time prior auth requirements around transfers to post-acute care. So that was waived. I imagine, you know, as we reach the end of this this crisis stage, I guess, if you will, some of those are going to be eased. But those are conversations I think that we can have, you know, and, you know, I know Mark is going to go after me. I'm sure he's going to talk about this, but, you know, is it unique to Bristol Hospital? Is there something, you know, that's unique to their portfolio of patients that is driving the issue? those are the kinds of things that we want to look at and want to, dive down on and have those conversations. Prior auth is an incredibly important part of the process. I did hear a statement earlier that, Medicaid does it electronically. Medicaid also pays substantially lower rates than private carriers do. And I think you have to look at the full picture when you're looking at prior auth to make sure that the appropriate level of care is being provided. I shared some statistics on my testimony about the amount of unnecessary care that is delivered in this country. And that is, again, not to say that we are correct 100% of the time. I am sure that we are not. I've gotten personally involved in cases where we've needed to, to engage. But having said that, I think there's a lot of complex, very complicated issues contained in the bill. And there's a lot of very, very tight timeframes in the bill. And I worry that there would be enormous unintended consequences around those. There is also, just to add one more thing, there are provisions around Medicare requirements that the state doesn't necessarily have authority over. So, that's another piece of the complexity that we'd need to work through and look at.
All right, and my last question is, just could you respond to Aetna Ambulance's testimony that said they're waiting for reimbursements that go back, to June and July? Like, any feedback on that and why they're still not being paid for services going back that far?
When I heard that testimony, I reached out to my carriers to ask the same question, and if there are what we can do to facilitate that, if it's accurate, and I'm awaiting that information. So I will get back to you on that.
Yeah, so thank you. I think, thank you for reaching out. I'd love to get some feedback on that. Great, Representative Meskers.
So first, Susan, you and I don't see eye to eye, and we have different views. But I think your carrier should know how awfully, incredibly well they're represented and what a good job you do in the process, right? And the level of information. So I guess in tonight, I will challenge you a little bit about the assessment, only in and of the extent, and I'm sure Senator Huang will catch me on this, but if we're down around 80% on the MLR, because no one has been able to get to a hospital or claim a procedure over the next year or two, even if the demand goes up, we're assuming on a smoothing basis, either there'll be refunds to the policyholders or potentially an assessment assessed from the state. So it's not a free lunch, but I wouldn't suggest that our rates have to go up tomorrow, given the fact that you're probably at an MLR of about 80% right now. So I want all of us to understand that we're not, Tony will say it's not a free lunch and I'm taking someone's refund, but I would say that there's probably profits in the system so far. But I want you to bring back to the carriers one of the issues that you and I have spoken about, which is that the MLR model of 15% means that you guys make money. If the bill is $1, you make 15 cents. If the bill is $2, you make 30 cents. So running more water through the hose gets you a higher payout, gross. So we're working in a system with a disincentive for the insurance industry to save money in the allocation of our healthcare dollars and not be able to keep a larger share. Because if my premium is $2 today, you keep 30 cents roughly, or the MLR is 30. And if my premium is $1, you get 15 cents. So there's a perverse incentive not to see the bill shrink. So we have to think about, in the event we become more effective in managing our healthcare system, how the insurance system benefits on their premium collection for the savings they might bring from the system. Because on the other side of the equation, I've said it 3 times tonight, if a premium's at $25,000 this year, and it's going to $50,000 in 7 years, the CBIA is going to turn against the insurance industry and the pharmaceutical and the healthcare industry and all of us will turn against all of you because we can't afford to spend $50,000 for a healthcare premium. So we have to figure out how we work together collaboratively, because if we go that route, ultimately we go to a public option, which is either good or bad, and you end up with an insurance industry that is the supplemental insurance policy that you'd get in the UK, with a national health care and supplemental policies for a concierge service. So what I want to see us work on is how do we protect the private sector industry by getting value per dollar. And that's, I think, the first attack with the governor's plan is on the attacks on the pharmaceuticals, is beginning to look at how do we control pharmaceutical costs. So I'm looking at that. The next place is I want to know why my nonprofit hospitals are grossing up and the practices that they're running and the treatments are going through the roof. So we're going to need the insurance industry to basically pick their battles and help us figure out what the most constructive way to run the industry, or the constructive way to administer healthcare to really drive down costs. Because, frankly, if we're going up 7% a year, if when I was in Catholic grammar school, I'd get a D-. So if my insurance company is supposed to be driving down my costs, they're going to get a D-. It's not their fault, but who has a better insight? Fox, Penthouse, Process, the insurance industry. So I would love to work collaboratively with you guys, figure out where the oversight needs to be and where we can do this better. So, and I appreciate all of your feedback. It's been nothing but insightful every time you've spoken in front of us. Thank you.
And likewise, Representative Meskers, I've appreciated the challenges that you've put before me time and again. You always lead the conversation in important ways, and I appreciate the back and forth that you and I have had. I think a couple things to respond, because I actually have thought about your question and am actually bringing it back to some of our executive team. But the MLR, first of all, as it stands today, I understand your point, but we do issue those rebates today if we're in a fully insured plan and the MLR, goes below those thresholds, the 80 and 85%. I guess I would also add that in a fully insured competitive market that we have, that is the check and balance to some extent to your issue that you raise about, you're going to get 30% more or whatever, 15 or 20% more if out of $2 than $1, right? We hit a breaking point at some point. We're hitting that right now. I mean, we're reaching the tolerance level of our consumers to pay for our product. And that is what is causing, all of the consternation that is landing on your desks at the Capitol, right? So I think, your point is really well taken. And I think Representative Nuccio, noted a couple of plans that have come onto the market just recently. I don't think that, the carriers are sitting on their hands. I think they are putting competitive, innovative products out there in the market. I think the other piece of this that you have to consider is the self-insured side, right? In those instances, you've got about 70% of the market that's self-insured today. Those bank accounts are the employers. We're the administrators in that sense. So, an Anthem, a Cigna, an Aetna, et cetera, they are reaching into that bank account to pay the claims. So in that instance, those dollars are directly the employer's dollars. We're not taking the risk in that. So their tolerance too, I think they hold us to MLRs themselves, right? It's not the same MLR as what you see there, but they're looking at.
But they must be reaching the same breaking point.
Yes, exactly. And that's why we are, where we are today. But, the other reason that those MLRs are at 80 and 85% is because there are going to be years when we go above those, right? We're going to go to when we're going to go to 90, we're going to go to 95. As we start to creep up, somebody's going, what the heck is going on, right? We didn't price our product well. We have our own kind of reinsurance product, mechanisms out there, but that's not a healthy plan. when you get up to that level. And that's what you see in the partnership plan, because at some point your premiums are not covering your claims, and that's when you hit insolvency.
Yeah,
So I
no,
think
but Susan, you're on the wrong road there. It's not a criticism. It's not that I have any issue with the MLR, but the incentive is to run more water through the process to get
and
a
I guess I would
larger
go for that
income,
one. I would go to the competitive marketplace and the tipping point that I think we're at today.
which is where I'm like, I would rather see your MLR get reduced to 80 when you turn around and say, it's not $2 for my premium, it's $1.
Right.
So that the
Value-based.
incentive is reversed, that when you can save me money, you keep a larger share of it.
Right.
So there's an incentive to drive the prices down.
Right.
That's
Right.
the issue.
Understood. And we'd look forward to working with you on that kind of proposal.
Senator Wong.
Thank you, Madam Chair. It's actually kind of fun to follow Representative Mesker, and he actually promoted me to be a House member. Susan, thank you for your time. So look, and I agree with, I'm tending to agree with Representative Mesker a lot, just for the record on this, is the fact that if health insurance rises to 50,000 per year, we have all failed in our job. Absolutely. And I think we're all united in trying to find solutions that contain cost and in fact, possibly lower it. So I don't have a copy of your testimony. I don't see it, but I didn't hear you mention the fact that what would you, through your plans and your insurers, make some suggestion in regards to the prescription drug cost containment? That is a big part of the governor's cost consideration. And it is indeed one of the big cost explosions because of innovation or the cost of innovation, as you've heard from our pharmaceutical and biotech companies. What are your thoughts for your members and efforts that you've made in regards to prescription cost containment?
And you're raising really important points, and I welcome the opportunity to respond to them. First, with respect to the governor's program, it is something that we are generally supportive of. Want to make sure that that there aren't unintended consequences in there, but absolutely, that's where the focus needs to be on those underlying healthcare costs. Second, and I say this a lot, and it is not the soundbite. And it can be painful conversations at times, but the tools that the health plans have in their toolbox need to remain. And those are things that you're hearing on the other side of the equation, which give us leverage against the pharmaceutical companies, which are around formularies, which is around, tiering and step therapy, trying to make sure that it's the right drug at the right time, at the right place, right? That the incentives are not aligned towards the highest cost drugs, but instead the most effective or quality level drug at the less expensive levels. Not that there shouldn't be protections in the statute for that. The appeals processes, the direct overrides that are in there. There are all kinds of consumer protections in there. But at the end of the day, if we don't have those very important tools to manage the costs that give us the leverage over the pharmaceutical companies in those conversations, then we will lose the battle even more.
Yeah, and I appreciate that. And you pose a very interesting question, is the fact that the formularies and the toolboxes that you have. I would dare say that is a big part of the reason why, quote, the bracket of health insurance companies aren't on a lot of people's holiday list. And it's very easy to not like you because you have to say no. But I hope that you're basing it on a actuarial analysis based upon hundreds of thousands of case analysis. You've got the experience rating. Connecticut proudly calls itself the insurance capital of the world, but it is because we have insurance companies that have a length of record and actuarial analysis and risk management. It is why we're in a business that is able to succeed. And I think the second part of it is you don't always articulate that from a point of, this is why. You say we can't do it. but you have to report all of your information and evaluations and data points to the Department of Insurance. You, by every contract that you have and every transaction that you undertake, you are an open book from a standpoint of transparency, auditing, and regulation. Would that be a fair statement?
Yes, it is. And I go, a couple points further. One is, and it speaks to the benchmarking and the transparency pieces that are in part of the other bills. We give data to something called the All Payer Claims Database that Connecticut was late to enact, but has now it's reached a maturity level that allows it to be used for public policy. So it has all of the claims, our healthcare claims. So you can look at and segment out on a blinded basis, what are the costs in the system? What are the drivers in the system? So that is all, that is something that is always, best when you're making policy decisions, is let the data drive the policy, right? The second piece to your, and I appreciate your sentiments around the actuarial analysis and our ability around those. I think what people don't often understand is that our protocols are evidence-based criteria, right? We all talk about evidence-based medicine being that should be the driver, on what care is delivered, right? The criteria that our carriers use are developed by all the professional societies. Those are the way in which medical necessity is determined when people go for their prior auth is by that criteria. So, when you talk about evidence-based medicine, everybody's like, yes, 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 to your point. But when you talk about it as a prior authorization and questioning whether that's the right drug at this time, and I appreciate the gentleman who spoke earlier about saying, there is no generic drug for what he's suffering. Absolutely. And those things need to be considered. But evidence-based criteria is what the health plans are using when they're making these types of decisions. So thank you for the opportunity.
Well, absolutely. And it's kind of interesting. Ellen Andrews earlier said, I don't always agree with the health plans, but I can be clear on this, that you're both in agreement that you think the all payer system is one of the gems of transparency and comparative cost analysis that we have in the state of Connecticut that a lot of people don't know about. And I hope they're able to utilize it in their cost comparison. So, but I appreciate your time. And I think the key is obviously our insurance companies have a way to go. And obviously it is a sensitivity and a consumer responsiveness, but you've been in this business and you have a track record and you can't overpromise because you're regulated. And you have to substantiate this to the insurance department. And that's important because you're a proven entity, whether we like it or not. And I think we should collaborate and work with entities that are an integral part of the Connecticut business fabric to succeed and contain cost. We all have the same goals. I think the other important point to leave on is I'd be remiss to not acknowledge the hundreds of emails I've gotten from insurance company employees and people whose livelihood and connected businesses are impacted by many of the insurance businesses, because it is not an amorphous, unpleasant entity. It is an employer that puts a lot of paychecks in people's mailboxes and ultimately pays mortgage and support people in these very difficult times. You can't discount that. And I appreciate, at least sometimes, that you present a human element in that that sometimes the insurance companies don't do. So I appreciate your time, and I know the hour's long, but thank you, Madam Chair, and I appreciate your time and the work that you provide as well.
Thank you, Senator. Thanks, Sue. Next, we have Mark Schaefer, followed by Parisa Charmichi Goodwin.
So good evening. Senator Lesser and Representative Wood, and thank you for adding me back to the docket after I ducked out to get my first COVID shot. And I just want to give a shout out to the New Haven Health Department, who's kind enough to loan me an exam room from which to offer this testimony. So I'm here to testify as I'm here to on behalf of the Connecticut Hospital Association to testify on House Bill 6586 concerning prior authorizations and healthcare provider contracts. CHA strongly supports this bill. As you know from the many folks who've testified thus far in recent years, a number of health plans have begun abusing the prior authorization process. And even though we recognize that that process is really in place to help ensure patients receive the right care, we believe that the way this is used today often negatively impacts patient care and results in significant added costs and burden to hospitals and other healthcare providers throughout the state. This isn't a new thing in Connecticut. Aggressive authorization practices were common in the late 90s, shortly after the introduction of capitated Medicaid managed care. Private health insurers then, when they were administering the Medicaid benefit, used aggressive prior authorization focused on inpatient care especially, and it resulted in significant industry penalties, including loss of license. Things did improve for a time, but we're finding now that aggressive prior authorization is, again, a very, very prominent fixture on the healthcare scene and an ever-present burden that hospitals have to cope with. And I think part of the reason is it's not just employer-sponsored coverage anymore. Many Medicare beneficiaries are getting their Medicare benefits managed by the private health plans, which are using the same prior authorization, basically methods to manage the Medicare benefits in a way that CMS doesn't do for the Medicare fee-for-service program. There are a variety of ways that today's prior authorization practices are unnecessarily burdensome and jeopardizing patient care. There's the variation across health plans with respect to authorization submission process that creates inefficiencies that are unnecessary and costly. Prior authorizations applied to services where there's no evidence of inappropriate practice and care standards are well established. Health plans typically have different requirements for the information a provider must include in a prior authorization request for a particular covered benefit, and health plans often change these requirements unilaterally throughout a contract term. Health plans also delay prior authorization decisions, returning requests multiple times, claiming insufficient information. Delays are most common when patients come in after hours or on weekends, when most health plans don't have staff available for reviews.
3 minutes, if you could just summarize, please.
Sure. I think that a couple of sort of final points. One is, if this was restricted to the sort of borderline medical necessity cases, that might be okay, but an OIG report found that for Medicare Advantage, 75% of the denials were overturned, which suggests that the tool is being overutilized and extended to situations that shouldn't be in question. So it's the complexity of what exists today in the prior authorization world, how difficult it is to negotiate, how profoundly burdensome it is for the clinicians on the front lines, for the hospitals that have to develop the staff and infrastructure to manage it. And we believe that the bill proposes practical means by which a greater degree of harmonization, consistency, predictability, and efficiency can be introduced to the process so that it can work the way it was intended. Thanks so much for the opportunity to testify tonight.
Mark, thank you. I appreciate you sticking it out in the room there where you're getting your shot. So yes, I just want to make a comment that I hear, your concerns. I'm sure you were around when we were talking with Sue Halpin from the association plans, and I think there's a lot of work to be done here. So appreciate the testimony and your work on this. Any questions from the committee? Thank you, Mark. Next up, we have Parisa Termici Goodwin, followed by Gisela Pena.
Thank you, Representative Wood. My name is Parisa Termici Goodwin, and I am the Executive Director of the Connecticut Oral Health Initiative. We are a nonprofit oral health advocacy organization that advocates for increased access to quality, affordable oral health services for all Connecticut residents. I'm here to strongly support Senate Bill 1004, which will extend the period which a child can be on their family's dental and vision coverage up to age 26 if they need the coverage, being that they don't have it through their own employer or some other way. So the idea is that it would be an option to carry it on just as you can with your health insurance currently under Connecticut law and federal law. So I know I am almost your last for the evening, and I do want to be conscious of that, your patience and your time, and not repeat what Representative Gary Turco said about how this is something that is sensible, is good for Connecticut families really across the board, and makes sense to align it with the law for health coverage already. And also what Marian Mansky said, she's from the Hygiene Association, and I think she really outlined how this is important for oral health and also for your overall health. There's also some great information about what it does for just chronic diseases, for lowering your risk of preeclampsia and other poor maternal health outcomes, how it lowers your risk of heart disease, and how it helps manage diabetes. So that's good for your health, and it's also actually good financially. There's going to be savings on the health side, and there's going to be savings for your own kind of out-of-pocket expenses. So we can prevent a lot of harm and disease and save money. So it's all around a good, sensible thing to do. And I did want to note that there's over 50 pieces of testimony and support on the CGA website right now. A lot of them are from people in their 20s, a lot of college students. I know I've spoken to some students in the past couple of weeks who've let me know that they found out that they didn't have their dental insurance anymore when they showed up at the dentist. And then some of them had a bill or had to decide if they were going to have the cleaning or not. So it's something that is a confusing surprise, I think, to a lot of families to find out that the dental coverage typically is not carried over unless the employer sets that up ahead of time. So I'm happy to answer any questions, but I want to keep it short and sweet. And I do encourage you to look at some of that testimony if you haven't had a chance to already, from people that have been impacted themselves, from dentists, hygienists, a lot of dental students and dental hygiene students. So I think it's a lovely thing to support, and I'm happy to answer any questions. Thank you so much for your time.
Thank you, Parisa. And I give you a lot of credit for staying on from Gary Turco and listening to all the testimony today.
Oh, yeah.
Thank
you. It was a pleasure. It was a lovely day. So, and thank you all for your patience.
Some great, discussions for all of us out there that love insurance. All right. Any questions from the committee? Great. Thank you, Parisa.
Thank you all. Have a good night. You're almost done.
Next up, we have Gisela Penna, followed by Patrick Charmel.
I don't think either of them are here.
Is there anyone else waiting to speak?
I don't see anyone in the waiting room.
Okay, great. Well, thank you, Insurance and Real Estate Committee. Thank you, Diane, Zoe, and Logan for getting us through this. And we'll see everyone on Thursday.
Thank you, Madam Chair, for a very good meeting. Appreciate it.
Thank you, Madam Chair.
Good night.
Safe drive.
Thank you very